So day 2 is again with the blessings of God we are beginning with Saraswati Vandana. Saraswati Vandana play करिए जल्दी से. चलो.
या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्म विचारसार परमां आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीमभयदां जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थिता वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्.
Good morning, everyone. It gives me immense pleasure to welcome you all to day 2 of this prestigious event. Yesterday was truly remarkable, filled with insightful sessions and thought-provoking discussion and inspiring interactions. As we move towards our first presentation, I request our speaker, Dr. Mohsin Aslam sir, to come and speak on the topic, impact of gut microbial manipulation in diabetes. I also request a chairperson, Dr. T.K. Saikia sir and Dr. Rajkumar Jain sir, to come and also please do introduce our speaker.
Good morning, Dr. Mohsin Aslam. He did his MD in internal medicine and lot of fellowships. He is a consultant physician and clinical scientist at Asian Institute of Gastroenterology, known as AIG Hyderabad. Lot of achievements are there, lot of awards are there. I request him to start his speech.
Yeah, thank you, sir. And I would like to thank Dr. Ashish Dengra, sir, to inviting me for this NDID. And this is my first visit to Jabalpur. So I'll be talking on impact of gut microbial manipulation in diabetes. So of late, we are more focusing on gut microbiome in inflammation and all the diseases. So next 10 minutes, we'll see how we can influence or improve our blood glycemic control by manipulating our gut microbiota, and what are the different ways by which we can manipulate our gut microbiota. So the hidden metabolic powerhouse within our digestive system lies an integrated ecosystem of microorganisms that profoundly influence our metabolic health and blood sugar regulation. So they are considered as one of the metabolic organ. Our gut hosts approximately 100 trillion microbes with a collective gene pool of 150 times larger than the human genome, forming a second brain. This microbiota profoundly influences digestion, immune function, metabolism, and it plays a crucial role in glucose homeostasis. And even recent studies have shown that gut microbiota play a crucial role in insulin sensitivity and blood sugar regulation. So what is the gut diabetes connection? So the gut bacteria directly affect insulin processing and may contribute to type 2 diabetes development and control. Our diet is a primary factor influencing the gut microbiota, composition and metabolic health. So probiotics, prebiotics and fecal transplantation offer promising treatment pathways. So how the gut microbiome influences our glycemic control? It is by 4 mechanisms. One is production of short chain fatty acids like butyrate and propionate, which improves the insulin sensitivity and gut barrier function. Again, they help in microbes modify bile acids, which regulate glucose metabolism and energy expenditure. Gut microbiome also influence our appetite and insulin secretion. And healthy microbes reduce the inflammation and disrupts glucose processing. So the short chain fatty acids are produced when beneficial bacteria ferment dietary fibers in the colon. So the short chain fatty acids like acetate, propionate and butyrate are beneficial for insulin regulation. So when the balance goes wrong, what happens? It results in dysbiosis, which can trigger a cascade of metabolic problems leading to prediabetes and diabetes mellitus. So this dysbiosis results in reduced diversity, that is fewer beneficial bacteria, overgrowth of harmful bacteria, which results in barrier breakdown and increased leakage of bacterial toxins into bloodstream, which results in systemic inflammation. So which are the heroes and what are the villains in our gut? So the protective bacteria like bifidobacterium, lactobacillus, roseburia and faecalibacteria help to prevent diabetes mellitus. And in diabetes patients, there is a decreased levels of this beneficial bacteria. And Prevotella, which has a dual effect, that means it increases the inflammation but still are known to reduce the blood sugar levels. If you see a profile of a stool profile or gut microbiome profile of a diabetic patient, there is a 2 times increased levels of lactobacillus, increased formicatus ratio, and also decreased bacteroides levels. So gut microbiota results in decreased indole, increased short chain fatty acids and decreased microbial anti-inflammatory molecules. So this results in decrease in GLP-1, protein YY and results in impaired glycemic control. Or decrease in the indole results in increased food intake by hypothalamus, increasing the development of type 2 diabetes. Decreased butyrate results in increased intestinal permeability, increased lipopolysaccharide production, increased inflammation resulting in insulin resistance and development of type 2 diabetes. So scientific breakthrough, that is microbiome activity predicts glycemic response. So recent study like landmark research study has shown that gut microbiome activity when assessed to advanced molecular activity analysis can predict individual post-pandemic glycemic response, highlighting the need of personalized microbiome derived approaches to blood sugar control. So now therapeutic revolution. So by understanding the mechanism of how gut microbiome opens the doors to innovative treatments of metabolic disorders and prevention of diabetes and better diabetic control. So what are the strategies? Experiment and clinical studies demonstrated that targeting the gut microbiome is effective for preventing and managing diabetes. Lifestyle changes like regular exercise and weight management are crucial for improving the metabolic health and restoring the gut microbiota. So the 4 pillars of microbiome therapy are dietary interventions, prebiotics, probiotics, and fecal transplantation. So dietary strategies are like foods that heal, that is high fiber vegetable and fruits, fermented fruits like yogurt and kefir, whole grains and legumes, prebiotic rich fruits like garlic and onions. And foods that should be avoided are high fat, high sugar processed foods, artificial sweeteners, excessive red meat, and ultra processed snacks. So one size does not fit all. That means individual microbiome profile creates dramatically different glycemic response to identical foods, revolutionizing our understanding for personalized nutrition. That means if you see 2 different patients, if you give the same meal and if you measure the postprandial glucose levels, they spike differently. This is because of different response to microbial profile. So tailoring diets based on microbiome profiles. So beyond traditional approaches, that is traditional glycemic index approach improves, insufficient individuals respond dramatically different to identical foods. So integrating microbiome data improves prediction of from glycemic peaks from 34% to 42%, and personalized diets considering both microbiome and genetics optimize postprandial blood glucose effectively. So ancient wisdom meets modern science, that is traditional diets and gut health. So consuming fiber-rich diets and our ancient Ayurvedic principle emphasizes that digestive balance and metabolic harmony remarkably aligned with modern microbiome sciences, and fermented foods like idli, dosa and buttermilk promote beneficial bacteria and are directly linked to glycemic variability. So again, increased fiber, reduce harmful foods, and choose plant-based diet for improving the gut health and better diabetic control. So fiber, what is the role of fiber? It feeds gut microbiomes, dramatically increases the short-chain fatty acids, and improves insulin sensitivity throughout the body. It has a prebiotic action, and our ancient grains and legumes commonly found in Indian diets naturally support microbiome diversity. So what are the benefits of Mediterranean diet? It has higher bacterides to fumigatus ratio, which is good for diabetic control, increased short-chain fatty acids, and high protella abundance. Plant-based diet, it increases the bacteride abundance, decreases the fumigatus, and improves insulin resistance and glycemic control. So prebiotics, that is feeding the good bacteria, it increases the inulin increases the bifidobacterium and faecalibacterium genera while reducing the bacteroids. Fructooligosaccharides, they are broken down into beneficial short-chain fatty acids by microbiomes, and galacto-oligosaccharides improve glucose homeostasis through microbiota modulation. Inulin supplement has shown that 8 weeks there was a significant reduction in fasting glucose in type 2 diabetes subjects, and increased fecal butyrate levels correlate with fecal bacterium changes. So probiotics like lactobacillus, this improves insulin sensitivity and reduces inflammatory markers in diabetic patients. Bifidobacterium strengthens the gut barrier function and enhances glucose tolerance. Akkermansia protects against metabolic dysfunction and supports healthy weight management. Symbiotics, they are the power combination. They are the dietary supplements combining both pro and prebiotics. These multi-strength capsules with insulin significantly HOMA IR in diabetic hemodialysis patients in one of the studies. Now, we are moving towards washed microbiome transplantation. That is, in unstable diabetic patient, it has shown to significantly reduce glycemic variability and decrease insulin requirements dramatically. So, washed microbiome transplantation treatment increased gut microbiome diversity and enhanced beneficial metabolic pathways, particularly butyrate production. So changes in the fecal serum metabolites directly correlated with improved glucose stability and metabolic functions. I think one more minute. Again, fecal microbiome transplantation, it is either through endoscopy or through colonoscopy or giving oral capsules. It aims to restore health bacteria balance in diabetic patients. Again, this has shown to improve insulin resistance in diabetic patients at 12 weeks and improvement in HbA1c. The future is microbial. Okay. There is strong evidence that research supporting gut microbiome has a novel therapeutic target for diabetic resistance, and combining our wisdom of our ancient ancestors with precision of modern science offers n number of opportunities to transform metabolic health worldwide. So to summarize, gut microbiome activity is a power determinant of glycemic variability, opening new therapeutic pathways. Personalized approaches integrating microbiome data can completely revolutionize diabetes care and management. Traditional dietary wisdom provides valuable foundation for modern metabolic treatments, strategies and interventions for diabetic control. And together, science and traditional can transform lives and help curb the global diabetes epidemic effectively. So the future of metabolic health lies within us in the ancient wisdom of our gut. Thank you.
Nice presentation. Any question from audience?
Thank you, sir. I request our chairperson to felicitate our speaker on the stage. I also request our speaker to give memento to our chairperson. A huge round of applause, please. A huge round of applause, please. For our next session, I request Dr. Farista sir from Hyderabad to come up and speak on the topic from grains to glucose control, the science of mellitus and diabetes management. I would also like to call our chairperson, Dr. Neeraj Baderia sir and Dr. Umesh Pratap sir.
So this is Dr. S.K. Gautam sir's oration, and late Dr. S.K. Gautam sir was a renowned physician and academician, and he was a very kind-hearted doctor, and with the juniors also he was very much like the family, and he never showed any ego that I am so senior, and he was very down to earth. So Dr. S.K. Gautam oration is taken by Professor Dr. Faraj Farista from Hyderabad. He is a very good friend of mine, and over to you, Faraj.
Thank you Ashish for bestowing me with this oration. I think this is 4th year that I am here in Jabalpur, and next year I'll become an undergraduate from Jabalpur if that happens to be. I said this is 4th year, next year I'll finish my undergraduation from Jabalpur. So it gives me an immense pleasure to take this oration today. I think today what we are going to talk about is our ancient things which हमने सब खाया है, हमने सब feel किया है. How many of us eat millets? So jawar, ragi, bajra. Can I see people raising their hands? How many of us? Professor, what is predominant in north? Of course. What is predominant in north? आपके पास क्या चलता है millets में?
Millets में it is going on good because sensitization is being taken place for last 2 years, and people are adopting millets in growing number.
Right. Thank
Definitely.
you. So yeah. So my respected chairpersons, which millets is more consumed in Jabalpur?
मैं तो रीवा से हूँ.
आपके पास जवार, रागी, बाजरा कुछ चलता है?
हमारे यहाँ ज्वार चलता है सर.
ज्वार चलता
जी.
है. So what today I'm going to focus about is our ancient, what we have forgotten, and then in the last 2 years, this is the first time that we have done a trial with Government of India, with the Millet Research Institute, which recipes are good for diabetic patient, because if you see, some of the millets have high glycemic index, but the glycemic load is less. So today, when I'm going to finish, I'm going to present to you hardcore data, half of it because still it needs to get published. Since this was oration part of the data, today I'm going to present. And then this data is going to get published next month by Government of India. So let's understand millets. I think we all know, if you go back in history, you will be amazed. So you will see it is right from 4500 BC. From the first time when mankind started eating food, started making food from recipes, you will see it goes back, the history goes back to 4500 BC, which is very, very rich. The Indian Sanskrit text, you will see Yajurveda makes the mention of few of these millets. So even in our Sanskrit, in our Vedics also, the mention of millets is already there. And we always say that probably we as Indians have that history, we have it. But here you will see it is consumed as a staple cereals from prehistoric times in Asia, Africa, and Europe. So it is not only India, you will see other countries also where it was being consumed. Proso millet is one of the oldest human foods believed to be the domesticated cereal. So you will see first foods which were had by mankind, proso millet was the first food, cultivated food started by the... Then what happened? If it had so much amount of history, it had so much amount of rich culture, we all know what happened. Then there came industrialization, there was change in dietary habits, then came wheat, then came rice. That is where you will see, here there is a very interesting point which I want to highlight. Here you will see the annual per capita consumption of millets in India has nosedived from 30 kgs in 1960 to 3.9 kgs in 2022. So now this tells you what has happened and why the rates of NCDs have gone up so very high. Because see, we all felt that India is a carb-eating nation, and then START study has already showed that we always felt, okay, we are from South India, so we have more carbs. START study has now clearly said, all the zones, north, east, west, south, all the zones consume equal amount of carbs. So carb consumption is equal in entire part of India. So this figure should tell you why, when, what has happened. So millets is losing its glory, because you will see what has happened now. What we used to take it as our rich food, a rich culture, now we feel that it is for our cattle. Now if you see in most of the foods or any of the parties or any of the other things, if you see, It is considered to be a coarse grain which we do not like to eat, which probably we are either giving it at the fodder food. What are the classifications? So जब हम इतनी सारी बात करते हैं millets के बारे में, so these are common foods eaten across India. So based on the size, it is divided into major millets and minor millets. So if you will see the major millets, sorghum, that is commonly called jawar, and pearl millet, bajra. So based on the size, these are two, jawar and bajra are the major millets. And the rest of the things you will see, there are different names from different cities or parts of India, which are the minor millets. We talked so much, of course, probably I'm not sure if we have more of this quinoas and all in this part of the country, but in Hyderabad, probably in Bangalore, in other metro cities, we are more towards these smart foods, superfoods. So you will see millet itself is a superfood. It is very rich in iron, calcium, folic acid. It is high in fiber. So these are the foods which already have so much amount of nutrition. They are super grains, eco-friendly. Way back, you will see in British era, Coleman was the first, I would say, a scientist who was working on the Mysore state when he was deployed there on millets. So this is the first kind of time or the first time where a study on millets have been done along with Government of India, along with the Indian Institute of Millet Research. So this study was divided into two parts. Part A was clinical study for in vivo glycemic index. So to understand what is the glycemic index of different millet foods, out of that, which were good, that were selected and given for diabetic patients in the part B. So this is where it was done. So I was the co-investigator along with this. So then it was CTRI registered. So what were the inclusion criteria? You will see, we are talking about the part A, healthy non-diabetic males aged between 19 to 39 years, BMI of normal, and fasting blood sugars of less than 110. So these were typical healthy people whom the glycemic index of various millet foods was studied. Subjects arrived in fasting state, fasting blood glucose was taken. The reference food was asked to the patients to eat within 12 minutes. The glucose was tested at 15, 30, 45, 60, 90 and 120. So there were 6 times glucose readings were taken after the millet meal. So these were the foods which were taken. So you will see jawar roti. So we tried to take foods which are being consumed locally, which have been eaten daily in all the houses. So here you will see jawar roti, bajra flakes, pawa, kodo millet ugani, baniyad millet, tomato rice, this is more in our Telangana. Foxtail lemon rice, again a part of our meal, a little millet upma, proso millet roti and ragi ambali. I think this ragi ambali drink is also more common in north and in south as well. So this is very, very interesting. This is what was the result. So you will see the glycemic index. L is the low glycemic index food, M is the moderate, and H is the foods which had high glycemic index. So when we are talking so much about millets, now we have science, evidence-based. So you will see foxtail lemon rice, millet tomato rice, proso millet roti and little millet upma, they were falling in that low GI. Bajra was into the highest GI. So this tells us that when you're talking to your patient, when you're telling your patients, every millet is not similar. When you're talking to your patient, especially your diabetic patient, then probably you may not be that interested to give a bajra related whatever you want to advise. So that has the high glycemic index. So these, then after that, there was the part B which was done. This was typically in a diabetic patient who had a A1C between 7.5 to 10. Along with the standard of care, it was done. Here, they were divided into two arms. One was the standard arm where the patients were continued on the dietary advice. Second arm, the patient were added one meal replacement with the millets along with the standard arm. So one meal, either it is a largest meal in the lunch or in the dinner, which were replaced for the diabetic patients. This were a battery of tests which were done. So you will see, we not only tried to see the regular parameters, there were a lot of pleiotropic parameters which we studied. We studied the fasting insulin, the C-peptides, HSCRP, the HOMA-IR, insulin sensitivity, beta cell function, along with the other parameters or the other pleiotropic parameters. So these all were studied at the time of enrollment and after the 3 months of completion of the study. There was CGMS which was again deployed when starting of the study 1 week before the CGMS was deployed, and then 1 week before the end of the study, CGMS was again deployed for the same patients. Here you will see on the left hand side, on the right hand side, you will see many of these peaks. So if you will see the peaks here and then you compare the peaks there, whenever that meal replacement was done, the peaks have come down. So if you will see this, if you will see that, if you will compare the average also here, in these patients you will see it is around 355, that is around 231. So whenever that meal replacement was done, that peaks have come down and that has been shown with the CGMS. Again, a few patients similar pre, and then this is with the millet meal. One interesting thing, of course, when I presented this last month, somebody observed it very closely. They said, if you see the graph here, it is flat. Here it is peaking. How come millets, then here it is peaking? So definitely this tells us that it is very difficult when you do a food trial. Whatever we tell our patient, whatever we give it, they will never have it for 90 days similar. So that is where, when we also saw this CGMS, we went back, we asked the patient, they said yes. That day we had only one roti and some biryani. So that is where the peak happened. So that tells us that it is very difficult to do a food trial. That is where, if you will see, in so many years, there have never been done a food trials on millets, for years now. Here you will see the glycemic index and the glycemic load. So yes, some millets have high glycemic index, but you have to understand they are rich in fiber, but the glycemic load is very, very less. So for your diabetic patient, we look at foods which have less glycemic load because you do not want the peaks to happen. This is again a very, I would say, not an alarming, I will just take 2-3 minutes. So not an alarming results which have come, but you will see the control and the test arm, the difference. If you will see the control arm, the A1C reduction was 0.1%. The test arm, it was 1.1%. Now, you tell me, leaving sulfonylureas and insulin, most of these drugs give you an A1C of 0.6 to 0.9. Just with meal replacement of millets, you've got almost a reduction of 1%. So this is telling you how important diet it is and what diet your patients should take. And this is not fancy diets. That is what we all have to understand. These are foods which have come from history, which have come from culture, and everybody can afford it. It is not something like quinoa or something which is very, very fancy. Again, you will see the control arm and the test arm here. Only 1.3% of the patients achieved the A1C reduction, whereas in the, you will see test arm 12.3% achieved the A1C reduction. Again, that is also very raring, that how many percentage of the patients had a A1C reduction. So this is going to get published next month from Government of India. The pleiotropic benefits and that HSCRPs and all, we've got a very good result, but I could not get it here because it has to get published and then it will come out in the next conferences. But I just wanted all of you to know that how the GI have changed, how much is the A1C reduction, what percentage of patients have reached that. And then this clearly tells that all the millets are not same. Some millets have low GI, some millets have high GI. It is very important that for a diabetic patient, you select the right millet so that you do not get that glycemic load or that glycemic peak which happens. So these are the 4 foods. So if you want to take a picture, I think this will help you to a larger extent when you're treating your patients. Foxtail lemon rice, barnyard millet tomato rice, millet roti, proso, and little millet upma. So these are the 4 foods which had the lowest GI, which you can give it to your patients. It is not only good for your patient, it is good for the country. Climate resilience, it doesn't require water. There is less biodiversity which is required. It can be grown in any part of the country. And then yes, we have many millet related now fast foods and fancy foods also coming into the market because taste is where it has to be. If it doesn't touch your palate, then you can't take it. And then that is where probably along with the Indian Millet Research Institute, which is Center of Excellence in Hyderabad, we are working very closely and we are trying to develop new R&D products along with millets. So 2023 was the year of millets, which was declared by our Honorable Prime Minister. And then to conclude this, now we have foods, or we have our traditional food which helps us to fight this NCD battle. So it is high time to prevent, it is high time to take things in action so that we delay at least the burden of NCDs. So I would like to end it here on a quote from Mahatma Gandhi ji. It is health that is real wealth and not pieces of gold and silver. I think we all agree that even if we were not doctors, probably I have all health enthusiasts sitting and seeing here and giving their lovely smiles, that we all believe that health should be our priority. And then if I take it from Dr. Mohsin's gut also, I would say, if I ask you who is more richer, Ambani or Adani, what will be your answer? Ambani? Anil Ambani. I would say, sir, the person with the right gut microbiota is more rich than Anil Ambani and Adani. So thank you so much for inviting me. Exactly. So thank you so much again for inviting me to the lovely city of Jabalpur, and back to the organizers.
Thank you, sir, for such a nice presentation. Since this is your session, no more question from audience.
Thank you so much, sir, for this lovely session. I request our chairperson.
As it was the oration, so first, Faraz, you can read this.
Yeah. So I think this is in honor of Dr. S. Gautam, sir. He's done his MD General Medicine. He's from Medical College of Jabalpur, ex-Chief Medical Officer of MEEB, President of IMA State Branch from 1972 to 93. That is long time.
Long.
President IMA Jabalpur branch, founder member of API Jabalpur, President of API Jabalpur branch, having a lot of honorary credits to his API membership, Diabetic Association of India, Association of Chest Disease, Indian Red Cross Society, and various fellowships. So sir has been involved in philanthropy as well.
Yes, we should have a great round of applause for him and S.K. Gautam, sir. Now we will read the citation.
NDID is privileged to award NDID late Dr. S.K. Gautam Oration 2025 for year 2025 to Professor Dr. Faraz Farishta, Director of FS Endocrine and Diabetes Center, CEO Millets Panda Healthcare Private Limited, Professor MedCity Institute of Medical Sciences, ex-Investigator Council Chair for Indian Society of Clinical Research, and Course Director for Fellowship in Geriatric by IMA Academy of Medical Specialties, Telangana State, and Editorial Board Member of for International Journal of Advanced Medical and Clinical Therapeutics, and State Council Member of IMA Telangana State, and Governing Council Member of Telangana State RSSDI, Executive Committee Member of Indian Society of Hypertension, Telangana State. He is a recipient of Dr. Arastu Jar Jung Memorial Oration Award in NatCon Utsav 2024, recipient of Mehdi Nawaz Jung Award 2025 in Medicine by MNJ Hospital and Trust at IMA Hyderabad. He is recipient of Excellence Award in Field of Diabetes by Honorable Government of Telangana, Shri Jishu Dev Verma. Outstanding contribution as Eminent DNB Teacher Award by ANBAI, Fellow of American Association of Clinical Endocrinology, Fellow of American President of Diabetes Awareness Foundation, Member, Scientific Committee of IMA Hyderabad, Society of Hypertension, Telangana State Chapter Program, and Research Editorial Board Member of World Journal of Pharmaceutical, and member of British Thyroid Foundation, and member of ISCR, member of Arab Society of Pediatric Endocrinology and Diabetes.
Great round of applause for Dr. Faraz. Please come for the oration. Okay. Sorry. तालियां बजती रहे, तालियां. Clapping is a good exercise. ये ले लो. Moving on to the next talk.
I would like to call Dr. Nikhil Motiramani from Raipur to come up and speak on the topic Real Challenges, Real Solution with Inclisiran. I would also like to call a chairperson, Dr. Ramesh Bhargava sir, and Dr. Vikas Mishra sir, and Dr. Ashok Methwani sir to take a seat, and please do introduce our speaker.
We would like to welcome our next speaker, Dr. Nikhil Motiramani. He is a DM Cardiology from Jipmer Institute. He is a fellow of American College of Cardiology and many other fellowships. Currently, he is head of department in Moti Ramani Heart Institute, Raipur. He has over more than 20 international and national publications. He is a regular invited faculty in the top national and international conferences. We'd like to welcome.
Thank you, organizers, Jingyasa sir, and thank you, chairpersons. Today, I have been given a task to discuss more about LDL. In short, sometimes me and my friends used to call the full form of LDL as let's do it little. So let's figure out why there has been so much importance for this LDL. The reason we all know, and over the period of time, our patients more and more are getting the age from 40s to 30s. Now we all know that we are treating even all these events, ASCVD events, whether it be stroke or whether it be MIs, in years of 20s. So second decade is basically now the earliest era which we are noticing. So how does this LDL, its profile, help us in dealing, and why do we need newer molecules? And now this molecule inclisiran, we know that it has basically arisen and is going to take over of a period of time as soon as, because the most constraint in countries like India is a cost constraint. So I think that is taking behind the slow progress of molecules is one that factor. But if we leave that factor down, molecules like this are going to progress and take over the period of time very soon, because our patients also are not willing to take daily drugs. Atherosclerotic vascular disease, we all know that it is the deadly markers, and now this all parameters are coming from where? These are coming from all our lifestyle disorders, whether it be diabetic disorders, hypertensive disorders, and underlying cause of this major disorders is obesity. So 1 in 10 and more than 10 of deaths and MIs. So this is what the real world setting shows, and the real world data on achieving LDL goals, you can see how it is not being still achieved in the real world. So why do we actually need to control or get these numbers up? Because the more amount of LDL that we control it, that is where we are asking our metabolism to be controlled, and the more metabolic control helps us in making our arteries plaque free, and if we are plaque free, then only we can prevent the further events to be reduced. And the earlier the therapy is there, this poor LDL control will get into better control, and this plaque burden might not shift to higher plaque burden over the period of time. So that is why even if we talk about dyslipidemia, we talk about diabetes, we talk about hypertension, now rather than controlling the duration of control, the 24-hour control in diabetes and hypertension is taking place, and similarly in dyslipidemia, the more earlier control is being tried. So what are the challenges? So these are such case scenarios. So this is the guy who's 39 years old, his BMI is 26, so you can see at 39, the BMI is 26 means the lifestyle has not been proper. Diagnosed with diabetes, presented with NSTEMI, had a DES implantation in RCA, and medications that he is on is anti-diabetic therapy. The good point is now the anti-diabetic therapy has SGLT2 on board. Atorvastatin is 40, so he is on moderate to high intensity statin. HbA1c is well controlled, but let's see what's the LDL. So his HbA1c is controlled, but the LDL is still 154. So does this needs to be taken care of, or because of his diabetes control and with although moderate to high intensity statin, his load is okay? If we see the recommendations or if we see our events, patient already had an event. So if a patient already had an event, we know the patient is at risk of other events, whether it be in form of MI or it can be in form of other vascular events, whether it be peripheral arterial disease or whether it be ischemic cerebrovascular disease. So in such cases, we need to robustly bring down the LDL. Earlier it used to be said that 27 LDL is sufficient for our body metabolism. So those the studies have shown, but over the period of time, the researches that are being done, there have been papers which are even saying that even 5 of LDL is sufficient. So maybe over the period of coming time, because the researches are very much more in these cholesterol metabolic molecules, not just LDL, they are now working upon apolipo-A, apolipo-B, so we'll be able to see the numbers being drastically reduced. So how do we do that? Patients are already on moderate to high intensity statins. The next things that we know that we can use or we should use is ezetimibe followed by bempedoic acid. But why do we need inclisiran or siRNA? The reason is that if a person already has an event, it should be taken note of that one event progresses or can rapidly fire another incident because we do not know the exact structuring of our vascular system. So the earlier we control this, the better the outcomes in terms of the events we can give to the patients. So not just uncontrolled dyslipidemic with high intensity statin and ezetimibe, other measures do require this. Patients who have undergone an event should be taken care of, and basically our threshold in prescribing such molecules should be coming down, especially with patients who are at very high risk of event or who already had an event, so that we can actually give them some life free of such morbidity or the mortality that we face from this atherosclerotic vascular diseases. So inclisiran first strategy, so definitely if we hit the LDL down and over the period of time our moderate to high intensity does the work. So then one question arises, so if inclisiran already hits the LDL down to low levels, why would we need statins? Statins are something that are not just LDL molecules. They have a high amount of anti-inflammatory effects. They have their other properties. So statins do not go away. But the maintenance of LDL with inclisiran helps those statins to do their proprietary work even much more better. So with that, the treatment burden goes down. We know that Orion 3, Orion 4 basically builded this molecule to phase 3 trials. Now we have Orion 8. So what do we see? That with help of inclisiran, more than 80% of the population of people or patients actually get the LDL control. And how do they get the LDL control? An extra 50%, that is what basically it is 48.7. So extra 50% of control of LDL gets better. So what happened? Our patients who are having atherosclerotic vascular disease are patients who are basically diabetic or pre-diabetic. They do have a benefit of more than 50% of LDL-C reduction. So this is another case scenario where we see this is a lady who's 52 years old and BMI is 32. So we know that when BMI, so we are now not talking about overweight, we are talking about an obese patient. She suffers from chronic kidney disease, has a big comorbidity, underwent NSTEMI and underwent a bypass with multiple grafts placed in LAD and RCA. So with patient like this who's obese, who has a significant comorbidity, now we see what's the dose of statin that we are putting the patient on is 20, but the beautiful point is that the patient has already been on ezetimibe. So we have made sure that we do give something to the patient, but what is the LDL level at this point of time? The LDL level is 120. Is it controlled? With high risk factors, comorbidities, with patient already having atherosclerotic vascular disease, we know that although the criteria of AHA and ESA differs, but we do agree on to a standpoint, whether it be AHA, ESA, or whether it be our Indian lipid guidelines, Lipid of Association of India, that the lower the better. So this is why the robust lipid lowering therapy, especially in patients with very high risk factors, with very high risk of getting atherosclerotic vascular disease, or even more the patients who had an event, is very, very much necessary, and maintaining this LDL helps them in reducing the events even further. So this is where the inclisiran helps of the post hoc analysis of the 3-stage trial. What did they say? They reduced recent MI, the remote MI. So it is not just the numbers speaking. The numbers are speaking in terms of reduction of the specific mortalities or the morbidities. And how does it provide sustained reduction? Yes, it does provide sustained reduction, as it was seen with Orion 9, 10, and 11, that nearly 50.5 was sustained reduction extra was seen. From Orion 7, you can see what was the reduction in the renal impairment, what was the reduction with in terms of mild, moderate, and severe. So it has not seen that they do affect other organs by reducing the LDL, that it is like we are giving them an effect or giving them another side effect. No, it does not do that. So a patient who has a prior kidney problems along with events of MI, there is significant reductions. We saw in the earlier case that a person who had no CKD also had nearly 49% of reduction extra. Here you can see with this impairments the difference. So these are the similar case scenarios. I'll skip that and actually just say that whenever there are long-term safety needed in higher CV risk, inclisiran is very well tolerated. The basically TEAs are the side effects and serious side effects. The terms of effects and side effects are very less. And the good point here is that over the period of time, the safety is established by reduction. There is little serious side effects or less side effects. And the risk assessment, we all see if we have specific patients who have event done or patients who are at very high risk category should be taking this along with statins. So these are the guidelines which help us. So this was my final statement. As our patients who we saw, that if an event is there, we have significant comorbidities. Eventually adding this molecule and getting the LDL levels earlier the better helps in getting. So our threshold with such patients should be there. And now companies have already effectively started reducing, giving 1+1, so that price has come down. So this molecule from the physician side should be being prescribed at a lower threshold. Thank you.
Any questions?
Thank you, Nikhil. Any question and comments? How many injection you have to prescribe?
So when we initiate the therapy, basically it is one injection stat followed by third month injection and then every 6 monthly. But over the period of time in a year, you need only 2 injections, that is 6 monthly.
For how long?
It depends on your LDL levels. Usually, like the patients that we had on, mostly more than 1.5 years, patients are doing well on moderate to high intensity statin therapy.
Then how do you maintain this LDL level again?
The LDL levels, again, the baseline should always be statin. To add upon that, patients who are at very high risk or specifically who had already an event like patients who we do plasty, we do not want them, the other event to be happening earlier. So with such patients, that is why the major talk, it's not just about the LDL numbers. It's about our threshold, that how well do we initiate and how well do we keep those LDL levels in control. Because as we see over this all lifestyle disorders, not just dyslipidemia, in diabetes now we are talking more about 24 hours diabetes and hypertension control. Similarly with LDL, the better amount of LDL control we are giving them over the periods of years, the better their chances of not getting the recurrent event.
Any question and comments?
I'll ask 2 questions.
Yeah.
What is your experience with the reduction in the HSCRP with this molecule and lipoprotein little a, if at all you have observed? And are there any serious side effects that you have encountered when people have very low LDLs, like less than 20, less than 30 maybe, with the use of this molecule?
So so particularly talking about my patient, the lowest LDL of my patient is 11. And the patient who had an LDL of 11, he is doing well, no myalgic side effects, per se no weakness complaints. So in terms of overall quality of life, he has no complaints. So but on the contrary, as we say, there are people who we initiate just statins and you can find complaints of weakness, although they are not myalgia complaints. So again, it depends on our patients that what they are complaining and what their symptoms, because sometimes the complaint of weakness is very vague. And there are events which we see that they are actually myopathies because they will be coming with CPK levels. So definitely with low LDLs in such a per se body functioning does not get disrupted as what in my patient of LDL that I have 11 that I have seen. In terms of reduction of CRP and lipoprotein A, there is definite reduction of lipoprotein A and HSCRP that is seen. But again, this added benefits are better with statins, but they are present with inclisiran also. Because what inclisiran is doing is, it is actually interfering with production of PCSK9, which ultimately does deal with LDL and the metabolism. So there is reduction with HSCRP also.
Thank you, Dr. Nikhil. If there are no more questions, we will wind up the session.
Thank you. Thank you.
Thank you so much. I would now like to call our chairperson on the stage and the speaker to exchange mementos. A huge round of applause, please.
Clap, clap. Clap, clap. ये सबके में डाल दो. तालियां बजाई नहीं तो फिर मैं हाथ ऊपर नीचे करवाऊंगा, डांस करवा दूंगा. बहुत बहुत बधाइयां निखिल जी को. Next session, thank you.
Moving on to our next session, I request Dr. Vitul Gupta sir from Bhatinda to come up on the stage. He'll be speaking on such a vital topic, pollution and diabetes. A deadly combo, right? I would also like to call a chairperson, Dr. Sanjay Nema sir and Dr. Ashok Srivastava sir. I request our chairperson to introduce our lovely speaker, please.
Hello. Good morning.
So अभी सर एक बॉम्ब फोड़ेंगे, pollution and diabetes a deadly atom bomb. So क्या होता है देखिए.
Good morning, everybody. We are moving ahead with the next topic, a very interesting one, pollution and diabetes. The speaker is Professor Dr. Vitul K. Gupta, MD, FICP, FCI, FACP, FIACM. He is consultant, Kishori Ram Hospital and Diabetic Care Center, Bhatinda. Chairman, Association Physicians of India, API, Malwa Branch. Chairman, CCDSI, Punjab. President, LAI, Punjab. He had been health and human rights activist, national convener of Pollution Council, Cardiac Society of India, Chairman, RSSDI, Punjab Chapter, Member, Executive Committee, Cardiac Society of India, Fellowship of ICP, CSI, ACP, and ISCM, Role of Honor in Table Tennis, Lawn Tennis, Badminton and Swing, great. Chairperson, Organizing Committee, EPICON 2014, Ludhiana. Organizing Secretary, MAPICON, Bhatinda, 1425. 52 scientific papers, 51 chapters, several abstracts, guest lectures and chair, so on and so forth. You can see on the screen, he has a lot of laurels to him. We welcome him for this important talk, different from the routine talks, pollution and diabetes. Dr. Vipul Gupta, please.
Thank you, chairpersons, for kind introduction. And it is my pleasure and privilege to speak amongst the great, inspiring, motivating personalities like Dr. Sunil Gupta. Dr. Sunil Gupta, please. मैं आपका नाम ले रहा हूँ as, inspiring and motivating personality. Gift man of India, Dr. Jayant Panda. My friend, Dr. Rajesh Agarwal. And the host. Great job done. So it is, thank you very much for inviting me to this lovely conference. I start the lecture by paying tributes to my late father, Comrade Ved Prakash Gupta, my friend, mentor, Dr. Gurpreet Singh Wonder. He has been guiding me since first day of my medical college. He was 1 year senior to me. And coming on to the topic, pollution and health. After discussing the two important topics, gut microbiota as well as the other thing, that millets. This is an important topic which is coming up in last decade. India is often referred to as diabetes capital of the world, and ICMR data, we all know how prevalent diabetes is in India, and it is one of the most significant global health challenge of 21st century. So diabetes, Dr. Sunil Gupta is president-elect of the largest body of research in diabetes, RSSDI. So the recent evidence highlight as under-recognized contribution of pollution. So pollution we discuss under environmental pollutants and endocrine disrupting chemicals, because these are important since diabetes is an endocrine disorder. So United Nations Environmental Program defines pollution as the direct or indirect alteration in biological, thermal, physical or radioactive properties of any medium in such a way as to create a hazard or potential hazard. So mind you, underline these words, hazards and potential hazards to human health or to the health, safety and welfare of any living species on this earth. So India, if we consider pollution, WHO reports 9 out of 10 people worldwide breathe in polluted air, with India being one of the most affected country in the world. That is why the topic pollution and diabetes gains importance in Indian scenario, so much so that 63 most polluted countries are from India out of 100 in the world. So that is the extent. So Earth's health and health of the Earth's inhabitants is excruciably linked to each other, and adverse effect of pollution are not only with air pollution, but equally serious and not very much talked about. Again, I must congratulate Ashish for including this topic, because this is not much talked about topic, and that is why we are talking about it. About soil, water, noise, radioactive, biochemical, biological, chemical pollution, together we are going to discuss as environmental pollutants, not only the air pollution. So what are environmental pollutants? So these are the chemical substances or mixture released into the environment. So that is persistent organic pollutants, heavy metals, air pollutants, agrochemicals, plastics and additives. Plastics are, mind you, are coming up very fast, because recent studies state that the brain also contains minute plastic contents. So major sources include industrial factors, transportation, agriculture, household activities and burning of fossil fuels. The environmental pollutants are classified according to the medium, like air, water, land, noise, thermal, light pollution, biological, chemical and radiation pollutants. So what are endocrine disrupting chemicals? So they are defined as exogenous, chemical or mixture of chemicals that interfere with any aspect of hormone action, which contains the synthesis, breakdown, development of hormonal receptors, etc. So these are also very important components of environmental pollutants. So these are the various chemicals, and if you see the list, they are in every part of our life contributing to it, making of polycarbonate, plastics, cosmetics and fragrance, agriculture, lubricants, electrical equipments, name any part of our equipment in the life, they contain endocrine disrupting chemicals. So these are the classification according to the natural and synthetic. For the paucity of time, I will skip a few slides but it is represented here, which you can very well appreciate. So based on the sources, they can be included into drugs, household and industrial chemicals, byproduct of operations. So the common endocrine disrupting chemicals and their use, you can see they are included in food products, pesticides, contraceptives, textiles, personal hygiene products, medicine, electronics and kid products. That is why I say they have captured the whole of the life system of human beings. So there is growing interest that pollution include environmental chemicals, and most representative of disrupting chemicals are known. So again, it is the list that is persistent, organic pollutants, organochlorine pesticides, industrial chemicals, digoxins, and pre or post substances. So this cartoon represents the environmental pollutants, their source, and how they affect the system, that is the obesity, diabetes, increased cholesterol, metabolism, adiposity, as well as the resistant secretions. So these chemicals are resistant to degradation. That is why they are persistently present in the nature. So special concern for phthalates and especially the BPA, because more than 95% of the people worldwide have BPA in their bodies. So that is how they are capturing the human body and adversely affecting the health. EP are present ubiquitously in the environment, and human exposure through the intake of water, food via inhalation and through skin, they are entering our body. And this cartoon very well depicts how agriculture, household, wastewater, etc. are adversely affecting our bodily culture. Numerous studies like EP exposure to endocrine metabolic disorders have suggested the adverse health effects. Widespread plastic use in India highlights the concern regarding the phthalates and BPA impacting on diabetes prevalence. So that is why we are talking about pollution and diabetes, a deadly duo. So the studies reports suggest a strong association between diabetes, pre-diabetes, and environmental pollutants. Exposure to environmental pollutants during pregnancy is another critical issue, and I must mention here that Sunil Gupta is having the DIPSI or diabetes in pregnancy to his heart, conducting various programs in diabetes in pregnancy. I think in how many languages you have conducted? 22 languages he has conducted this program. So pregnancy is very high risk group. So again, this cartoon tells us how obesity, type 2 diabetes and type 1 diabetes is being affected by environmental pollutants. Again, prevention and treatment, organizational effects and additional effects. So these cartoons stress that environmental pollutants are affecting our life in like never before. So this is how they are again exposure to the metabolic disorders, to the reproductive system, to the female reproductive system, and initiation of cancer as well as metabolic diseases. Again, this cartoon, environmental pollutants are carcinogenic, the hepatotoxicity, the nephrotoxicity, name any system that is being affected by environmental pollutants. Specifically, coming on to the diabetes, this is how the diabetes is being affected, and various pollutants are affecting the various pathophysiological cascade leading to diabetes. Various types of studies can provide evidence to identify the environmental pollutants, yet systemic method is needed to integrate this data to help identify such hazards. And this is one of the key characteristics study where 12 key characteristics of endocrine disruptors were endocrine, and this is a very crowded slide where a consensus statement presented a logic that reveals the characteristics of endocrine disruptive substances that highlight the evidence support identification of cases. So there were 12 cases affecting different parts of the body differently. So EDs can induce cellular changes by mimic or interfering with hormone types. So this is how the hormonal receptors are being affected. So the disruptors, the systemic representation of main. So this is the model which is real important, and if we want to conclude, this slide can conclude how the endocrine disruption is affecting our metabolic health. The impact on health, you see every part of human body is being affected from this cartoon, and we have published this book under the API banner. So this is a concise book of 34 chapters, including each and every system of the body, how pollution is affecting, and this is available free of cost at our website, www.apimalva.com. You must go through it, and this book I will be presenting today to Dr. Ashish at Jabalpur. So these are the 34 chapters included in this book affecting each and every system of the body, and this is how the mechanism is going to be affected: prenatal exposure, epigenetics, immunology, oxidative damage, air and alveoli. I will not go into details because of paucity of time. And this is the pathological pathway, how the environmental pollutants or specifically air pollution is affecting the, and clinical outcome is diabetes, pre-diabetes, ischemic heart disease, and affecting all the system of the body. So this is impact on metabolic health, and this is again how the air pollution specifically is disrupting or having adverse health effects on our body. So research gaps and future directions, we need longitudinal studies. We should identify biomarkers, gene environmental interactions, gut microbiome, already speaker has discussed. It is coming up as a very big way in human health. So healthcare cost and pollution related diabetes should be researched upon. The vulnerable population include children, elderly, low income group and pregnancy. Preventive and mitigation strategies, we all know, they come under public health level, clinical level and individual level. We must not wait for governments to act, and we should act at our individual level. That also is going to make a great effect on controlling pollution and pollution in the environment. So my dear friends, to conclude, India is often referred to as diabetes capital of the world. Environmental pollutants and endocrine disruptors represent a new frontier in diabetology, and we must investigate, research on this aspect, and be careful to ask the history of pollution whenever a patient of diabetes walks into your clinic. Definitely, pollution and diabetes are a deadly combo. The interplay of industrialization, environmental exposures, and metabolic health requires urgent action. Mechanisms ranging from insulin resistance, beta cell toxicity, oxidative stress, inflammation, mitochondrial dysfunction, and epigenetics underscore the multifactorial impact. So it is a multifactorial disease of which the environmental pollutants are integral part. Now, addressing these exposures through policy, public health interventions, clinical practice is essential to curb diabetes epidemic, particularly in developing nations where both pollution and diabetes is rapidly rising. And that is why we are now capital of the pollution of the world as well as diabetes in the world. So my dear friends, this book is available free of cost, and I welcome you all to 13th annual conference of API Malwa branch, that is MAPICON 2026 at Bathinda in September. This is hybrid conference. You can join on the virtual mode as well as on physical mode. Thank you very much, Dr. Ashish, for giving me this opportunity to address this audience about pollution and diabetes. Thank you very much.
Thank you very much, Dr. Vitul Gupta, for presenting the topic diabetes and pollution nicely. Any questions from our audience, he will be pleased to answer.
How how do you assess the impact of air conditioners as a pollutant in our health?
So it is not my assessment. It is basically contributing more to the climate change and global warming, and the leftovers are going to contribute to the pollution. That is the environmental pollutants, various types are there. So it is going to be there. So I asked one old person from a village that what is happening in the world. He told me in Punjabi कि डॉक्टर साहब जितने सुख के कारण उतने दुख के कारण, जितने सुख के साधन उतने दुख के कारण. So we were talking about the traditional medicine when we talked about millets. So traditionally Indian culture is the best culture in the world. To contain, for hygiene, you see, we never enter our kitchen with footwear. So we have very clean and traditional diet, and since we are forgetting our traditional ways of life, we are confronting all NCDs in last 3 decades.
Since no more questions, I think we conclude the session. Thank you so much, Mr. Vitul Gupta, for an excellent talk.
Thank you
really
very much.
deserve all our praise.
Thank you very much. So Dr. Panda has also contributed a chapter. Since Dr. Sunil is here, I will invite them on stage to present this book to Dr. Ashish.
Thank you, sir.
And if there is someone from medical college, I call upon the stage because I
R.S.
will
Sharma sir ko
present
bula lo.
this book for medical college also.
A huge round of applause, please.
Ashok sir आइए. He is very senior physician, Dr. Ashok Srivastava. बहुत पुराने RSSDI member हैं. तालियां बजती रहें. तो ये एटम बम सर हमको देके जा रहे हैं, तो आपको सबको संभाल के रखना है कि पोल्यूशन के बारे में जो बताया उसको. मोमेंटो टीम प्लीज कम. तालियां बजती रहें. सर ये भी डाल दो.
Thank you so much for this lovely session, sir. Moving on to our next session. Sorry. I request our chairperson, Dr. Ajay Bhandari, sir, and Dr. Diksha Soni, ma'am, Professor Dr. R.S. Sharma, sir, and Dr. D.S. Chaudhary, sir, to take a seat. Our next lovely speaker, Dr. Jayant Pandey from Odisha. Panda. Dr. Jayant Panda, sir, from Odisha, who will be speaking on such a beautiful topic, MRDM versus type 5 diabetes, the Cuttack story.
This is the oration of late Shri C.R. Bhandari sir's oration. So first we will read the CV of sir. So over to Jain sir, please read the CV.
Dr. C.R. Bhandari sir, born on 25th October 1924 in a reputed business family of Indore, and did MBBS from this is Gandhi Medical College in the 1934. हाँ थोड़ा नीचे आ नीचे अच्छा दिखता है. I think Gwalior Medical College, yeah. Did MBBS from Gwalior Medical College. Yeah. MD Medicine from Indore MGM Medical College under famous clinician S.K. Mukherjee, and then joined as a demonstrator in the Indore Department of Medicine. Is promoted and came to Jabalpur Medical College in 1961. Since then, he served the Government Medical College, Jabalpur, where he retired as a professor and head of medicine. He was a clinician par excellence, still remembered by his students in the clinical cardiology. Yeah. Clinical cardiology. He was very friendly and a dedicated teacher. Was an active member of API, CSI and IMA, regularly participated in national and international conferences, published a number of papers in national journals, and passed away 3rd July 1988. So,
big round of applause for our late Shri Dr. C.R. Bhandari sir. और जैसा कि मुझे पता चला है, क्योंकि हम तो जूनियर थे, कि शहर में कोई भी अगर ईसीजी करता था तो पहला हॉस्पिटल और भंडारी सर का था. ऐसा सच है सर? जी, तो ये मतलब हमारे लिए सौभाग्य की बात है कि उनके सन डॉक्टर अजय भंडारी सर हमारे साथ हैं, तो उनके लिए बहुत बहुत तालियां. और सर को हम लोग याद कर रहे हैं, लेट श्री C.R. भंडारी सर. ओवर टू यू.
my regards to Dr. Bhandari and all chairpersons. So, with this, I can start the oration. I'm.
Hello. Good morning to all of you, and it is my pleasure to introduce Dr. Panda, but it needs no introduction, of course. But all his credentials are so big that probably his introduction will take more time than his lecture. So I think we should go ahead with the lecture, and then we can discuss the things later on. Thank you.
Thank you, sir. Thank you. My oration is dedicated to late Dr. C.R. Bhandari sir, and I thank the whole team of NDID DIO-CON 25, the 7th International Congress on Diabetes, where very elegantly this has been launched in the city of Jabalpur, and the Mahi group had done a marvelous work by inviting so many. Yesterday in the pre-conference, I saw many senior doctors and a huge crowd that at 11 p.m. extra chair was to be put in the hall to accommodate the doctors. And especially my thank to Dr. Ashish Dengra, the attracting force at the Jabalpur city, who has brought all of us here. Give a big hand for the Mahi Medical and the Research Foundation, the MMRF, which has done it all throughout 7 years and got all of us here. My topic, as you know, is malnutrition related diabetes mellitus versus type 5 diabetes, the Cuttack story. All of you practice diabetes. How many of you see patients who are ketosis resistant, responding to oral drugs, yet not very hefty, not very fat, lean, and maintaining a good glycemic profile with insulin and oral drop insulin? But they have never presented with ketosis, and if you see them, hardly you suspect insulin resistance. How many of you have seen? Please raise your hand. All of us see. As in our diabetic population, almost 1/4 of the patients are of lean structure, a BMI less than 19.2 who are considered lean diabetics or malnutrition related diabetes mellitus. And why malnutrition? Because most of them have a low birth weight if you track them, number one, and most of them have history of malnutrition in their childhood. So taking that into picture, in IDF 2025, April 15th, Peter Schwartz, the president of IDF, launched the concept of type 5 diabetes, designating this to be a diabetes which is seen only in patients of malnutrition or lean patients. And before that, we had a consensus meeting at Vellore regarding that, and those all who were there at Bangkok in the IDF, we had type 5 diabetes declared, and a study group was made, and I was invited as a member because in my place at SCB Medical College, Cuttack, for last 50 years, we are working on this concept. This publication in the Lancet way back in 1984 by Professor B.B. Tripathi and Bishikar, which shows clinical pattern of diabetes mellitus and describes this J-type or lean diabetes. And this is my publication with Professor Siddharth Das in the diabetes and metabolism regarding the low body weight or the lean diabetes. And this is our technical series, low body weight type 2 diabetes or the lean diabetes. And in the international workshop on diabetes peculiar to tropic in 1995, accepted this entity as a special type of NIDDM, and in the classification it was introduced. This is Cuttack, Hotel Akbari, where who's who of diabetes of the world are there in 1995, who declared this as a PDDM or protein deficient diabetes mellitus, and along with FCPD or fibrocalculous pancreatic diabetes, they were classified under MRDM or malnutrition related diabetes mellitus, introduced by the WHO in its classification. So I salute my mentors, Professor B.B. Tripathi, Professor Siddharth Das, who are working on this particular entity for last 50 years and telling us the data from our registry. We run a ICMR registry on young diabetes patients where we see particular varieties that I'll show you, and I'll tell you how you should deal with them. So today's oration is dedicated to young diabetes and the people with lean body weight. You must be thinking the rising number of diabetic is from rural area or urban area. What do you feel? Most of them are from a rural belt or a urban belt. Most of you think urban. The affluent people, they take more, eat more, work less and gaining. Contrary to our belief, it's 5 times in urban area and 8 times in rural area. Since 2014, the case numbers are plotted here, and prevalence of diabetes increased more in rural than in urban. And in the rural area, those who had malnutrition, those who had low birth weight are the people who develop this type of diabetes. I am showing you 2 publications from Northeast. The first one is just 4 kilometers from Bangladesh border, where the prevalence of diabetes was 9%, median age was 44, but 23% of patients had BMI less than 18.5. And 5% prevalence of diabetes in a patient of Arunachal Pradesh, in a village of Arunachal Pradesh, where median age was 41 and 20% had BMI less than 18.5. So these people are thin, at the same time they had very requirement or diabetes. Taking you back to the history, in the France in 1877, these patients were described as lean diabetic, and in 1955, Dr. Jones have described in the Lancet as J-type diabetes of Africa or the Jamaica type of diabetes in the Africa. And Dr. Bajaj has described them as malnutrition related diabetes mellitus in India. And this is the world map, the WHO map of 1985, which shows the yellow part is the PDPD, that is protein deficiency pancreatic diabetes, the PD, the fibrocalculous pancreatic diabetes, and the red part, which mostly we get in India, is both PD pancreatic diabetes, protein deficiency pancreatic diabetes, and fibrocalculous pancreatic diabetes. So it was well accepted by WHO, was put to the classification and were followed, but unfortunately it was subsequently withdrawn. I'll show you that. And this is our criteria at that time. And Dr. K.C. Samal and Dr. Tripathi from SCB Medical College described that way back in 1996 as a severe diabetes, fasting blood glucose more than 200, onset of diabetes before the age of 30 years, and body mass index less than 18, the absence of ketosis on withdrawal of insulin, and poor socioeconomic status with history of childhood malnutrition, insulin requirement more than 60 units per day or more than 2 units per kg per day, rural origin, absence of radiological feature of pancreatic calculi, and then the dilatation or the fibrosis, the lab features of exocrine pancreatic dysfunction. This is the classical description 30 years back from the Cuttack. And this is the picture of Dr. Bajaj's group, the Wellcome Trust unit in 1988, the malnutrition and diabetes study group, who also contributed data to WHO. And this is our picture, the Cuttack picture, the International Workshop on Diabetes peculiar to the tropic. And unfortunately, in 1998, WHO removed the classification, telling that there is no much evidence that the malnutrition can cause diabetes. The lean means in South Asian population, we accept less than 19.2 kg per meter square BMI. But in our study, it was taken as 18.5 when published in the Lancet. So this is a classical patient I'm showing you, the case report. The age of diagnosis is 17 years. Index symptoms were fatigue and the giddiness. The blood sugar was 165 milligram per deciliter. Weight was 49 kg and the BMI was around 15. And the patient was on oral anti-diabetic drug prior to presentation, and weight loss of 12 kg over 3 years. No history of diabetes, diabetic ketoacidosis, abdominal pain, and no complications. And from lower middle class family, full term normal vaginal delivery, and patient had a birth weight of 2 kilos. So it shows a low birth weight. Duration of the breastfeeding was 2 years. BMI was 15.9. Waist circumference was just 66 centimeter. Height 156, and the ideal body weight was 56 kg with normal pulse, blood pressure, and no much symptoms. The investigations within normal with the albumin 4.9, and the stool elastase was 203, and anti-GAD was negative. And this shows you the C-peptide, which was initially low at 0 minute, and in 90 minutes it becomes normal or more than 2. And no evidence of fatty liver or pancreatic calculi in the CT scan and the ultrasound of the pancreas. The total body fat content were low, and the patient in the next generation sequencing was negative for the pathogenic or the likely pathogenic variants of the gene. So summarizing the case profile: lean, young onset, non-autoimmune diabetes, fasting insulinopenia, normal pancreatic structure, low body weight fat, non-ketotic, without a classical genetic disorder, low birth weight, low socioeconomic group, qualifies for the type 5 diabetes. And patient was put on glimepiride 3 and sitagliptin 50 milligram once daily. So there are many categories which we don't remember as a criteria to diagnose type 2 as well, like low in fruit, low in grain, low in the vegetables, and then high alcohol, high body mass index, high air temperature. There are so many risk factors for type 2 diabetes we miss. In 44 December also the Dutch hunger winter describes the babies born of low birth weight have a higher blood glucose. And this is the map, the global prevalence of the undernutrition, and India has around 15 to 24% people undernutrited, and then this is the heat map of low birth weight. You can see India is in the top in the low birth weight as per the WHO classification. And these are the classical descriptions of low birth weight, light, not taking, the protein intake is low, mildly increased diastolic blood pressure, low growth hormone, did not have terms of insulin sensitivity, and the classical description in the Jamaica was the clinical syndrome of severe acute malnutrition may have early life origins because of children with marasmus have low birth weight than those with Kwashiorkor, and they had a very high blood glucose level. And this shows the blood glucose level in this lean people are very high, the insulin is less. And the PAK1 in the glucose homeostasis signaling is shown here, where early malnutrition is a feature and starvation and early life malnutrition gives as per the history. Even Dr. Ramesh Kardori as well as S. Bhatia in their publication has shown protein malnutrition resulting in hyperglycemia and the hypoinsulinemia. These are the pancreatic islets, where in malnutrition you get micro islets where the insulin secretion is low and there is hypoinsulinemia. From Pakistan also there is a group of patients reported who have low body weight and ketosis resistant and described as a malnutrition diabetes, and this J-type diabetes has classical description in the history with the responding to insulin, oral drugs, especially sulfonylurea and DPP-4, as well as the high protein diet, the resistance of exercise and the aerobics. So this is from the Scientific American regarding the pancreatic pathology, and then regarding the undernutrition associated with the diabetes, this is the classical criteria. So this is from Dr. Yagnik, that if there is a overnutrition, it results in classic type 2, and if there is a undernutrition, it results in type 5 diabetes. So finally, I'll give you a picture of where you should classify these patients and end my talk. You see, it can be type 1 or slowly evolving immune-mediated diabetes. It can be fibrocalculous pancreatic diabetes. It can be monogenic diabetes. It can be lipodystrophy, Wolfram-like syndrome, or type 5 diabetes. So these are the different criteria. I'm not going to the details how you'll differentiate type 1, fibrocalcific diabetes, the monogenic diabetes, the patients of maturity onset diabetes in the young, the lipodystrophy or the Wolfram-like syndrome, as well as HIV lipodystrophy. So here, summarizing the criteria of different types. In this type 1, you get low C-peptide and GARD positive. In fibrocalcific, you get pancreatic structural disorder with low C-peptide. With MODY, you get genetic testing positive with the intermediate C-peptide. Lipodystrophy, you get high C-peptide and the genetic testing positive. The Wolfram-like syndrome, you get the genetic testing positive. With type 5, the classical pictures that I showed. These are the investigations you can do, and in a resource constant setting along with a good history, you can take a pedigree chart, physical examination, C-peptide, GARD antibody and the ultrasound. And remember, in your class, in your clinics, in your consultation, you will get a particular group of patients. At least 1/5 to 1/4 of your patients will be lean. The type 5 diabetes is a distinct metabolic entity associated with insulin deficiency, preserved insulin sensitivity, low body weight and low total body fat content with relatively reduced hepatic glucose output. The antenatal and the postnatal undernutrition of variable degree and combination is responsible for the pathogenesis. And understanding the differential diagnosis of other causes of diabetes in the young and the lean is critical, using the appropriate tools to diagnose and manage these disorders, and future direction, the term of diagnostic algorithm, complication risk, and understanding of therapeutic intervention is required, which is being studied by IDF. So ladies and gentlemen, in these patients, you especially see ketosis resistant, history of malnutrition, very high insulin requirement, and features of the protein deficiency. And they are phenotypically different than classical type 2, and especially in India and Africa, it's a different entity complication wise, clinical presentation wise, which we can aid. So please classify them, fit to the entity by doing a C-peptide or the guard antibody, and report these cases as type 5, because the entity has already come by IDF, and in the future this will be a separate classification. I thank again the NDID team for the oration, and expecting the message regarding the malnutrition related diabetes goes clear to all of you. Thank you for your time. Thank you for your attention.
Thank you, Dr. Panda. Excellent talk. And at least I can vouch for myself that I have become wiser. And retrospectively, I can diagnose some cases which were previously not diagnosed as type 5. And I think I can diagnose them as type 5 diabetes. Thank you very much for the excellent talk and motivating us for the this type of diagnosis, which is not very common in our part of the country. But thanks a lot. Since this is an oration, there are questions are not allowed, but still, if there are some comments, that can be made. So, thank you very much again.
Thank you, sir. Thank you.
ओरेशन के बाद साइटेशन प्लीज आइए सर साइटेशन पढ़ेंगे
A huge round of applause, please. I request our next chairperson, Dr. Dilip Tiwari, sir. Dr.
We will read the citation. Please, please. थोड़ा सा.
So it is a very pleasant thing to have a discussion on Professor Dr. Jayant Panda, and he has delivered a lecture on one of my very favorite teachers. You will be surprised to know that he taught me, Dr. Bhandari. So you must think that how much senior he was. And we remember him still for his all the dedication towards the community, and I think he was the best teacher that I had. Now coming to Dr. Panda, he is a consultant in diabetes, metabolic and critical care medicine, serving at Odisha Medical Education Service since last 23 years. And fellows of Indian and American College of Physicians and Societies of Diabetes, member faculty council of ICP, treasurer National RSSDI, and member of the GC Diabetes India, vice president of the Odisha chapter, Young Achievers Diabetic for NCCD 2018, Kolkata. Awarded DMD SC Honor 2014 by Dr. Mohan's Diabetes Specialty Center, Chennai, and delivered R.K. Menda Memorial Oration, IMA, Calcutta, 2016. RSSDI 2015 commemorative oration in the Then API, Boehringer Junior Lectureship in Diabetes, 2019, KG Nair Oration at Virtual BBCon 2020, Lucknow, an active member of the API, RSDI, ICM, IMA, IDCS, ISDS, ESD, ADA. So from A to Z, I have contributed chapters in textbooks, updates, various monograms, journals, and the principal investigator of many international and national trials, and organizing secretary of the 45th RSDI 2017, Bhubaneswar.
बहुत तालियां.
And I will accept that I omitted so many other things.
सर ने जो RSSDI करवाई थी भुवनेश्वर में वो बहुत ही ग्रैंड सक्सेस थी, तो बहुत बहुत तालियां सर के लिए. और सर RSSDI में बहुत ही ज़्यादा एक्टिव मेंबर हैं. और सर आप कुछ कहना?
And I must thank the effort of Dr. Ashish Dengra, where in Jabalpur, in a place like Jabalpur, so much of good shines, and you all come, and for last 2 days I'm seeing virtually and physically the discussion and the interactions, which makes all of us wiser. So give a big hand for the NDID team, Ashish. Let it continue, all our blessings. And all of you are invited to Odisha on different occasions. We keep on inviting people. So through Ashish and through all senior leaders, I invite you to Odisha. And anybody, anytime need any help at the Jagannath Darshan or any work in Odisha, please never hesitate to tell us. Thank you. Thank you.
तो पुरी में दर्शन करने तो सर से बात करके जाएंगे. सर. तालियां नहीं रुकनी चाहिए. क्लैप 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 क्लैप. बहुत कंजूसी कर रहे हो यार. अभी खाना खिलाएंगे ना, चिंता क्यों कर रहे हो? पहले एनर्जी बर्न कर लो, कैलोरी बर्न. मैडम को नेक्स्ट टॉपिक.
Thank you so much. I request our chairperson, Dr. Dilip Tiwari sir, Dr. Shriram Agrawal sir, Dr. Rajesh Kewat sir to take a seat. I also request our lovely speaker, Dr. Rajvi Kovil sir from Mumbai, who will be speaking on a topic, surmounting obesity with tirzepatide. I also request our dear chairperson to introduce our speaker.
I have a pleasure of introducing Dr. Rajiv Kovil sir. He is Medical Director and Consultant Diabetologist at Kovil Diabetes Care Center. He is also Consultant Diabetologist at various hospitals, and he had been speaker for various national, international forums, and he is an invited faculty for various fellowship programs, and he is President of Indian Podiatric Association, Secretary RSSDI Maharashtra, gold medalist in diabetology, Mumbai University, and he has published various publications in the national, international journals, along with being a principal investigator for various clinical trials. So
Thank you so much, Chair. Thank you, Ashish. Thank you, audience. I hope I can add some clinical strategy to what we are going to talk today about tirzepatide. It's a new molecule in the last 6 months. It's captured everyone's imagination across the globe. We're going to talk about SURMOUNT, which is this group of studies on obesity, and we're going to talk mainly on SURMOUNT 4 and SURMOUNT 5. This is my disclaimer. I'm a contracted speaker for Eli Lilly for this talk. Let's talk about, so we know a lot about GLP-1 because it's been there for the last 2 decades. We know it works on the brain, maps the brain, reduces the gastric emptying. then it's insulinotropic, it stimulates the insulin release from the beta cells only in the presence of glucose. Not much is known about GIP. GIP is a nutrient stimulated hormone with multiple sites of action. One needs to realize that the mapping of the brain by GLP and GIP is different. Glucose independent insulin secretion in almost healthy individuals, GIP estimates almost 50 to 70% of the incretin effect. So when we look at incretin as a whole, and we've been having incretin based therapy for 2 decades, almost 70% is through the GIP axis as such. Inhibition of food intake, anti-emetic and neuroprotective effect, basically all these drugs trick the brain. There are no GLP-1 receptors on the adipocytes, but you have GIP-1 receptors on the adipocytes. So it also helps in lipid metabolism, and there's an insulin dependent fatty acid uptake and mobilization. The fasting triglycerides as well as the blood flow to the adipose tissue improves with GIP-1 as such. So GIP is a very important regulator of lipid metabolism. It increases glucose and lipid uptake into the adipocytes. It increases adipose tissue blood flow. Under fasting condition, it mobilizes lipid from adipocytes. A combination of GIP and GLP can cause a lot of changes in our metabolism, and that's what we need to understand about tirzepatide. Now when we look at tirzepatide, we need to understand that peptide engineering has actually progressed in the last 2 to 3 decades, and today we have multiple hormones or a combination of multiple hormones which act on multiple different receptors. So earlier we had all the hormones which are centered around GLP-1 as being the core, but now what we call as the G protein coupled receptors, we are having a mix and match of multiple hormones which can act on multiple different receptors, and they can actually help in glucose homeostasis and energy balance. So tirzepatide is a dual cretin, is the first dual cretin which actually came into a phase 3 study, and the first dual cretin which actually got an approval as such. When you look at tirzepatide, it is a imbalanced and biased dual cretin. When I say imbalance, by imbalance I mean that it has the same affinity for GIP and it has 5 times lesser affinity for GLP. Now this makes it a very interesting hormone because as we know that 70% action is through GIP. So when we do dose escalation, and especially in majority of the time when we do dose escalation, this imbalance where it has 5 times lesser affinity to GLP-1 actually reduces the side effects of GLP-1, which is mainly the upper GI and the constipation and many other things. That's why all of you all who may have used tirzepatide would have seen that the GI side effects are lesser because there's an imbalance on the receptor itself. 2, it is biased at the GLP-1 receptor. So in spite of having a GIP-GLP-1 action, though it acts on the GLP-1, it works through the cyclic AMP and does not go to beta-arrestin. If you go back to your pathophysiology, when you stimulate beta-arrestin, then it inhibits the insulin release from the pancreatic beta cells. So a co-agonism which has an imbalance towards GIP and a bias onto cyclic AMP actually makes it a synergistic effect where you have a better reduction of blood sugars and a higher impact on the satiety centers and the brain centers which map satiety and food regulation. As you can see, it works for 5 days, no dosage adjustments. Guys, just keep your murmur to yourself. Though no dose adjustments of Mounjaro is actually recommended for patients with renal or hepatic impairment. So when you have a combination of this dual cretin, it maps the brain better than a single or a mono cretin as such. It regulates the uptake of glucose and modulates the lipid uptake as well. In India and globally, it's indicated for type 2 diabetes as monotherapy in addition to other products as well, and also for chronic weight management where your BMI is more than 30 or more than 27 with the presence of any weight-related comorbidities, which could be any of the NCDs, pre-diabetes and diabetes, hypertension, dyslipidemia, OSA or cardiovascular disease. Now when you look at obesity as such, we know that obesity is a chronic relapsing disorder and there's a need, socio-medical need for all of us to start treating the core problems of NCDs, which is obesity. And a lot of guidelines have told us right now that we need to make people lose weight on the diagnosis of diabetes or to prevent OSA or any of this. But if you go through guidelines, none of them actually tell us how much percentage is required other than the obstructive sleep apnea where 10% is required for reduction of OSA symptoms. But data from this particular molecule suggests that you can have a disease modifying change because all the other molecules could give you only 8 to 10 to 12%. You have a molecule which is giving 20 to 25% reduction in overall body weight, and that can change or modify the disorder and disease. When I say this, I say it with a lot of conviction because 10 to 15% weight loss in newly diagnosed diabetics can put them into remission. The SURMOUNT OSA with tirzepatide showed that if you have a 20 to 25% reduction in body weight, you will reduce from severe to moderate OSA to mild OSA, which again means the indication and the guidelines for OSA may change to 20%. And till date, we don't have any other therapy other than bariatric surgery, which is not scalable. So today we have a anti-obesity medication which almost comes close to a sleeve gastrectomy, causing almost 25% to 30% patients losing more than 25% of the weight. So SURPASS is this group of studies done in people with type 2 diabetes. SURPASS 1 was with placebo, SURPASS 2 versus semaglutide, SURPASS 3 versus insulin degludec, SURPASS 4 versus glargine, and SURPASS 4 as an add-on to insulin glargine. In all these patients, it caused a significant reduction in HbA1c and a significant drop in body weight. We come down to its group of studies in obesity or chronic weight management, which is SURMOUNT 1, which is in patients with type 2 obesity without type 2 diabetes. SURMOUNT 2 is weight management in people with type 2 diabetes. SURMOUNT 3 is weight management after an intensive lifestyle. SURMOUNT 4 speaks about what happens if we stop the drug. What is the rebound effect after we stop the drug? And SURMOUNT 5 is an open label study between semaglutide, largest tolerated dose versus Mounjaro at 15 milligrams. If you look at SURMOUNT 1, it's a phase 3 multi-center randomized double-blind placebo-controlled studies, 119 sites. Patients has to be overweight or obesity with complication. We had excluded type 2 diabetes. The up titration is monthly, as you can see. The primary endpoints was the percentage body weight. Co-primary endpoint was the percentage change and the percentage of population who lost more than 5% at week 72. If you look at SURMOUNT 1, at the end of 72 weeks, 16% of patients had 16% weight reduction in most of the patients at 5 milligram at 72 weeks. So 5 milligram dosage is also a good anti-obesity agent as such. If you look at the higher dosages, 22.5 average weight reduction in body weight with tirzepatide 15 milligrams at 72 weeks. So SURMOUNT 1 was a study which clearly established that you can reach this kind of body weight reduction just at 5 milligram dosage also. And in India, we will observe that most patients have a sweet spot between 5 to 7.5. Very rarely do we have to go up to 10 or 12.5 or 15. And majority of people with obesity achieved more than 10% weight loss with tirzepatide 5 milligram. As you can see that at 5 milligram dosage, you had almost 90% of the patient losing 5% and almost 75% losing 10% and almost 1/3 of the patient losing more than 20% weight loss. So again, people of obesity on tirzepatide experience a lot of improvement in their body composition also, and most of the weight loss was attributable to a reduction in fat, including the visceral fat as such. And all these cardiometabolic variables actually go down, whether it's the blood pressure, whether it's diastolic, systolic, triglycerides, HDL and LDL. And people who lost more than 20% body weight had almost a 10 to 17 millimeter reduction in their systolic blood pressure as compared to patients who lost 10% where there were 5 to 7 millimeter reduction. So that is a huge change when you look at it. If there's a post hoc analysis of SURMOUNT 5 which looked at how much is the cardiovascular risk going down in the 10-year cardiovascular risk going down, And it clearly shows that the absolute cardiovascular risk going down with tirzepatide was 2.4% versus 1.4 with semaglutide, which means you are saving almost 2 million cardiovascular events versus 1.15 cardiovascular events by just the blood pressure and all these variables going down. Again, Surmount 4 actually looks at the question that what happens if you discontinue Mounjaro, because this is a question which most patients will ask you, that what will happen if I discontinue Mounjaro. So this had two phases. The first phase was 36 weeks, was everyone was up titrated to the maximum tolerated dose of Mounjaro, which was 10 or 15. After 36 weeks, they were blinded and they were put either on Mounjaro or they were put on a matching placebo to see what happens when you withdraw Mounjaro to these patients, and that was run over 52 weeks. So you have data over the first 36 weeks and whether chronic weight management you require a drug to be on, or after withdrawal whether you can continue the weight loss as such. And you had 783 patients in this. What it showed is that at the end of 36 weeks, on the highest tolerated doses, which was 10 and 15, you had a 20.9% reduction from a baseline weight of 107.3. People who continued to be on Mounjaro, they had an additional 5.1% reduction, and there's a 26% total reduction from their baseline weight at week 72. People who discontinued and were on matched placebo, there was a 9.5% rise. So clearly stating that if you want to maintain the same weight, you need to be on long-term therapy. But importantly, when you compare Surmount 4 to semaglutide step 4, which had a 20 weeks run-in period followed by a 48 weeks of maintenance, the higher you lose in your initial weight, the lesser is the chances of weight gain. So in the induction period, which is called as 36 weeks here and 20 weeks there, the larger weight loss, you'll make sure that you do not gain more weight. So Surmount 4 clearly told us that if you discontinue Mounjaro, there will be weight gain. It has not answered that if you have to maintain the same weight, what is the strategy? They have a study called Surmount Maintain, which is ongoing, which tells us that there are 3 cohorts in that. One cohort, you are continuing the same dose after reaching the target weight. Second, you are going down on the dose. Third, you are completely removing the Mounjaro off. The results will be out next year on Surmount Maintain. We'll have a clear direction that this is what patients ask us. If you have lost 20 kilos, what do you do? Should you cut off the medicine? Should you reduce the medicine? Or should you go on to a similar dose? So the answers will come next year on this. Again, if you look at the adverse event, majority is the upper GI, and as the dose increases, it keeps on increasing. Importantly, diarrhea is very common in an Indian patient and is usually very intractable. You may have to cut down the dose if you get diarrhea in Mounjaro patients. So the Surmount 4 summary was that with just a 5 milligram dose, you can cause a 16% drop based on the Surmount 1 and 22.5% with 15 milligram. There's a lot of key variables which actually drive cardiometabolic disorders, blood pressure, waist, triglyceride and HDL, and most common effects were gastrointestinal as such. Now let's look at Surmount 5, which came in just a few months back in May, which looks at semaglutide versus tirzepatide. It's an open label study on head-to-head trials. And GIP, we know how it works, not getting into details of this. Now, tirzepatide at the maximum tolerated doses versus semaglutide at maximum tolerated doses for people with obesity without diabetes as such. Again, phase 3B study, up titration in the similar way as it's done for Mounjaro. Even for Wegovy is the same, 0.25, 0.5, 1, 1.7 and 2.4 on the maximum tolerated doses. Primary endpoint was a percentage change in body weight from baseline to week 52. 750 patients were screened for this particular Surmount 5 program. So if you look at this particular chart, at 72 weeks at the maximum tolerated dose of Mounjaro, experience a mean percentage body weight reduction of 21.6 versus 15.4% in those taking semaglutide at the maximum tolerated doses. Again, showing that the dual creatine works better than a single creatine as such. 1 out of 3 patients taking Mounjaro achieved more than a 25% mean reduction in body weight versus 1 in 5 taking semaglutide. So significantly higher number of participants achieved weight reductions on Mounjaro versus those on semaglutide as such. If you look at waist circumference, there was a waist circumference change of 20 centimeters, which shows that the visceral fat is going down. And if you look at the change of waist circumference between tirzepatide and semaglutide, there's a 5.4 centimeter difference. And data suggests that 5 centimeter increase in waist circumference increases vascular mortality by 7% in men and 9% in women. So apart from the weight loss, there is a reduction in visceral fat, which is very, very clearly seen. In terms of adverse events, similar as the effects are similar as such, whether it's a dual cretin or a single cretin. It's usually the upper GI, and diarrhea is usually the most common side effects as such. Adverse reactions also similar as such. So in summary, tirzepatide demonstrated a superior weight reduction versus injectable semaglutide at the maximum tolerated doses, 21.6 versus 15.4. Most common adverse events are gastrointestinal in nature and was mostly mild to moderate. Tirzepatide, having said that, does not have a cardiovascular outcome study in people with obesity. It has a cardiovascular outcome study in people with diabetes, which is still not published, but it has been presented. Semaglutide has got outcome studies in people with diabetes and people with obesity without diabetes. So we will still look at the SURMOUNT MMO, which is the cardiovascular outcome trial in obesity, which should be coming out in 2027. Thank you all for a patient hearing. Any questions from the house, please?
Hello. Wonderful presentation, sir. Congratulate. And any question from the house? Any related complication that is to be monitored during tirzepatide therapy?
So related contraindication, if you have had pancreatitis before, or if you have a pancreatic lesion, do not use it. If you have a family history of thyroid cancer, which is medullary cancer, which is very, very rare in India, apart from that, nothing really. If you have acute gallstone disease, do not. Symptomatic gallstone disease, don't.
Sir, if there is so much of rapid weight loss is there with the tirzepatide, then chances of sarcopenia are also too high.
Yes, sir. So sarcopenia has not yet been addressed by any of the agents. Yeah. We will take another 5 years for a drug to come for sarcopenia, which is called bimagrumab. Yes. It is being investigated with semaglutide. Its combination with tirzepatide has been withdrawn. So right now we don't have any treatment for sarcopenia other than functional core training and high protein diet. But any weight loss will give you muscle loss, and the studies on, I think it's SURMOUNT 3, where they have evaluated with the help of MR, and they have shown that there's a 10.8% fat-free mass loss with tirzepatide also. So there is, if you are losing 10 kilos, you lose 1 kilo of muscle mass also. That is
so with this drug, we should at least advise our patients also for some resistant exercises.
Absolutely.
Rather than just going for walk and all.
Completely
we
agree.
should do some endurance and resistant exercises.
Completely. Absolutely right.
To build a muscle mass.
Absolutely.
Very important point raised by Gupta sir. Thank you.
Was there any subset of patients who had used this Mounjaro or tirzepatide, having past history of pancreatitis, and now they are recovered from pancreatitis? Was there any subset and used in that?
So pancreatitis per se was an exclusion criteria. And if you look at adverse events of pancreatitis, it has been similar between both the groups per se. But pancreatitis and proliferative diabetic retinopathy were two exclusion criteria for the SURMOUNT program as such.
One physician came and she had an incidence of thyrotoxicosis in his patient. So are there any reports of thyrotoxicosis after Mounjaro? No.
It's a coincidence, I would say. Absolutely.
Yeah.
Medical coincidence.
So how, maximum weight loss, how much you have seen in your patients?
Up to 35 kilograms when the BMI is more than 35.
Any other indication of Mounjaro besides diabetes and the obesity, like in MASH, the fatty livers, like in the aortic valve replacement by the TAVI and the post PCI, they are using it in New England Journal says that it is giving the good results.
I think it's a very good question. MASH per se, they have a phase 2 study called Synergy NASH. They have not gone into a phase 3 program with tirzepatide. They are following tirzepatide, the triple agonist for the MASH indication. And everything which works through the glucagon has better activity on the liver. So survodutide will be the first drug which will have MASH indication per se. So having said that, there will be reduction in your fat. Any 5% weight loss is equivalent to 50% weight loss from the liver. So there will be better, but they do not have histologically proven phase 3 study as there is with semaglutide and the SN study, which is histologically biopsy proven studies on that. And as far as the heart goes, there is the select and the sustain clearly shows that cardiovascular events go down. Now in heart failure with preserved ejection fraction also Wegovy has data. Whether it's the epicardial fat also goes down, that is the hypothesis. Probably epicardial fat goes down and you pump better. But the hypothesis or the mechanistic advantages of these drugs are still under review, both these drugs. So they don't have any value. Real world studies on cardiovascular, there are, but you have, I believe, steer with semaglutide, but I think when you have a randomized control CVOT, why should we look at real world CVOT? Thank you. Thank you so much.
Excellent talk on tirzepatide. 1 minute. Rajiv, we will have a
I request our dear chairperson on the stage. A huge round of applause, please. Thank you so much. I request our next chairperson, Dr. Akhilesh Pratap Singh sir, Dr. Deepak Behrani sir, and Dr. Sheikh Nabil sir from Bangladesh. I also request our lovely speaker, Dr. Rajesh Agrawal sir from Indore, who will be speaking on our next topic, pre-diabetes to be treated or not. I request our chairperson to introduce our speaker.
I think I should continue. So Jai Hind everyone, and at the outset I must thank Dr. Ashish Dengra for inviting me, and not only Ashish Dengra but the NDID team for inviting me on this August gathering. Today we are talking about a very important topic. We all know that diabetes is increasing like anything, and obesity is the precursor for diabetes. So there is a global scenario from obesity, overweight, obesity to dysglycemia to pre-diabetes to diabetes, and whether we should act on the pre-diabetic. That is the topic of today. This is a debatable issue. So what is pre-diabetes? Prediabetes is a bridge between normoglycemia and hyperglycemia, characterized by higher than normal blood glucose but less than diagnostic criteria for type 2 diabetes. This, we have to remember this. Pre-diabetic range, that is fasting 100 to 125, post glucose is 140 to 199, and A1C 5.7 to 6.4. Less than that are normal, more than that are diabetics. So these are the values which these are ADA criteria. We have certain other criteria by other organizations which we will discuss in next few slides. So before going further, there are two cases of pre-diabetes. Red case is 42-year male with family history of diabetes, coronary artery disease, hypertension, obese, BMI is 33, acanthosis, lethargic, dysglycemia, and A1C is 6.3. Green case is 42-year male, no family history of diabetes, coronary artery disease, hypertension, BMI is 23, almost normal weight, no acanthosis, no complaints. A1C is 5.9 and little dysglycemia. We all are talking about ADA criteria. So I just want to ask you, how many of you want to treat red case, that is with family history of diabetes, A1C 6.3? Please raise your hands. We will see how scenario will change after the talk. If you want. And how many of you, chairperson can note how many are ready to treat our green red case, and how many doctors can want to treat green case. So this is the prevalence of diabetes, and alarming figure is central obesity and generalized obesity. Almost 600 million patients are having generalized obesity plus central obesity. And we know this is the reason for insulin resistance, and these are potential diabetics or future diabetics. So this is huge burden. So should we act on this or not? We will see. And we are aware of the fact that as BMI increases, as obesity increases, dysglycemia increases, so also here the number of pre-diabetes patients increases as the BMI is increasing. This is the natural history of diabetes, and we all know, sorry, these are fast moving. That before diagnosis of diabetes, almost 5 to 7 or 10 years have passed, and this is the time, this is the window period where you can reverse diabetes. What we are talking about now, reversal of diabetes or remission of diabetes or complete cure of diabetes, all this is possible in this window period of starting of insulin resistance to diagnosis of type 2 diabetes. Why these are moving fast? So this is the study of, I'm sorry, there is some, this is the study of 72,000 patients who are having, who are pre-diabetes and followed up for 2 years. And there is, this was done to study timeline to develop diabetes, and 35% patients had developed diabetes at 1 year and 60% at 2 years. And you can see that we Asians are, after Paima Indians, are most vulnerable to develop or convert pre-diabetes to diabetes. Why this is moving fast? I don't know. So why this is happening? Moving slides are moving fast. So this is review of 7,000 publications for pre-diabetes, and prevalence was found to be highest amongst the high-income countries. But the relative growth is found to be highest in low-income countries. So rural population and rural population of our country is also developing diabetes. We are seeing now even children and rural, those who are hard workers, they are developing diabetes. I don't know what is going on. So pre-diabetes is a risk factor for cardiovascular disease, dyslipidemia, hypertension, and once about the
you have to bear, I don't know what is happening. So, I am sorry for this techno problem. So we are more vulnerable to get converted into pre-diabetes to diabetes, and this is same happening. कैसे बनता है? परमानेंट बंद करता है? स्लाइड मोड पे कुछ गड़बड़ है क्या? राइट क्लिक. I don't know. So anyway, I will discuss everything. बीच में आपको slides दिखेंगी. So 72,000 patients we were discussed. They were developing diabetes at 1 year, 35%, and 60% patients of pre-diabetes developed diabetes at 2 years if not done anything. Then एक बार इसको बंद करके देखते हैं. I think probably now it will be. अब नहीं होगा शायद. So this is the pre-diabetes progression. Various randomized. अब इसको यहाँ शो करो भाई. Okay. So various trials shows that there is progression of pre-diabetes to diabetes at the rate of 5 to 20%. It all depends on the various factors like age, obesity, family history, ethnicity, baseline A1C, and lifestyles. There is meta-analysis of more than 250,000 patients who were followed for 24 years, and cumulative incidence of type 2 diabetes was 31 to 41%. This is, we have seen already that we are, after PAIMA Indians, we are most vulnerable to get converted into pre-diabetes, from pre-diabetes to diabetes. This is the review of more than 7,000 publications, and it is highest pre-diabetes conversion is in high-income countries, but highest relative growth is in rural, low-income countries. So this we have already discussed. The important thing here is overall CV mortality in last 20 years has decreased from 3.5 to 2.2, but obesity-related CV mortality has increased to 3 times. From 2.2 to 6.6, you can see these blue bars. Whom to screen for pre-diabetes? Those patients who are obese, are having family history of diabetes, history of gestational diabetes mellitus, are first-degree relatives of diabetes, cardiovascular disease, hypertension, PCOD, are those who are physically inactive. They should be our patients, those who are having acanthosis nigricans. That is very evident sign of insulin resistance. They should be investigated, and patients who are having, who had gestational diabetes, they should be followed up for every 3 years for whole life. And other patients should be followed according to their risk profile.
This is rapid diagnosis of pre-diabetes is very important, and this is my paper published in IJCMD, in which what we did the A1C of attendants of the diabetes who are coming to us, and we found it very effective and early diagnosis of pre-diabetes. Risk factors for pre-diabetes: overweight, obesity, genetic predisposition, physical inactivity, unhealthy diet, and elderly age. So these two, overweight and genetic predisposition, are genetic factors, and rest of them are epigenetic factors which precipitates genetics into the practice. Why pre-diabetes to be treated? Because in pre-diabetes there is dyslipidemia, there is increased visceral adipose tissue, RAS activation is there, and dysglycemia. All this leads to the oxidative stress and inflammation, leading to insulin resistance, ultimately endothelial dysfunction, and increasing the risk of cardiovascular events. This is ASDAV study of more than 10,000 patients. As dysglycemia increases from normoglycemia to impaired glucose tolerance, all-cause mortality and CVD mortality has increased. Why pre-diabetes to be treated? This is another small study of 600 patients from China. They were divided into 4 groups: control group, diet only group, exercise only group, and diet plus exercise group. And what the results was: 51% lower incidence of diabetes during the active intervention period, and 43% lower incidence over next 20 years. The average annual incidence of diabetes was 7% for intervention group versus 11% in control group. This is the longest diabetes prevention outcome study of 30 years follow-up, which had shown that diabetes delay is prevented by 4 years, and there are fewer CV disease events, lower microvascular complications, and CV deaths. These are various diabetes prevention programs which shows that 30 to 60% of the conversion from pre-diabetes to diabetes can be prevented by lifestyle modification only. This is direct trial which has shown that those patients who has lost more than 15 kg weight, they were 86% achieved normoglycemia, and those who maintained that weight loss, they achieved 70% remain in remission for more than 2 years. Why to treat diabetes? Because pre-diabetes is a stage when diabetes reversal is possible, remission is possible, it is easier at this stage. Various medications like metformin, pioglitazone, or you can say all medications except insulin secretagogue and insulin, they are helpful in preventing conversion of pre-diabetes to diabetes. Though there is no medication has been approved by the US FDA for diabetes prevention, but ADA recommends metformin for pre-diabetes if there is history of GDM, age is less than 60 years, BMI more than 35, and pre-diabetic status, that is A1C and dysglycemia. Then weight loss medication, already we have heard about. They are also helpful in preventing the conversion of diabetes to pre-diabetes to diabetes. These are various trials with various molecules, right from metformin to acarbose, netiglinide, glargine, metformin, rosiglitazone, troglitazone, pioglitazone, all are reducing the conversion of pre-diabetes to diabetes. This is step 10 trial with semaglutide. I will not go into that details because this has already been discussed by Dr. Rajiv. The important thing is when baseline A1C pre-diabetic 66%, after the 2 years of Wegovy prescription, there was almost 50% reduction in the pre-diabetic patients. They were converted into normoglycemia. These are the weight loss, amount of weight loss with lifestyle modification. Then this is with semaglutide and this is with tirzepatide. Why pre-diabetes not to be treated? This is $1,000,000 question. We must ask ourselves, are we justified in treating pre-diabetes? Because different criteria by different organization,
overdiagnosis and over-medication and stigma of a chronic disease leads to the lot of mental stress. And here lies the problem. WHO does not consider A1C as a criteria for diagnosis of pre-diabetes. Only ADA considers, and NICE and International Expert Committee considers 6 to 6.4% A1C as the pre-diabetic range, while ADA considers it is 5.7 to 6.4. So if we can consider ADA criteria, then we overdiagnose. If we consider NICE and WHO criteria, then it is underdiagnosed. WHO also considers and NICE also considers fasting blood glucose 110 to 126 is the pre-diabetic range, while ADA considers 100 to 125 is the pre-diabetic range. So this is the debatable issues, different criteria by different guidelines, and we are, this you can understand then in Asians, impaired fasting glucose is 29% by WHO criteria, which increased to 48% by ADA criteria. And in Caucasians, it is 43% by WHO criteria and 58% by ADA criteria. Why prediabetes should not be treated? Another question. Our treat to target levels for diabetes are A1C of less than 7 or 7 and ESD criteria less than 6.5, which are well above the diagnostic criteria for prediabetes. So should we treat or not treat? You have to decide. The person who are not to be treated with prediabetes, those who are stable in prediabetic range and without associated comorbidities, like he is normal weight, he is not having any dyslipidemia or family history or CV disease. So message is prediabetes is more prevalent than diabetes. Conversion rate to diabetes varies from 5 to 20%. CV disease and mortality are higher amongst untreated prediabetes. Rapid and early diagnosis is very important. You should ask yourself, are we justified in treating prediabetes because of stigma of chronic disease and overdiagnosis and over-medication? Now coming back to these questions, these cases, I would like to treat this red one, but not to green one. We should follow this green case regularly, and if he progresses to dysglycemia, to diabetic hyperglycemia, then we should treat, otherwise we should prevent it. And this, my article has been accepted in Journal of Association of Physicians of India. Next issue it will be visible there. Thank you very much. Thanks, Ashish. I am sorry for all techno problems, but it was not in my hand.
It was from our side, not from your side. आइए, chairperson. डायबिटीज को ट्रीट करना है कि नहीं करना है, कौन सी वाली जो प्रारंभिक अवस्था में है, प्री डायबिटीज. तो प्री डायबिटीज के बारे में आपने बहुत अच्छी जानकारी जानी, क्योंकि हम अगर यहाँ पे ग्लूकोज पिलाएंगे, ये जो 100 लोग अगर बैठे हैं इस हॉल में, तो 35 से 40% लोगों का पॉजिटिव आएगा प्री डायबिटीज. तो सोच लीजिए कि आपको आज से ही एक्सरसाइज और डाइट का फॉलो अप करना है, दवाई से दूर रहिए. आइए सर. Yeah.
If you can have a poll, then almost 50% of the persons will be pre-diabetic. Whether because of family history, whether because of their abdominal obesity, whether because of lifestyle.
Thank you. Sir.
A huge round of applause, please.
Clap, clap. दो बेटा. सर को दो.
Thank you so much. Moving on to our next session, I request our chairperson, Dr. Kusum Solanki ma'am, Dr. Rakesh Pathak sir,
इंटरनेट है ना सर, कनेक्ट करवा देता हूँ.
Dr. P.N. Gupta sir,
गुप्ता सर, हाँ आप ही का नाम.
as we move on to such an informative, as we move on to another informative topic, how to prepare PowerPoint presentation by AI for doctor by our lovely speaker Dr. Alok Modi sir from Mumbai. I also request our chairperson to introduce our speaker please.
Hello. Hello. Good afternoon, everyone. We are going to present Dr. Alok Modi, which is a very renowned diabetologist from the Mumbai. And I can't read out because there's very small print there. बहुत छोटा है. So, Dr. Alok Modi is a very renowned diabetologist. I'm sure that all of us, we are going to be okay. So, Dr. Modi, you are most welcome and you can start your presentation.
So good afternoon, everybody. At the outset, I would like to thank Ashish, my dear friend. He asked me to take this different topic, and this is primarily meant for people who are into, who come as faculty and who keep making PowerPoints, and you are very active in presentations. So normally, I'll keep this talk like I normally do. Rather than keep a presentation, I'll keep a live demo so it will make sense to everybody. But before I start, I'd like to ask people in the audience, how many of you actually make PowerPoints on your own? Seriously?
Sir, actually you are teaching us. You are all you are teaching us how to prepare. It's a very
I know, but then if you are not into making PowerPoint. So, but let me know how many of you have actually started making on your own. So only, I think 5 or 6 hands were there. So normally the next question is, if you're making your PowerPoint, how much time do you normally take to make a PowerPoint? 1 day? Then this talk is not relevant for you. But on an average, how much time would you take? How much? Almost a day. So I'll tell you my history. My friends call me up, and I got 2 calls today also. So sometime when I'm in for a conference, I'm going to give a talk. I get a call from my colleagues who say, I want a PowerPoint on this. Actually, you can make it in less than 5 minutes from AI. And the quality of the PowerPoint and the content of the PowerPoint could be much better. Max 15 minutes, you can make a wonderful PowerPoint, which would, trust me, be a very good quality. And what you're seeing right now are, in fact, all my PowerPoints are made through AI. And this is a PowerPoint made through AI itself. So the question is, how do you use it? So I'll give you live demos of how to do it, and that will help you. There are multiple methods by which you can do it. How you customize it and how you do it is entirely your hand. So you can see the quality of the PowerPoint that is coming in, and I'm sure you can't generate such kind of images and impactful 3D figures, and the kind of graphics that you see is very difficult to generate manually on your own. But why do you need AI? Obviously the speed is there, but more than that, the AI has got something called as agentic AI. If you know what is agentic AI, these are agents which do your work from A to Z. Agents should be considered like secretaries. So if you have a secretary, she will take care of your, she'll remind you that you need to have your breakfast, she'll remind you that you need to take your medicines, she'll remind you that you have your appointment, she'll tell you that you need to fill petrol or diesel in your car. So she takes care of your entire office thing from A to Z rather than just look after the business angle. So agentic AIs will take care of your graphics, your presentations, your content, and everything will be done totally and completely by AI. So that is the advantage. You can have a design which is much, much superior than you would be able to do it. Now see, you're not a graphic designer. Either you pay 10,000, 15,000 rupees and get a graphics designer to do your graphics and make a story which looks colorful and attractive, which is very expensive, not practical to do it every time. And the content that you have, it will spend, you might take 15 minutes or a day to make a PowerPoint, but to get the real content into what you're going to talk, sometimes takes weeks or days to find out, do your research and get your research papers and get your data. Ultimately, you're presenting data. Getting the data is a very time consuming thing. If you want to do justice to your presentation, AI can extract that data beautifully in less than 5 minutes for you. So you become efficient, you can engage, and you can become an effective presenter. Now the purpose of PowerPoint is basically it's like a Hindi movie. It's a storytelling thing. You need to grab your audience. So if I'm not able to grab your attention right now, as I can see I'm failing in that work right now. So if I'm not able to grab your attention, then there is no point getting a good PowerPoint. A PowerPoint, actually, I always say it's an extension of the personality of the presenter. Your own thoughts and your own processes about a particular topic. Now suppose I were to give a talk on tirzepatide, like what Dr. Rajiv gave and what you would give will be very different. I would be talking about my experience with tirzepatide, you would be talking about your experience. What's important is what you talk about your experience, because all of us are capable of reading the journals and finding out what tirzepatide is all about. So it gives you visual consistency, it gives you optimization of the layout, it gives you a hierarchy. As you can see over here, the kind of hierarchy in the visualists that you get is very difficult to design on your own. The content, the format, the way the matter has to make sense would make a lot of difference. So I was talking to one of my patients who's a director in Bollywood, and I said, how do you make successful movies? He said, it's very simple. You can always put in an item song, you can put in a rape scene, you can put in a music thing. Ultimately what happens is when you put in a murder or a very negative thing, audience doesn't like it, and if you end the movie there, movie never becomes a hit. You have to show a hero who comes out and salvages the whole situation, does some honky donkey, jumps on 30 floors, but saves the heroine and comes out and audience gets up clapping. So your PowerPoint is full of utterly boring statistics. Tirzepatide reduced liver fat by 23%, weight by 15%, reduce this by 10, reduce sugar by this. Nobody is interested in listening to those figures. But when tirzepatide comes out and glows up and shrinks a huge liver into a small liver, and there is a lot of explosion, you know, people start up and start looking into it. So that is PowerPoint. Otherwise, you can just rattle out the statistics sitting on the mic. So how do you give impression and imaging to statistics and to data is what PowerPoint is all about, and that can be done very beautifully with AI. And you can make it personalized. You know, my PowerPoints talk my story through my AI, your PowerPoint will talk your story through your AI. So now I won't waste a lot of your time. I'll show you multiple methods by which you can do it. Now this will be live videos, which I have not net ka issue, so I'll show you some videos here. The most common AI that everybody is comfortable with is, what AI tool do all of you use very most often? ChatGPT. I'll show you how ChatGPT can make PowerPoint. So just see this video here. Now I'm making a, since we are all diabetologists here, so I'm going to make a PowerPoint on how to approach proteinuria in diabetes or diabetes kidney disease. So I gave that command. It started giving me the highlights, what all it will make. So it's, as you can see, it started making the slides. It's making some 25 slides. All the content is there in front of you. The heading of the slides is there. It started writing what it is. Now this is the code. This is Python on which any AI works. It's a different kind of a code. So it's working on that. Now it's writing its own code, and it will generate the PowerPoint and show you. Now there is a difference here. If you are going to use a free version, you're not going to get the PowerPoint. If you're using the paid version or the pro version, you will get a Taiyar PowerPoint. If you're using a free version, this is all you'll get. You have to copy paste into PowerPoint and make your own slides. No money, no honey. Correct? So this is the honey that you will get. You'll get the PowerPoint ready. So now the PowerPoint is there. It's telling me to download it. I downloaded it. The PowerPoint is opening in front of you. You can see the PowerPoint. Definitely this is not a PowerPoint that you can get in any conference and present it to the audience. It won't look good. The matter is there, but these are very dull and boring slides. Now there is another factor in PowerPoint. Now everything is AI enabled. You guys are AI enabled, I am AI enabled. And unless we are AI enabled, we can't survive today. So there is AI inside PowerPoint, which very few people know. Now it is Christian Desk Copilot. That's the AI of Microsoft. It sees the context and starts changing the images. You see the magic happening here? See how beautifully the slides are looking now? See, it's talking of risk factors, talking of duration of diabetes. See the hourglass, all this has come on its own. See, the slides which were not worth presenting are changing their are getting metamorphosized, and these are the slides you can actually walk into an international conference and present, and I've done it. Just with one Copilot and ChatGPT, I create stunning slides which are worth presenting with a lot of matter. What content you put is something ChatGPT is not very good at because it is a generic LLM. Now I'm throwing two words here, generic and LLM. LLM means large language model and generic means it's general. Generic is like a general practitioner. He treats all diseases, but he's not a specialist of one disease. So ChatGPT cannot give you content which is specific to your disease. It will give you generalized content based on all internet searches, and it will do a lot of confabulations. It will give you wrong information. So if you want your PowerPoint, your data has to be borne by you. That is your responsibility. Put that data, get it colored through Copilot and ChatGPT, and you get a fantastic PowerPoint. How much time does all it take? 10 minutes. See in front of you, very easy, very simple. Let me show you another method. The next method is the method which I love, which is called as a tech method or the nerdy method. Now in this method, I will talk to ChatGPT and make it change its work the way I want. So it's creating the same PowerPoint. Now Microsoft Office runs on something coding called as VBA, Visual Basic for Applications. So I am asking it to make the code in VBA. I take that code, now see it's writing the code. As you can see, it's writing the code over here. After the code is written, this is the code which it has written. I copy this code, I go to PowerPoint, a blank slide directly, I open up a blank generic presentation. I go into in every Office application, there is a developer tab, if you have taken pains to see. In that developer tab, you need to open up a coding window called as a module. So you open up the module, and once you open up the module over there, you can see that you can paste the code over there. So I'm pasting the code over there. As you can see over here, this is the module. This is the module which I've opened up. I'm directly pasting the code. Now the code was generated by ChatGPT. I have zero knowledge of coding. Current AI tools, AI engineers don't learn coding. The beauty of AI is you don't need to learn coding. So this is all no code method. So this is the code, it is put in, and you click yes, and the PowerPoint is ready in front of you. Now you'll ask me why you do all this nonsense, why go behind, naak ko ulta kyun pakad rahe ho? Because in the code I can manipulate the code and change what I want, provided I know coding. So I said this is a nerdic method that is meant for engineer, people who are good in writing software like me, and you can change a lot of things. See, you can see how beautiful the presentation has started taking shape. So this is the second method. Now the third method, which I love, which I use a lot, and a lot of people at national level, and Ashish knows that, have got trained by me and they've started using this method. Now what is that method? I'll tell you what that method is. So now we have done our MBBS, right? We are all very good in treating appendicitis, we are good in doing deliveries, we are good in treating diabetes, blood pressure, but I'm sure I cannot do a good job of doing a delivery like madam would do, because she's a gynec, she's a specialist, I'm not a gynec. So I cannot do that kind of wonderful work that she would have done. So because she's a specialist. So generic AIs will do a very good job, but AI which is specific for PowerPoint will do a much more fantastic job. So that there are multiple tools. One such tool is Gamma. So I'll show you what Gamma does. So if you can head on to Gamma, get your license. These are my presentations. I have more than 3,000 presentations on Gamma. So I create a huge chunk of presentations for all my work, and this presentation which you're seeing is from Gamma only. So you can either give a code, you can give a command, a prompt, or you can upload a PDF file or a PowerPoint or a website, and you can ask Gamma to read that and convert it to PowerPoint, or you can sort of give a mixture of multiple prompts here. Data fields like Excel, and that can be converted. Or very simple, you can directly give the hyperlink, the URL, the link address, and that can be converted to PowerPoint. So I'm doing the same thing here. I'm doing a 10-slide PowerPoint on diabetic kidney disease, which is the same example I'm showing you. Again, everything, no money, no honey. So this comes because you're giving, if you have a license of Gamma, you can create a presentation of 80 to 70 slides. If you do not have a license, you will get only 10 slides. So what people like us do is very smart. If you want to be, we are Indians, you know. So जुगाड़ हर जगह रहता है. So if you don't want to buy, don't buy. 10 slide बनाओ, वापस दूसरा topic देके 10 बनाओ, वापस तीसरा देके 10 बनाओ, make 80 slides and your job is done. You can do that also. If you don't want to do that hassle, then pay for Gamma and get it done. But payment gives you a lot of options. So see, you can choose the kind of images you have, you can choose the kind of language you would use, you can choose the theme that you would like to have. And when you do that, This is how the themes are there. It is letting you choose the theme. You do that and you see how the slide formation starts. Now having done that, as you can see over here, we're creating the same slide. Now this is actually going on in the video. So you can see the magic happening. It has started creating the content and the matter on its own. And you can see the kind of presentation coming out. Don't you think this is the much than ChatGPT would give? 5 minutes, your presentation is done. I create presentations of international level of 80 to 70 slides, literally sitting on the lounge in the airport, and my presentation is done. So when I'm going to RSSDI now, the national conference, I've got some 3 talks. I don't have a single presentation ready, and they're complicated talks, and trust me, I will be creating it at 5 o'clock in the morning in the lounge, and my work will be done. Now there is a caveat here. You'll ask me, the content has to be authentic and good. Now that if you're going to copy paste from a journal, it's going to waste a lot of time. That is a feature of these tools. They pull up the content from various, so you can pull up 5-6 articles which you would like to talk about. Let's say tirzepatide, which Dr. Rajiv spoke about. You can use ChatGPT to write a review article on those 5 articles, create a PDF out of it, takes hardly 5 minutes, put that PDF over here and create your entire presentation on the latest on tirzepatide. Very simple, very nice. You can bring it here, your job is done. And the quality presentation is there which you can take forward. Now this is not the only game in the whole picture. There is something called as Tome. I'll go fast, I don't have much time. There is something called as Tome. There is something called as Beautiful AI. There's something called as Dectopus. So I'll show you that. Just give me a minute here. So I hope you can. So this is one thing called as Beautiful AI. This is called Dectopus. These are also wonderful dedicated AI tools through, PowerPoint tools through AI. I use them. What I do is I use 6 AI tools like this, ask the topic to be created by 6 different people, collect the slides and come out with what I need. So it's like I'm the head of the Department of Medicine. I've got 6 lecturers and 6 registrars under me. I ask all of them to do my work. I collect data from all of them. I submit my paper. Very simple. How you mix and match. Now the real beauty lies in not using AI. The real beauty lies in modifying AI to talk to AI to work as per your needs. That is called prompt engineering. This is very important. AI is one of the most brilliant medical registrar or lecturer you have. So if this case is a case of mitral regurgitation or mitral stenosis, or is it a mixed lesion MR with MS, you will get confused if you do not have an echo finding, but a brilliant medical guy can pick it up. A brilliant person can say it is dengue when there is no dengue report positive. But how do you churn that fellow to come out with a diagnosis is in your hands. So how you prompt AI is where the whole game lies. So AI can give you all kind of wrong answers, but if you do the right prompting, you will get the right answer. That is called prompt engineering. Learning prompt engineering is very important. And can you tell, I'll give you an example. When I was giving my Massachusetts exam, and I've cleared the American board exam for AI, for medical practitioners. I was asked to create a scenario for Ola and Uber, where they would get maximum business. The data they gave me was how many cars ply on which days, maximum traffic, which customers are more loyal, when there is more monsoon, which roads are more traffic free, which roads have got more traffic. All the data I had to compile and design a system for that company so that they can get maximum business advantage. So the data is there. How do I churn the data through AI is where my skill lies, and I would clear the exam or fail the exam. That is called as a business analyst through AI, and companies are employing these people. And do you know how much they're getting paid per month? Any guesses? If you're an AI business analyst, how much are you getting paid per month? 15 lakhs to 20 lakhs per month. Yes, so think if you want to continue as a doctor or not. It can make a difference to the revenue of the company. They're making billions of dollars because of these people. That is where the whole skill lies. So you can write research papers, you can create PowerPoint through AI, provided you know how to write the right prompt. So I'll just give you a live example here because that is not my topic for today. I'll just show you what I mean and then we'll close the talk for today. So this is one example which I showed about PowerPoint. Okay, now this is called biostatistics. Rather than go to a statistician, I do my journal, I do my paper live statistical analysis of a very different level live through AI. And I'm not talking through my hat. I'm also publishing papers through AI, which is what you can do now. This is one of the latest paper. It has just got published last week. I'm the primary author. This is another paper that I published few months back in an international journal. This is what we had this presentation today, right? Vitul sir, right? And this is my chapter in that book, again written through AI. This is a very recent publication. Anuj sir is the first author. Paper was written by me, Tropical Diabetes or Type 5. The entire paper in the international journal was written by me. This is the paper which has just got published 2 or 3 days back in International Journal of Diabetes and Technology, where I've spoken about quantum computing influencing artificial intelligence in healthcare. And this is another paper which has got published 3 days back, where I've compared all the generic GPTs through different statistics, and I've found out which GPT or Grok or Perplexity or Claude, which is good for what work in medical practice. So this paper analyzes that in detail. All those papers have been accepted well through proper processes, written by AI and acknowledged by AI, but you have to be ethical. You can't copy paste. You have to follow the guidelines when you're writing a normal paper. I'll give you a very simple example. Like again, I'm head of the department. I've got 3 lecturers and 5 registrars. I don't think all of us have that luxury. So when I'm writing a 10,000 patients data from my OPD for the last 2 years or something, or when I'm doing a study for HbA1c or blood pressure at a national level, having data of 2 lakh patients in a registry, then these people will be doing the churning of the data, the statistician will be doing, they will be writing sections of my paper. I will be the first author since I'm head of the department, and will publish the paper with all of us as co-authors. But am I doing the whole work? No, everybody is working. But I get the maximum credit because I'm head of the department. So suppose I combine all of them into one AI tool, which does the entire work, then I'm getting this paper. The only difference is when those people are working, I am taking credit because they are qualified medical practitioners who are writing it. This is also a qualified medical practitioner who has been trained to write the paper in an authentic, non-plagiarism, non-AI language way. That is where the prompt lies. So the prompt, now this is why these papers are being written, is because I've created my own 3-page prompt after 6 months of hard work. And my papers do not have plagiarism, do not have AI language. They talk very beautifully human language. I finally edit them before I send them for publication, and they are getting accepted. And let me tell you, I'm reviewing a lot of papers in a lot of international journals. Most of the papers today, biostatistics and quality of paperwork is being done through AI in an ethical manner, and that is where the future lies. You cannot keep writing an original study over 6 months. The amount of research is booming up in a huge way because of rapidity, because of AI. So this is just to sort of stimulate you people, seduce you people to understand that PowerPoint and biostatistics and research work can be done through AI in a very dignified, in a very ethical, in a very fast manner. And that is where the whole world is going. That is where the future is. So think about it. If you people are comfortable, that is where the whole game lies. But the whole game lies in prompt engineering. How you write the prompt, what kind of prompt you give, how do you needle that AI to give you the right answers is where the whole game lies. You have to learn prompt engineering. It's a game by itself. If you learn it, you can really put them to a good advantage and get the real mileage that you would like to. So I'll close over here. If there's any question, I'm ready to take. Thank you very much.
Thank you.
So, excellent masterly talk given by Dr. Alok Modi about the use of AI. Sir, actually you have taught us how to write and how to go about it. House is open for any doubts, because many of them will be having doubts regarding how to present and how to write an article.
तो आलोक का नंबर डिस्प्ले कर दो. Alok will make PowerPoint for everyone, 500 rupees each.
If I may have the opportunity, we are running 3 workshops for International Journal of Diabetes in Developing Countries. I'm one of the reviewers over there, and I'm in charge of one workshop where we are covering how to do ethical research, presentation, how to analyze and publish. We are running a full 3-hour workshop in the National Conference of RSSDI. So those of you are attending, please attend it there. We would be taking a detailed workshop from A to Z over 3 hours.
So we will do the memento exchange. You have done justice to the conference. टाइटल सर मैडम सर को दीजिए
आइए
With a round of applause, please.
चेयरपर्सन को सर से ले गिव टू वन मैन
राइट सर एब्सोल्युटली मैडम देंगे ना आप दीजिए
A huge round of applause, please.
थैंक यू सर थैंक यू वेरी मच My daughter has taken admission in NDID.
नेक्स्ट सर एक अपन अवार्ड जो लकी ड्रॉ निकाल रहे थे हर घंटे में वो भूल गए थे आइए इधर आलोक भाई आप एक पहला लकी ड्रॉ निकालिए किसका नाम आ रहा है मैडम
सुनील सर को बुलाइए सुनील सर को बुलाइए
सुनील सर कहाँ गए सुनील सर तो बाजू में ही बैठ खड़े हैं
सर
आइए लकी ड्रॉ निकालना है आपको भी एक तो मैडम ने निकाल दिया नाम पढ़िए ना आप खोल के एक सर ने निकाल दिया रजिस्ट्रेशन नंबर 40 अरे लिस्ट तो ले आओ भाई वहां से काउंटर से लिस्ट ले आओ
लकी 7
तो 2 नंबर निकले हैं तो नाम बता रहे हैं वहां से लिस्ट की फोटो खींच के लाओ 40 and 7 हर घंटे लकी ड्रॉ निकलेगा
Moving on to our next session, I request our chairperson, Dr. Mohan Lalwani sir, Dr. Suresh Patel sir, Dr. Priyanka Kukreli ma'am, and Dr. Tarun Nagpal sir to take a seat. Our next speaker, Dr. Sunil Gupta sir from Nagpur, who will be talking on our next topic, how to treat newly diagnosed type 2 diabetes.
No.
Rational, simple, algorithmic approach.
Topic has been changed.
Good morning, everyone. So I would like to give a brief introduction of Dr. Sunil Gupta, sir. Most of the people in endocrine field must be knowing the sir's efforts towards gestational diabetes and DIPSI guidelines. So sir is MD, FA, FACE, FRCP London, Glasgow, Edinburgh. And he's diabetologist. He's mainly in charge of Sunil's Diabetes Care and Research Center Private Limited, Nagpur. He's National President-elect RSSDI 2026. A big round of applause for you, sir. Congratulations for that. And he has 27 orations under his name, many awards. He has excellence in so many fields and many research papers and book chapters, abstract presentation, and conducted total 3,335 programs in last 31 years, and is doing great work for our patients in field of diabetes. Welcome to you, sir.
Thank you very much.
So I want to announce one thing, that this is Dr. B.N. Shrivastava sir oration. CV lagao. So Dr. B.N. Shrivastava sir was a teachers of teachers. Everybody knows that उन्होंने diabetes की practice तब चालू करी थी कि जब कोई D भी नहीं जानता था diabetes का. And he was practicing only diabetes since the days of the medical field when there was only physicians. So he has chosen the field of diabetology in the era of 80s. So it is a very great honor for NDID to present the Dr. B.N. Shrivastava sir oration. चालू करो ना. सर आप बोलिएगा ना.
हाँ
हो गया. जय जलो.
I have met Dr. B.N. Shrivastava sir couple of times few years back, and he is a wonderful human being and a wonderful teacher, and always very much interested in academics. And he has done his MBBS and MD from Agra City. I was also having the recipient of Rockefeller Fellowship Program 1956, long back, and I was not born. And he is member of various organizations, including very active in API. Can I go back to my slide?
D.S. Chaudhary sir was his colleague, and he want to
Yes,
tell
sir.
him about
Sir, please go ahead.
I want to tell something about the Dr. B.N. Shrivastava sir. He was my guide, and he was a dean. When I was doing the MD, he was dean, professor HOD of the at Medical College Jabalpur. At that time, he was elected as the president of the Diabetic Association of India.
Sir, yes, sir.
Thank you.
Thank you very
Over
much.
to you, sir.
So it's always an honor to deliver an oration on a name of a person who has done pioneering work in diabetology in this part of the country. So thank you very much, and Ashish, I'm thankful to you for this honor. My today's talk is because I wanted to talk on something which is original for the oration. That's why I've changed my topic to insulin injection induced lipohypertrophy, a forgotten entity in today's clinical priorities. So thank you everyone, including Ashish and his own team, and Jigyasa and everyone. Now this is a sorry. Okay. So this is a 13-year type 1 diabetic girl, having diabetes since 7 years, coming to a clinic like ours with HbA1c 12 on the very high dose of insulin, having intermittent low sugar and high blood glucose. She was already on high dose of insulin. Just remember these cases. Another case, 11-year-old boy, diabetes since 6 years, from the age of 5, came with HbA1c 14. Blood glucose never got controlled in last 1 year. Already on 1.4 unit per kg body weight, very high dose of insulin. You can just remember these faces. There are something which is unique in this particular case. You have the laser pointer? Laser pointer hai kya? Acha. So you can appreciate the swelling on the thighs. You can appreciate this swelling on the gluteal part, one of the gluteal part, area of this boy. And this is another girl of 8 years, diabetes since 5 years, history of recurrent hospitalization despite regular insulin and medical nutrition therapy, and she has the swelling here in the buttocks. And this is a 50-year man, type 2 diabetes on basal bolus therapy, presented with this ulcer in the thighs. This is another young girl, 22-year. You can see the forearm has got the swelling here on both the sides. And she wanted to go for surgery because she was getting married in few days. So surgically to remove this, because some surgeon has diagnosed it as lipoma. One thing which was common in all these cases, none of them were examined for their insulin injection sites by any of the clinicians before they turned up to the tertiary care center. This is the unfortunate part of the practice. Everyone just sees 300, 400, okay, 12 ka 14 kar lo, 14 ka 16 kar lo, 18 ka 22 kar lo. Only insulin doses have been increased, but no one has examined the insulin injection site. Now it is a protocol that every person with type 1 diabetes or type 2 diabetes on insulin, you should examine the insulin injection site at every visit, if not at least once in 6 months, and also make them also teach that how can they examine their insulin site, and that is nothing but the lipohypertrophy, which is my topic of discussion. What is this lipohypertrophy? How common it is? Why it is being neglected? It is a topic which is a preventable topic, preventable disease or preventable complication of insulin injection. So we are going to talk on local site injection, insulin related complications. So in local site reactions of the insulin and lipohypertrophy, and we will try to see this introduction, why it is important, prevalence of lipo, evidences, our own data, and the carry home message. So common complication with any injection is pain or maybe bleeding, bruising, lipohypertrophy, contamination, infection, and dose accuracy, and ultimately the problem. This is the bleeding and bruise. I feel everyone knows that if you use this needle for multiple times, it might injure the skin. This is the needle. This is a new needle. You can appreciate the needle at the one use. You can just see the some sharpness of the needle has been affected. This is needle for twice, and this is the needle when it was used for 6 times. So, and unfortunately, when I started my practice, my teacher has taught me. I asked that how many days, and senior people will agree with me on this, that how should you teach our patient? So on insulin therapy, they said, till the needle causes pain, you should continue. Sir, if I'm wrong, please correct me. Till the needle causes pain to you, you should continue using with the same needle. That was the traditional teaching those days. But in last 2 decades, we have learned that if you use these insulin for multiple times, that will give you complications. And that is why every needle, it says it should be used only once. India being a little cost-effective economy here and there, and that's why we have a concern. That's why we say not more than 4 pricks per needle. And this is a bruit, which, so choice of the needle, let me again teach you something good. How much is the skin thickness normally? So skin thickness does not vary significantly with age, gender, BMI, or ethnicity. You presume that some child who is coming to you at the 5 years of age versus you at 50 years of age, the skin thickness will not change. What changes in the subcutaneous layer. तो वो जो हम बोलते हैं ना मोटी चमड़ी का है वो गलत है, मोटी चमड़ी वाला dialogue is wrong. So skin thickness uniformly it is around 2.2 millimeter. Variation the skin thickness is not clinically significant. There is no medical reason to recommend the needle which is more than 4 or 6 millimeter in length. Shorter the needle, better is the outcome. And this is the epidermis and dermis, 2.2 millimeter. Then you have subcutaneous tissue, and this is the thick subcutaneous layer, and this is a thin subcutaneous layer. But when you give the injection, it goes in the subcutaneous space if it is more than 2.2 millimeter. So recommendation is for children and adolescent 4, 5 and 6 millimeter needle should be used. For adult 4, 5, 6 millimeter needle can be used. What about pregnancy? There is no during pregnancy there is always a concern about using various whether insulin should be used, whether we should use abdomen as a site for insulin injection. So you have to teach that in first and the second trimester they can use it in the abdomen. Third trimester if they want they can shift it to the thighs. Lipodystrophy is a local reaction of the impure form of insulin to the subcutaneous fat, but that was seen when we had impure insulin, we had porcine insulin, we had bovine insulin, very early days of practice, 20 years, 30 years back, when in 80s it was available up to 90s. Then we did not, we all have now using human insulin and analogs. So chances of having lipoatrophy is not there because it was more of an immunological reaction of the insulin antibodies at the local level. So now you have lipohypertrophy, which is a topic here. It is a soft or a firm raised swelling in the rubbery consistency which appear on the surface of the skin at the site of insulin injection, which can't be pinched together. It is usually reported because of the reuse of the needle at the same site. So poor rotation practice is the reason, longer duration of the therapy, reusing of the needle, and lack of the insulin injection rotation site. And if you see the prevalence, I request all of you to please focus on this. This is very important. The prevalence of lipohypertrophy, various countries, Spain, China, Italy, and the global data says around 40 to 50 and 60%. So it is very high. And the reason is reuse of the needle, incorrect rotation, and larger duration of the insulin therapy. But what does it cause? Even if you are taking insulin at the lipo site, repeated needle use at the same site, what are the consequences? So you have higher HbA1c around 0.55%, 10 units higher insulin use versus actual requirement, higher rate of unexplained hypoglycemia, glycemic variability, and more frequent diabetic ketoacidosis. One of the girl which I've shown you, who had in the buttocks, she got admitted with diabetic ketoacidosis, and she was getting admitted practically every 6-8 months in the local area because of ketosis, and no clinician has seen the site. So I feel that is the unfortunate part. So glycemic variability, almost 50% unexplained hypoglycemia, 40%, 20%, 25% higher insulin doses. Higher is the number of use of the needle, higher is the risk of lipohypertrophy. If you are using needle more than 6 times, almost 85% chances that you will develop lipohypertrophy. So I'll just skip few of the slides. Insulin injection site should be examined every 3 months. It is easier to palpate lipo than to see it, so you should teach your patient to palpate it. Put some ECG gel or some kind of lubricating gel can be used to facilitate the palpation, and patient should be taught to inspect the site like this. And switching injection from lipo to normal, whenever you switch the injection, when you take insulin at the same site, at the lipo site, swelling wala site, the site is painless, and that's why patient goes on taking in the same site, because it does not cause pain. But there is inadequate absorption of the insulin at the lipo site, and that causes uncontrolled diabetes. But so 5 times you are taken here, 1 time you are taken to the normal site, immediately you will develop hypo. That's how it happens. So there are different grades. 0 is no changes, 1, 2, and 3, and self. So you have to see to it that you teach them for the proper rotation of the site, and reuse should be avoided. So this is our own data which we published in Vancouver, Canada, 10 years back, and we have this data of type 1 versus type 2. Type 1, it was almost 75%. Type 2, those who are on insulin, 36%, they had lipohypertrophy. Then this is very important. This is the only paper in the world which we did for the first time. Clinical implication of lipohypertrophy on people with type 1 diabetes. And what we have done is, we have seen the prevalence is almost 70%, that 70% of a type 1 diabetes had lipohypertrophy. Insulin syringe, if it is being used more than 5 times, or poor rotation of the site, causing increased glycemic variability and increased risk of hypoglycemia, unexplained hypoglycemia. This has been observed. But this is a slide which I want you to see. This is a CGM in these children. First, it's a 14 days CGM, it's continuous glucose monitoring. First 7 days they have taken insulin at the lipo site. You can appreciate it here. And the next 7 days they have taken insulin at the normal site. So you can see that there is hyperglycemia in the first 7 days with lot of glycemic variability versus smooth line here in the CGM in the next 7 days. This is the first time in the world that we have shown this, and it was accepted, this paper, in DTT journal, very prestigious journal. So important message from all this is that it can cause glycemic variability and should be avoided. So these are few of the pictures of lipohypertrophy. This is lipo in the thighs. This is another lipo in the thigh. This is in the abdomen as well as bruit and some ulcers. This is the same patient. Now this patient was never told that insulin should be taken in the thighs or abdomen, and he was taking insulin in both the forearms for almost 7-8 years, and then he came with this kind of picture. Similarly, forearm, if you see lipohypertrophy on the forearm at the same side, this is in thighs, this is again abdomen, the bruit. There are 7 golden rules for the insulin injection technique. Always inject in the healthy fatty tissue layer. 4 millimeter pen needle or 6 millimeter syringe needle is best. Don't go for longer needles and thicker needles. Abdomen, upper thighs, arm and buttock should be properly rotated. Self-injection technique should be taught. Rotate it properly. Pen and insulin syringe should ideally be used only once. If you reuse it, the chances is that it might cause lipohypertrophy. Safe disposal of the needle. The final message for this lipohypertrophy session is the prevalence is very high, almost 70% or 60% in various studies, but it remains undiagnosed due to unawareness amongst healthcare professionals, so and educators as well as the people with diabetes. So cause is needle use, poor rotation of the site and longer duration. Consequences, unexplained hypoglycemia, increased glycemic variability, increased risk of diabetic ketoacidosis. Solution is awareness about injection technique guidelines. The final answer is education, education and education. More you educate people, so start thinking about lipo. You were starting, you were, when Alok was speaking, everybody was thinking about AI. Now I'm making you think about lipo. More you think lipo, you will be able to, will not miss any single case. So with this I stop here, wishing you all to educate the society on lipo on this coming World Diabetes Day, 14th of November. Happy Tulsi Vivaha, well in advance, maybe today or tomorrow, and New Year in advance. And thank you very much for your all support for my election as a president of RSSDI.
Thank you, sir.
Sir,
अभी प्रेसिडेंट हो गए हैं इलेक्ट RSSDI, जो इंडिया की नहीं पूरे वर्ल्ड की सबसे बड़ी डायबिटीज की सोसाइटी है मेंबर्स के मामले में, उसके सर प्रेसिडेंट इलेक्ट हैं, तो बहुत जोरदार तालियां। तो सर का एक ही डायलॉग है और मूल मंत्र है पेशेंट को ठीक करने का। जैसे आपने वो विद्या बालन की मूवी में देखा होगा ना, 3 बार बोलती है, तो सर 3 बार बोलते हैं एजुकेशन, एजुकेशन और एजुकेशन। वो बोलती थी एंटरटेनमेंट, एंटरटेनमेंट। तो ये सर का जो मूल मंत्र है, पेशेंट को पहले एजुकेट करिए। जैसे ये चीज़ कैसे जाएगी? एजुकेशन से। अगर आप पहले दिन इंसुलिन चालू कर रहे हैं और रोटेशन सिखा दिया, तो ये दुर्भाग्य जो हम आज भी देख रहे हैं इंडिया में, ये नहीं देखने मिलेगा। तो ये टॉपिक सर ने, ओरिजिनल रिसर्च वर्क है सर का, तो उसके लिए जोरदार तालियां। ओरेशन आइए सर, ओरेशन में कोई क्वेश्चन नहीं होते हैं, बाद में लंच पे सर से पूछ सकते हैं आप। साइटेशन आप पढ़िए।
अच्छा, आपको पढ़ना है शायद।
I think the Dr. Sunil Gupta, the oration, Dr. B.N. Srivastava oration has been, without any doubt, a lot of justice has been done to the oration. And the number of degrees and number of achievements are too many to read. It will be another lecture, so I'll speak in short. He is MD, FACE, FRCP, London, Glasgow and Edinburgh, FACP, FICP, FIAMS, FIACM, FDI, FRSSDI. All these qualifications, I'm not aware of the full forms, and I think we'll have to have a session on that. He is National President-elect 2026 RSSDI and National President of Diabetes in Pregnancy. He is heading the study group. He headed the study group India 2021-22, National Treasurer of AARO 24 to 26. He has 27 orations to his credit, 6 international, 7 national fellowships, and 43 awards. There is a long list of his awards. He is the only diabetologist of the country to be honored with the Outstanding Young Person of the World 2022 award from USA. He has been named in Guinness Book of World Records and also the Limca Book of World Records 2016. National Foxy Excellence in Healthcare by Lokman Times, Awards of Excellence in Academics, Madhumay Ratna Award, first Global Nagpur Award, Icons of Nagpur Award, Young Achievers Award, Vidarbha Gaurav Puraskar, 10 Outstanding Young Indian Award, 6 consecutive Best National Research Paper Award by RSSDI, 236 articles, book chapters, abstract presentations in international and national journals, and lot of conferences. His batting rate is 2.1 programs per week. So the citation goes to Dr. Sunil Gupta. Very well deserved, sir.
Thank you, sir.
3 cheers for Sunil.
Sunil, yeah, hip hip!
Hooray!
Hip hip!
Hooray!
Hip hip!
Hooray!
Thank you very much.
I must say one thing. Sir has all the achievements to the level of peak Mount Everest, but he is grounded to the earth. And I have never seen a personality like him. So much grounded in spite of having all those achievements.
Thank you. Jigyasa, you should have joined here. Yeah. इसको कहीं हाँ. Thank you. I'm all fine. Thank you.
Thank you. Next session will be along with Gupta sir only. Next session is on GDM. It is named by coffee with experts, but अभी lunch with experts हो जाएगा. तो मैं request करूँगा मनोज इंदुलकर सर को और moderator डॉक्टर राखी वाजपेयी जो कि प्रेसिडेंट जबलपुर ऑप्स गायनी सोसाइटी हैं, जोरदार तालियां हो जाए राखी मैडम के लिए. सेक्रेटरी जॉक्स कोमल जैन मैडम के लिए तालियां, और उनको भी रिक्वेस्ट करता हूं कि मंच पे आ जाएं, कुर्सियां लगाइए. और आज के चेयरपर्सन्स डॉक्टर निशा साहू मैडम, लता परियानी मैडम आ जाइए मैडम, प्रज्ञा हर्षे मैडम, कुसुम जैन मैडम, प्लीज कम ऑन द स्टेज. We will have some fun with all our renowned gynecologists, and the educative model, that is gestational diabetes is a very important part which we have to cover, and we do every yearly. Jigyasa, you have to join and conduct the session along with the president.
There's a question which Madam has asked about lipohypertrophy. Chairperson has asked this question. There is a lipohypertrophy, how many days it will get to resolve, or whether it will resolve or not. So ideally we should not give insulin to the lipocyte for long 1 year. After possibly 1 year might get resolved, and we should avoid giving insulin there, rather other sites should be utilized. Yes, thank you. And cosmetically, if you have a problem, you can remove this
madam
surgically.
Sir, Indulkar sir, please come. 2 चेयर और लाइए. तो ये हम लोग लेक्चर ना रख के हम लोग इंटरैक्टिव सेशन रखते हैं हर साल, ताकि यहाँ रखिए. ये आपने देखा होगा न्यूज़ चैनल में बहुत बहस होती है, लेकिन यहाँ बहस नहीं, ज्ञान वर्धन होगा कि एक ही टॉपिक को वो लोग खींचते हैं. पर यहाँ हम लोग इसको एजुकेटिव बनाएंगे, और जेस्टेशनल डायबिटीज़ पे डॉक्टर मनोज इंदुलकर सर, डॉक्टर सुनील गुप्ता सर और हमारा बहुत ज़्यादा काम है और हम लोग इतना सपोर्ट देते हैं प्रेग्नेंट फीमेल्स को कि हम लोग के मन में ये रहता है कि उनको स्वस्थ बेबी और स्वस्थ माता, एक बोर्ड लगा है बॉम्बे में, वहाँ पे बेबी बाहर आ रहा है और उसमें लिखा है कि बेबी गिविंग लाइफ टू मदर। तो मैं बार बार जाता था वहाँ जब पढ़ाई करता था, ये गलत कैसे छप गया, गलत कैसे छप गया। तो जब भी माता किसी बेबी को जन्म देती है तो वो माता का दूसरा जन्म होता है, क्योंकि इतने कॉम्प्लिकेशंस देखते हैं ये लोग डे टू डे। तो वो सही लिखा था, गलत नहीं लिखा था। वेन एवर अ बेबी इज बॉर्न इट इज़ अ न्यू बर्थ टू द मदर। तो इसीलिए हमको बहुत ध्यान देना है। अभी जो फिगर्स हैं डायबिटीज़ पे कितना रखना है, नॉर्मल व्यक्ति से प्रेग्नेंट फीमेल की शुगर लेवल्स अलग होती हैं। तो सुनील गुप्ता सर जो डिप्सी के प्रेसिडेंट भी रह चुके हैं और वो बहुत अच्छा प्रोग्राम्स करते हैं रीजनल लैंग्वेज में। अभी लास्ट ईयर हम लोगों ने सिंधी में भी किया था, मारवाड़ी, पंजाबी, हर रीजन में वो लैंग्वेज वाइज पेशेंट एजुकेशन के लिए और डॉक्टर एजुकेशन के लिए काम करते हैं। तो उसके लिए बहुत बहुत तालियां।
अभी हमने कल प्रोग्राम बुंदेलखंडी में भी किया पहली बार।
अरे वाह। ओवर टू यू प्रेसिडेंट मैडम।
Thank you so much. So, good afternoon, everyone.
Hello.
And first of all, I would like to congratulate Dr. Ashish Dengra, Dr. Jigyasa Dengra for conducting such a,
Thank you.
organizing such a nice international level CME. And I am thankful to them for giving me opportunity to moderate this session on GDM. So, the cases of GDM, gestational diabetes mellitus, are increasing in our society day by day. It is all because the age of marriage, age of conception is increasing, lifestyle is changing, and everyone is means running behind their career. So this is all happening because of that. So my first question to the expert: when should routine screening for GDM should be done?
So, I'm बोल रहे हैं?
The routine screening should be done in all pregnant lady, because DIPSI also recommended whenever at first onset or even in the first trimester, it has to be screened. There are various methods by various other agencies, ADA, CC criteria, DIPSI criteria. So to whom we have to screen, that is a very important question. So many, because nowadays the obesity is increasing. So any obese woman, even the BMI is more than 25, we must screen. Apart from that, if already the lady has a family, very strong family history of diabetes, so always ask in family history. Apart from that, if she had a past history of a bad obstetric history, then they may have a premature baby, they may have a recurrent abortion, polycystic ovary syndrome, and even if patient having a recurrent UTI, in that case also the chances of GDM is very high. Sir, would you like to say?
Hello,
I feel this. Let us have a very clear messages. First, every woman in the coming to the ANC clinic for the first time should be subjected for GCT, glucose challenge test. Every woman, irrespective, they have some risk factors, irrespective whether they are 22 BMI, they are 22 years, no family history, still do it. If it is negative in the first given opportunity, say first trimester, repeat it again at least once between 24 to 28 weeks of gestation. Ideally, first trimester, second trimester, as well as third trimester, you should do this test if it is negative in first and second trimester. If it is positive, don't repeat it again. People sometimes do that. Don't use urine sugar examination for taking the blood, diagnosing the blood sugar. Urine sugar has no value in pregnancy. Pregnancy is a condition where you will have normal renal glycosuria. Your blood glucose will be 110 and still you have 2 to 2% urine sugar positive, so don't try to diagnose it. Simple test called as, it has been approved by Government of India. What Government of India says? Irrespective patient is fasting or non-fasting, when they come to you, just give 75 gram glucose, take 2-hour test, more than 140, diagnose it. More than 200, diabetes, pre-existing diabetes, remain undiagnosed. 120 to 140 is a borderline case.
Okay, sir.
It's called a GGI, gestational glucose intolerance. And that GGI is a borderline case which need to be addressed by diet control, exercise. Most of the gynecologists, everyone is doing it. Just do it more consciously, because these are the women who might develop GDM in future, or they might have, and around 10% of them may need even insulin therapy, GGI cases.
Okay, sir. Thank you so much, sir. Actually, what American Diabetes Association 2025 says, the timing for the screening for diabetes is best at 24 to 28 weeks, unless she is over diabetic. And the rationale of it is the insulin resistance peaks in this period, and earlier screening may give wrong, false negative results. So the clinical point is universal screening captures the mild cases that might otherwise progress to undetected cases.
And
So-
according to the Government of India guidelines, each and every woman should be screened for the diabetes by the glucose tolerance test, that is the DIPSI test, as early as she concept.
So, madam,
it is
I am
must in
coming
the
on
first
it.
trimester of the pregnancy.
Okay, thank you, madam. So, my next question goes to Dr. Ashish. Who should be screened early, before 15 weeks? Who should be?
देखिए आज की डेट में इंडिया में एवरीवन, अगर आप इंडियन गाइडलाइंस के साथ चलेंगे, अमेरिकन गाइडलाइन छोड़ दीजिए, बिकॉज हमारे यहाँ तो क्या
coming
होता
on Indian guidelines.
या सो यू हैव
very
टू
soon.
डायग्नोज
हाँ.
एवरीवन इन, जब मैडम का क्वेश्चन है वो स्पेसिफिक है कि जो हाई रिस्क है,
Right.
ओवरवेट है, पीसीओएस है, प्रायर हिस्ट्री ऑफ एबॉर्शंस हैं, तो इन दोज केसेस यू हैव टू स्क्रीन अर्ली. बट इन इंडिया एज सर इज सेइंग कि सबको स्क्रीन करना है. हमारे यहाँ तो क्या होता है, हमें तो पता ही नहीं था हम 3 महीने कब प्रेग्नेंट हो गए. वो तो सीधे 3rd मंथ में आती है,
Right.
वो तो सीधे 2nd मंथ में आती है. तो इंडिया में तो ये बहुत प्रॉब्लम है. तो सर ने जो कहा और डिप्सी जो कहती है और इंडियन ऑप्स गायनी सोसाइटी भी वो ना अभी फॉलो करती है कि यू हैव टू स्क्रीन एवरी फीमेल जो आपके क्लिनिक में जिस दिन आ गई फर्स्ट टाइम, उसको पकड़ के चलना है कि इसका ग्लूकोज टॉलरेंस टेस्ट करना ही है.
जिस तरह आप हीमोग्लोबिन करते हैं, ब्लड ग्रुप करते हैं,
हाँ,
उसी तरह आप
it has to be done, और हम लोग करते ही हैं, लेकिन जो recent guidelines हैं,
नहीं मैडम, अपने
2025
गाइडलाइंस आर वेरी, गवर्नमेंट ऑफ इंडिया गाइडलाइंस आर वेरी क्लियर.
Yes, sir.
यू शुड नॉट
Yes, sir.
वेट फॉर द सेकंड ट्राइमेस्टर, थर्ड ट्राइमेस्टर.
No, we are not waiting.
Yes, yes.
So the rationale of doing this is early screening. It distinguishes over diabetes from the true GDM. Which test is recommended for the diagnosis of GDM?
Already told.
Already. So it is the 75 gram oral glucose tolerance test, and if the fasting is less than 90 and the PP means 2 hours, if it is less than 140, that means patient is not GDM, and if it is more than that, that means the patient is suffering from GDM, and you have to track that patient.
तो मैडम का ये कहना है कि प्रेगनेंसी की गाइडलाइन अलग होती है और एक नॉर्मल व्यक्ति की गाइडलाइन अलग होती है, तो कितना हमको शुगर रखना है वो सुनील सर बताएंगे.
फास्टिंग जैसे ही आपका डायग्नोसिस हो गया, व्हाट इज योर टारगेट? योर टारगेट फास्टिंग शुड बी आइडियली लेस देन 90. 2 hour post meal blood glucose should be less than 120, and this should be achieved at earliest. यदि आपका वो प्योर GDM है जो सिर्फ प्रेगनेंसी में आके डिलीवरी के बाद खत्म होने वाला है, तो ऐसे केस में आपको करीब 30% people might need drugs, 70% will do only on diet therapy well. 70% people will do very well on diet therapy alone. So important ये है कि every 4th or 5th woman in pregnancy have some kind of hyperglycemia. In pregnancy, 15% will be pre-existing, 85% will be GDM typically coming. एंड प्रीजीडियम चिमटी लेके बहुत एग्रेसिव कंट्रोल करना पड़ता है. Few of them may be over. मैडम 2-3 बार बोले over diabetes because they were not knowing, they were never tested their blood glucose. आशीष ने बताया कि आने के बाद समझ में आता है कि अरे इसको तो पहले ही HbA1c 9 आ गया, 8 आ गया. तो ऐसे केसेस में you have to be very aggressive, and there are some good counseling things which should be done in this.
So the next question is,
And HbA1c should be ideally less than 6. HbA1c should be ideally less than 6. Those who are known diabetes up to 6.5 is acceptable. Type 1 diabetes on high risk of hypoglycemia up to 7 is acceptable. But ideal is less than 6.5 is.
We have to do HbA1c.
HbA1c में क्या होता है कि HbA1c is glycosylated hemoglobin A1c. You should know that pregnancy is a state where is a state of hemolysis. So the RBC का जो life है, which is 120 days जो हमने बचपन से पढ़ते आ रहे हैं, that comes down to less than 90 days. And that is why HbA1c should be done in known type 1 or type 2 diabetes every month during pregnancy. Every month.
so sir, the rationale of keeping targeted blood sugar level during pregnancy, it helps in lowering the postprandial spikes, which reduces macrosemia.
और
in
मैडम आपको ना
babies
पोस्ट ब्रेकफास्ट भी करना है.
neonatal hypoglycemia.
मैडम आपको पोस्ट ब्रेकफास्ट भी करना है,
Okay,
पोस्ट लंच भी करना है,
Yes, sir.
और पोस्ट डिनर भी करना है.
This is very important. Like self-monitoring of blood glucose level is very important. It helps in, like, it is a key point. It helps every diabetic patient, and it also helps doctor to individualize the therapy, like exercises, food and medicine for individual diabetic patient. So what is the first line management for gestational diabetes? Sir, please.
First line therapy is always insulin, most safe in during pregnancy. Although there are many studies where the oral antidiabetic agent were used, like metformin also. But it is all dependent. If we control with diet and exercise, in that case we can use metformin. Other first line therapy is always a insulin.
Yeah, insulin is a drug of choice, and but पहले first is medical nutrition therapy, so good diet control.
Yes, sir.
And exercise. Gynecologist का permission ले लो exercise के पहले, एकदम intense exercise करने के पहले. But regular physical activity can be done, and regular exercise will help.
तो इसमें MNT में मैं आप बताता हूँ, एक पेशेंट आई थी, बंगाली फैमिली के थे, तो उनका यही GGT पॉजिटिव आया सेकेंड मंथ में. तो वो बहुत डर गई थी, बहुत सहमी हुई आई थी कि मुझे तो पूरे टाइम 9 महीने इंसुलिन लगाना पड़ेगा. तो आई हैव टेकन हर हिस्ट्री प्रॉपर थी, कुछ नहीं थी, फैमिली हिस्ट्री नहीं थी. सो आई काउंसल्ड हर कि तुम जो डाइट ले रही हो वो पूरा हिस्ट्री लिया तो सब गड़बड़ था, क्योंकि मीठा भी खाते हैं, बहुत ज़्यादा खिलाते हैं घर वाले. सो द मोमेंट शी हैज़ फॉलोड द MNT मेडिकल न्यूट्रिशन थेरेपी, मतलब डाइट उसने जैसे ही चेंज किया, आज 6 महीने हो गए उसको एक भी दिन इंसुलिन न कोई गोली लेनी पड़ी. बट वो रेगुलरली 7 पॉइंट शुगर करके भेजती है, और हर महीने आती है पूरा चार्ट लेके, उसको शुगर नहीं बढ़ रही है तो भी आती है. सो दैट इज द पेशेंट फॉलो अप रिक्वायर्ड आफ्टर योर काउंसलिंग. देन ओनली वी कैन विन द बैटल ऑफ हेल्दी बेबी ऑफ gestational diabetes and mother, healthy mother. तो ये बहुत जरूरी है monitoring.
So you have to have a good counselor like him also.
Thank you so much, Dr. Ashish. So the first line sir management, हमारा काम है कि हम स्क्रीनिंग करें, और स्क्रीनिंग में जैसे ही हमको पता चलता है कि भैया ये हाई रिस्क है, तो हम उनको ये मेडिकल न्यूट्रिशन थेरेपी में, जो फर्स्ट लाइन मेडिकल न्यूट्रिशन थेरेपी है, और फिर एक्सरसाइज उनको बोलेंगे 30 मिनट्स पर डे until unless exercise is contraindicated. और सबसे इम्पॉर्टेंट है कि हम उनको उनको है ना मेंटल मेकअप और उनकी कंसिस्टेंसी रखने के लिए उनको मोटिवेट करना, दैट इज द मोस्ट इम्पॉर्टेंट थिंग विच वी हैव टू डू. और अगर उनका नेक्स्ट क्वेश्चन इज व्हेन टू स्टार्ट फार्माकोलॉजिकल थेरेपी. डॉक्टर कोमल जैन. When to start pharmacological therapy in GDM patients?
अगर हम MNT देते हैं पेशेंट को डाइट एक्सरसाइज सब समझाते हैं उसके बाद भी जो ग्लाइसेमिक कंट्रोल का हमारा टारगेट है if it's not achieved 1 to 2 weeks then we must go for pharmacological agent or therapy.
Yes, very true.
And if your
Dr.
blood
Komal?
sugar is very high, suppose if fasting is more than 126, postprandial more than 200, HbA1c more than 6.5, don't wait for these 2 weeks.
Yes,
आपके पास पहले ही समय कम है, hardly आपके पास 2-3 महीने रहते हैं कभी कभी, तो don't wait for 2 weeks, directly start in pharmacotherapy.
Thank you so much, sir. So,
sorry to interrupt, ma'am. As we all gynecologists are practicing and we know diabetes is becoming very common, so every 4th or every 5th patient is having GDM, GTT
Yes,
positive.
yes, yes.
So we know all these management, but we have very much a lot of doubts which we want to clear in this session since we have experts with us. So can we ask our doubts rather than going through all these things?
Yes, these questions are for experts only.
So, sir, I want to ask some of my doubts, like since we are living in era where we are seeing not only diabetes, the patients with diabetic complications also getting pregnant. Like the patient with diabetic nephropathy also comes to me, she is having creatinine level 4. Should I allow her to continue the pregnancy or is there any checkpoint where I have to tell her नहीं इसके आगे आपको diabetes ऐसे कौन सी मतलब ऐसा कौन सा complications है like coarctation of aorta in cardiology where we say no you don't have to conceive and you have to get it aborted. So are there any complications of diabetes where we have to say no you don't have to continue this pregnancy and you have to abort it, or we have to continue in all the complications in this era also?
Just before this session I was taking session on the same topic on online around 12:30 or so. I spoke on this for half an hour now. So important, patient when comes to you with type 1 diabetes or type 2 diabetes might having pre-existing complications. First is retinopathy. If I'm just giving you carry on message in 30 seconds. If someone has retinopathy pre-existing, either NPDR or mild NPDR or PDR. If you have mild NPDR, it is likely that with pregnancy the retinopathy will get worsened. If it is PDR, proliferative diabetic retinopathy, it is contraindication for pregnancy. So such women should not get conceived. If they get accidentally conceived, you have to tell them there is high chances of almost 20 to 40% of retinal detachment and intravitreous hemorrhage at the time of expulsion of the placenta delivery, and such patients should be subjected for LSCS rather than the normal delivery.
Retinopathy is contraindication for spinal anesthesia also, so this is a very
Yes,
complicated
very
case.
Yes, so that is one thing. Second, those who don't have retinopathy will not start in pregnancy. The pregnancy will not begin the retinopathy, but it will deteriorate the pre-existing retinopathy. That's one. If you have diabetic nephropathy, already urine में albumin जा रहा है, proteinuria ज़्यादा है, तो there are high chances of having hypertension. If they don't have, then preeclampsia, and there is high chance of IUGR, intrauterine growth retardation. And these patients will also have associated retinopathy. And there are also chances of having deterioration in the hypertension and renal parameters as the pregnancy advances. So this is again relative contraindication. Those who having established coronary artery disease, you have to take permission from the cardiologist where their cardiac output and other things will be able to manage the whole show. So these, and if you have hypertension, AC inhibitors, ARBs and MRAs, these 3 drugs are contraindication. So you have to withdraw all these drugs, switch over to your beloved labetalol. I feel most of the gynecologists, they love 2 drugs. I have seen gynecologists का प्यार husband के बाद यदि कहीं है तो gynecologist लोगों का प्यार है एक labetalol पे और एक metformin पे. जो भी GDM है उसको metformin लिखते हैं. So that is, your whole society loves these 2 drugs. So that you can certainly switch over. And statins, many of the people with known type 2 diabetes, they are already having statins. Statin is contraindicated in pregnancy, but I am giving you good news today. Those women who have familial hypercholesterolemia, very high cholesterol, and by withdrawing statin, if you are increasing the risk of coronary artery cardiovascular disease, in such women, recent guidelines of 2025 American Diabetes Association says statin can be continued in pregnancy because of the high risk of cardiovascular disease in such women who have familial hypercholesterolemia. Other people, it should be stopped. Similarly, metformin is a good drug. But when it comes to pre-existing type 2 diabetes, we prefer insulin as a gold standard drug of choice. Those who are polycystic ovarian disease, already on metformin, there is no reason that after becoming pregnant, after 12 weeks, there is no reason to continue metformin after 12 weeks. You can withdraw it. Metformin will neither postpone GDM or neither avoid GDM, nor it will avoid preeclampsia, which was the earlier thought process. So meta-analysis says after 12 weeks you should withdraw metformin. There is no additional reason of continuation of the metformin in PCOs. But those who are type 2 diabetes along with PCO taking metformin, in my opinion, as a common sense, I will continue metformin and add insulin. So
Thank you.
Thank you so
diabetic
much,
gastroparesis,
Acha.
autonomic neuropathy or diabetic gastroparesis is another contraindication for pregnancy because of hyperemesis gravida.
One thing what I want to say is that if a patient is having creatinine of 4, that means she is already having renal failure है ना, है, तो उसकी जान बचाना, मदर की जान बचाना ज़्यादा ज़रूरी है. Pregnancy is not important. That तो अगर कोई भी life threatening condition में है due to the complications of diabetes, we should first save the life of mother. We should ask her if she gets pregnant. We should ask her to go to the specialist and get consent for the termination. What I feel.
Regarding complications of diabetes, sometimes a patient is having, in GTT she is having sugars of approximately 130 to 140 arbitrarily. And then some patients are having HbA1c of 15% also. But we see complication with GTT 130, 140, and we don't see complication with those patients. What is the reason behind that?
The risk of having congenital malformation with HbA1c, let me tell you, if it is more than 10, chances of having risk of congenital malformation or other mishaps are almost 25%. More than 10, you said 15, so it's going to be more than, much more than that even, so 20, 25. But that does also indirectly mean that 75% patient, despite having high blood sugar, are going to deliver normal. They will not have any complication. So it's a kind of chance that whether you belong to 75% or 25%, but it is important someone comes with high HbA1c, coming with pregnancy, where you can't do anything. In that situation, you have to explain the prognosis properly. Or even if they are coming in the first 10, 12 weeks, 15 weeks, and when you can take the decision of termination, that time the termination decision has to be taken by the family members and not by the obstetrician nor by diabetologist. They should be taking the decision. You have to tell the prognosis that your HbA1c is 12, the chances of having problem is almost 25 to 30%, whether you want to continue or you want to take a chance for 70%.
Sir, thank you, sir.
Thank you so much, sir.
Sir, one more question. Sir, what is the prognosis of pregnant patients with diabetic foot?
Diabetic foot, of pregnant women with diabetic foot. I feel diabetic neuropathy.
Patient, she is just now, she is 8 weeks approximately. She is
See,
having diabetic foot with HbA1c of 10. She want to continue by anyhow.
So, again the same thing. You have to correlate with the vasculopathy. When you have neuropathy, that means diabetic foot means neuropathy. So you have neuropathy, and that means associated other retinopathy, nephropathy might be there. So you have to evaluate it properly, tell them the prognosis, And we have one lady, one type 1 diabetic who had pre-proliferative diabetic, NPDR, non-proliferative diabetic retinopathy. She was mad for getting conceived. Mad, like we said, 10. And she ultimately got preconception counseling. She was put on pump. We have to take her insulin pump on higher. We did it. She delivered a baby who was normal. But unfortunately, after 3 or 4 or 5 years, her nephropathy progressed, retinopathy progressed, and after 6 or 7 years, ultimately we lost her. She went on dialysis. Now the baby, recently their mother and other patients, they come. She said the baby is now 11 years and we don't have the mother. So
my question is, I want to ask you, sir, insulin is the best drug for GDM. Sir, if you keep patient on insulin, what is best, either like basal bolus or pre-mixed?
Madam, basal bolus is the best treatment.
Sir, what is, first tell us what is the difference, what is basal bolus and what is pre-mixed, and which is best, sir?
Yeah, there are different kind of insulin they come. Basal bolus, you have to give basal insulin as well as bolus insulin with pre-meal. And pre-mixed insulin are already 30%, 70% or 50-50 short-acting, long-acting. So most of the physicians, they are aware of the pre-mixed insulin. But pre-mixed insulin should not be the first drug of choice. In rarest of rare cases of GDM, you can use it, but all pre-GDM type 1 and all pre-GDM type 2 known diabetes, severe hyperglycemic basal bolus therapy is best, because what is traditionally being taught and written in the textbook is altogether different than what we see in the practice. So we have the data which is already published. In pregnancy, you require higher prendial doses. So pregnancy is a post-prendial hyperglycemic state. Book says 70% long-acting, 30% short-acting or 50% short-acting, 50% long-acting. Pregnancy में ऐसा नहीं होता. Pregnancy में 70% short-acting and maybe you will require 30% long-acting.
Okay, sir.
So that's why basal bolus is being preferred. You can easily manage the show. And as the pregnancy advances, sugar goes on increasing up to 37 weeks. 37 वीक के बाद में एक प्लेच्यू आता है और 38 और 40 के बीच में वो थोड़ा नीचे जाता है. तो ये जो 36-37 वीक तक जो धीरे धीरे बढ़ना है वो प्रीमिक्स से मैनेज नहीं होता मैडम. उसके लिए आपको बेसल बोलस थेरेपी.
थैंक यू सो मच.
तो ये जो मैडम का क्वेश्चन है, सिंपल आंसर है उसका. पेशेंट 4 बार लगाने को तैयार नहीं होता है, तो मैं उनसे ये पूछता हूँ, तुम रेडीमेड शर्ट तुमको फिट आती है कि खुद से सिलवाते हो तो फिट आती है? तो वो बोलता सर जब मैं टेलर के पास जाके फिटिंग कराता हूँ तो बढ़िया बनती है. तो वन साइज डजंट फिट्स टू ऑल. प्रीमिक्स वन है कि 70 और 30, आपको जरूरत है नहीं है 70-30 लगाना पड़ेगा. बट बेसल बोलस आपके हाथ में है कि कितना हमको बेसल चाहिए और कितना बोलस चाहिए. तो दैट इज द बेस्ट थेरेपी.
सर, आई वुड लाइक टू आस्क क्वेश्चन विथ यू. सर, जो हम ओरल हाइपोग्लाइसेमिक्स देते हैं तो उसमें बेस्ट मेटफॉर्मिन बोल रहे हैं. देयर इज अनदर ड्रग. What are the other drugs, sir, we can use, and what are the safety profile of those drugs, sir?
Is already pointed out the metformin which we commonly use, and there are many other drugs, glyburide, that can be used, but literature already pointed out with this all other drugs, sulfonylurea, there is a detrimental effect of the fetus. So only metformin, insulin. So there are many studies where sulfonylurea is being used, but because of the detrimental effects of the fetus, it is not being commonly used.
Madam, glibenclamide is a drug which has been officially approved by global guidelines to be used in pregnancy, but there is long-term safety data is not available on the offspring. Metformin, you have safety data available, not major concern, but there are certain concern in the offspring of diabetic mother in the up to 9 years of age, 11 years of age. Now they will get data of 13 years of age. So there is a good long-term safety data in this. So metformin, that's why even European government now, NICE guidelines have come, and now they say metformin can be used. There is a trial called MITI trial, where type 2 diabetic patients have been given metformin pre-conception till delivery. Conception से पहले से चालू किया, delivery तक दिया. No safety concern as far as neonatal outcome is concerned. So they say, now the European guideline says you can give metformin from pre-conception till delivery. On the basis of that, DIPSI guidelines have recently changed their strategy of 2024. Earlier we used to say after 20 weeks देना है GDM में, now we say after 12 weeks भी दे सकते हैं.
Right, sir.
समझे ना? तो मेटफॉर्म दे सकते हैं. अकारबोज एक ड्रग है जिसके ऊपर डाटा थोड़ा सा है. कुछ लोगों ने उसको अलाउ किया, पर I feel most of the people are not using it. Theoretically it seems to be a good drug, but then better is to stick to metformin and insulin alone at this moment of time. And never try to give combination therapy or give metformin. It has never been tested in pregnancy. अपने को आदत है ना combination therapy लिखने की, तो अपन ने वो गलती से देना नहीं देना कि metformin दे, insulin नहीं ले रही है तो ये भी दे दो वो भी दे दो, ऐसा नहीं होता pregnancy.
Thank you so much, sir, for enlightening us. So my question goes to Dr. Komal Jain. What is the post-delivery follow-up for GDM patients? Post-delivery follow-up.
Post-delivery, after delivery, we can ask patient to come after 4 to 12 weeks and then after every 1 to 3 years for the follow-up.
Okay. So, Dr. Jigyasa, would you like to add something in that?
I would like to add that diabetes, since GDM, she has got with GDM. I am talking of GDM, not diabetic patient. GDM, this is the checkpoint for her for getting diabetes in future. So she should be tested for sugars and HbA1c whenever she visits, or at least every yearly. Yes. Which she should always be counseled about, that she should be careful. And this is the checkpoint. You have to change your lifestyle, you have to avoid sugars, you have to do exercise, and you have to do whatever you can do so that you can postpone your diabetes.
So, like counseling of not only patient, but the counseling of family members is also important so that they can support them.
So, chairpersons, any questions? So, we will wind up. Yeah, because they'll end up into hypoglycemia usually. So,
So, what are the complications for a diabetic patient, not only for the mother and for the baby? Sir, please.
Mostly, as already sir said, there are many complications seen in fetus. Sacral agenesis is an important complication. Apart, there are congenital malformation, ASD, VSD, oftenly we see in these babies. So many other malformation is also observed if it is not being controlled. Many times we have to give target to our patient. Always regularly monitor. Ask them to keep the blood glucose level below 90, always fasting. And postprandial, not like 140 or 180. We have to ask them to keep less than 120 so that we can avoid this congenital malformation in the fetus.
Dr. Komal, would you like to say something on that, because you are a gynecologist and you are doing a lot of obstetric work?
For the fetus, as sir said, there is congenital malformation and macrosomic child, and there is sudden IUD. This is the main complication for fetus. And for the mother, there is multiple like kidney eye problems, and there is cesarean section delivery.
Preeclampsia, and during delivery, shoulder dystocia.
So in the trial of normal delivery, there can be shoulder dystocia due to this macrosomic child.
And later on T2DM. And for babies, you can see macrosemia. Everyone said that neonatal hypoglycemia is very common. Stillbirths, long-term obesity risk in baby.
Indulkar sir, any closing remarks?
Only as Gupta sir said, we have to educate our patient. First give a target and ask them to continue with insulin. Otherwise, you already conceive. So now it is your responsibility to care of your fetus, because many of your baby may comes with the complication, and that gives a issue in your society as well in your life also.
Sir, Dr. Ashish, I would like to ask you, what are the recent innovations in GDM management?
GDM care innovations, as we know, the CGM, the digital tech developed apps are there to follow up their insulin sugar levels, and we can send them the insulin dosages. So there is n number of technology now available for GDM patients along with insulin pumps. So technology is making a boom in this field also. As sir was saying that we have shifted her to insulin pump, and the app-based technology apps are available for keeping the follow-up. Even the patient's husband can see all the reports online. So we are all connected, so the doctors can also see their reports daily. So there are many glucometers now which are available with the AI driven things. So it is a very good era we are going to, and with this monitoring is very easy to do nowadays, and the patient can modify their insulin dosages while sitting at home only.
So COVID has taught us a lot.
Yeah, thank you.
So I want the
Take away, yeah.
take away summary from one message from each expert. Sir, Indulkar sir. One message, one take home message. Sir.
It's already pointed, counseling is very important. That is the only way by we can prevent the complication in fetus.
It's a great deliberation, sir. Dr. Gupta sir being the DIPSI chairman earlier, it can't be better than this. People, ladies especially, they are on weight lowering drugs like semaglutide and tirzepatide, then they conceive. So what is GLP-1 analogs and pregnancy you would like to?
You should give some best question award also. So give him the best question award.
It's honor, sir. It's honor, man. It's honor.
So now please listen to this very carefully, because we are all going to face this. GLP-1 analog carry-home message at this moment, 2nd November 2025, is contraindicated in pregnancy. One strong message. But there are, in most of the Western, most means almost all developed countries have a protocol that whenever a new drug is being launched, they have a very close watch that every data is being entered in the common registry. So they have the registry data available from at least 6 different countries, and they have shown around 938 women who were known diabetic or obese have been taking GLP-1 analog and got conceived. And they have seen the neonatal outcome of those women who were subjected to insulin versus who have been exposed to GLP-1 analog. There was no neonatal complication observed till date, those 938 women who have been exposed to GLP-1 analog. And most of them were either tirzepatide or semaglutide. That's a very strong message. Now, because obesity is one of the cause of infertility, many of the obese women are being given by the infertility centers GLP-1 analog before they plan the procedure. So now the recommendation is you can certainly use GLP-1 analog for obese women planning for pregnancy, but withdraw the GLP-1 analog at least 2 months prior to the procedure. If you do it early, then there are chances, the half-life of these drugs is 1 week, 5 to 7 days, 5, 6, 7 days, and they take 4 half-life. Now they say 8 half-life, so 8 half-life is 2 months. So minimum 2 months gap, and then you can plan the procedure for the women. So that's about GLP-1 analog.
Thank you so much, sir.
Yeah, this is your prize, sir.
Sir, please come on the stage. Sir ने बोला और ऊपर से आ गया.
ऊपर से आ गया. Very nice, so nice.
आइए, come on the stage.
Congratulations. Congratulations.
Thank you.
Friends, I am Brigadier Satyaran, retired AMC officer. I am working with Apollo Jabalpur Hospital as a physician. Thanks for the honor, sir. Thanks.
So we will wind up with this very interesting session. ये तो कॉफ़ी विद एक्सपर्ट्स थी, लेकिन ये लंच विद एक्सपर्ट्स हो गया है, बिकॉज सबको सर लोग का फ्लाइट्स है, तो वी हैव डन इट प्रायर एंड वी हैव अ वेरी वंडरफुल चेयरपर्सन्स. आप लोग कुछ कहना चाहेंगे क्लोजिंग रिमार्क?
So this is very nice chat on GDM, very informative. Many doubts are clear, and this is very useful in our day-to-day practice. Thank you, and congratulations Ashish and Jigyasa for this wonderful academic session. Congratulations.
Gupta sir, I think you are an outstanding teacher, and we are very much honored to that all our doubts were cleared. And one take-home message will be that whenever a patient with GDM is diagnosed, you tell her EDD is 2 weeks before, because there are increased chances of sudden IUD. So if you tell her that EDD, normal EDD is this, then they have that mindset कि नहीं madam 15 दिन क्यों कर रहे हैं. Thank you.
These are tips, huh?
Dr. Ashish here.
Very good tip, Dr. Pradnya. Madam, please. Swaraj, madam is there.
Can I say something? It was an excellent talk by all of you experts. I just want to add one more thing. Ki whenever patient is diagnosed as GDM, and now with Google and all, they are already informed about various drugs and this thing. The anxiety part is the very high level in these patients. Whenever they come to us as, for the obstetricians, I have seen this anxiety level increase, how the child will be, how the labor will be, how the antenatal period will be prolonged. So we have to take care of that also empathetically. So that is what I just want to say, ki, treatment, you experts are there to guide us, but as an obstetrician, it's our role to make them understand what they are suffering and how to carry over the pregnancy. So it is also a very important part of counseling. Thank you so much.
Thank you, sir. It was very informative and very knowledgeable talk today. We have learned so many things new. We always thank Ashish for arranging such a nice topics, especially on the diabetes, gestational diabetes, even though the all knowledge get brushed up every time. And thank you very much for all information.
सर सभी को बहुत बहुत बधाइयाँ इतने अच्छे टॉपिक के लिए जो हम लोग नहीं जानते थे कि हर मंथ यदि जीडीएम वाले पेशेंट हो तो कराना चाहिए, क्योंकि हम लास्ट वीक में कराते थे या 28 वीक्स के बाद कराते थे. तो नाउ हमारे लिए एक नई चीज़ हुई है कि हमें शुरू से कराना है ब्लड ग्लूकोज. थैंक यू.
And all physicians, if a person with type 1, women with type 1, type 2 coming to you for pregnancy, please start using a new terminology called as fitness for pregnancy. You give fitness for cataract surgery, you give fitness for hernia surgery. Now start giving fitness for pregnancy. Fitness for
pregnancy.
What did I say? Fitness for
pregnancy.
Fitness for
pregnancy.
That is a real preconception counseling and care.
और उसका मूल मंत्र है एजुकेशन, एजुकेशन और एजुकेशन. उसको डराइए नहीं, उसको काउंसलिंग करिए, उसको बोलिए कि कितना आपको शुगर कब कब नापना है, इंसुलिन कैसे लेना है. इंसुलिन कोई जहर नहीं है, प्रेगनेंसी में वरदान है.
थैंक यू. थैंक यू.
थैंक यू इंदुलकर सर, थैंक यू वाजपेयी मैडम, सुनील गुप्ता सर, कोमल एंड द रिस्पेक्टेड चेयरपर्सन्स. आइए मोमेंटोस का वक्त आ गया. यहाँ मोमेंटोस प्लीज. इंदुलकर सर मोमेंटो. सुनील सर, सुनील सर यहाँ जी. मोमेंटोस मैडम, राखी मैडम आ जाइए. हाँ पहले इंदुलकर सर को आप दीजिए मैडम. आइए मैडम, आइए आइए. अरे इनॉग्रेशन ही है. तालियां बजती रहें. लंच जल्दी शुरू हो जाएगा, डोंट वरी. सर का सर लाओ. राखी मैडम, राखी मैडम को दीजिए. नेक्स्ट लाइए. ये देखो कोमल मैडम आइए. इंदुलकर तालियां बजती रहें. क्लैप क्लैप. जिज्ञासा गिफ्ट दे दो मैडम को. तो ये हमारी धर्म पत्नी है जो हमारे को झेलती है कि हम लोग टाइम नहीं देते हैं. आप लोग का ये प्रोग्राम कराने में हमको यहाँ डांट खानी पड़ती है, पर ये बहुत सहयोग करते हैं. नीचे 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 वो देखिएगा नहीं, ऐसे नीचे. तो हमें ये
मैम ऐसे कॉम्प्लिकेटेड केसेस आते हैं ना, पेशेंट विद डायबिटिक फुट, दे कम टू मी कि सर और आप मिलके मैनेज कर लोगे, नेफ्रोपैथी हैविंग फोर क्रिएटिनिन, सर और आप मैनेज कर लोगे 4 क्रिएटिनिन, हमारी तो निकल पड़ती है मैम.
But by the grace of God, we are managing very well, and I should congratulate जिज्ञासा कि IVF में भी जो results आ रहे हैं वो बहुत ही astonishing है भगवान की कृपा से हमारे सेंटर में. और GDM और thyroid in pregnancy उसका जो हम लोग follow up रखते हैं वो मतलब every day send reports to us on WhatsApp, and every day we help them to change the dosages. और mental counseling जो होती है जिसमें वो बहुत परेशान हो जाते हैं वो that also we give them support daily और weekly. तो उससे जो result आ रहा है, इसीलिए मैं कह रहा हूँ कि आपको patient touch बहुत जरूरी है. ट्रीटमेंट ऐसे करिए कि आपका कोई घर का पेशेंट मेंबर है. मैडम लता, ओ निशा मैडम आइए. मैडम कुसुम मैडम, लता मैडम, लता मैडम आइए. इंदु, प्रज्ञा मैडम सामने सामने देखिए. तो ये हमारी ब्यूटीफुल लेडीज के लिए तालियां बजाइए भाई. ये नहीं होंगी तो बच्चे पैदा नहीं होंगे जबलपुर में. थैंक यू वेरी मच फॉर दिस वंडरफुल सेशन ऑफ GDM जो कि हर साल सक्सेसफुल रहता है आप लोग के सहयोग से. 5 मिनट आप लोग बैठिए. मैडम आप इनॉग्रेशन में बैठना है ऊपर. इनॉग्रेशन सेरेमनी के लिए अनुराग वो चालू करिए ना. सरस्वती 15 लोड करो और माचिस ले आइए. जल्दी लगाओ. ये इनॉग्रेशन और अवार्ड सेरेमनी भी है. नवनीत सर कैसे? बस चालू कर. नहीं ये इसी में ही है. इनॉग्रेशन के लिए हाँ नहीं खाना खाना है. अभी कहाँ जाएं? हमारे साथ हमारे चीफ गेस्ट रिस्पेक्टेड डॉक्टर नवनीत सक्सेना सर हैं, डीन मेडिकल कॉलेज. जोरदार तालियां हो जाएं. सर प्लीज कम ऑन द डाइस फॉर इनॉग्रेशन. हमारे डैशिंग हैंडसम सर और गेस्ट ऑफ ऑनर स्पेशल इनवाइटी में प्रेसिडेंट जॉक्स राखी मैडम प्लीज कम ऑन द डाइस. सुनील गुप्ता सर प्लीज कम ऑन द डाइस. हाँ हमारे बहुत ही हैंडसम डैशिंग अमरेंद्र पांडे जी प्लीज कम ऑन द डाइस. स्वामी सर प्लीज आ जाइए. आइए ना. राजा प्लीज. सो राजा राम कर्ण इज फ्रॉम अमेरिका. इनके लिए बहुत जोरदार तालियां. इसके बाद इनका लेक्चर सुने बिना नहीं जाना है. ही इज फ्रॉम अमेरिका. ही विल गिव यू सम इंट्रोडक्शन ऑफ.
I'm sorry I am standing between you and your lunch. My talk is right after this, so sorry for that. I actually am from Miraj, which is between Maharashtra and Karnataka. I did my MBBS, MD there and the DM in KEM endocrinology. Then I went to US in '96. 30 साल से मैं वहाँ हूँ, लेकिन इस बंदे को मैं 5 मिनट मिला जयपुर में, and he managed to get me here. So that's about him.
Thank you, Raja. Please come on. So we will start with Saraswati Vandana.
या कुन्देन्दु तुषारहार धवला या कुन्देन्दु तुषारहार धवला या
Sorry, madam, Richa madam, आप आइए. President आई है, मैं भूल गया था. Sorry.
या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवै सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीमभयदाम् जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थिता वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम् या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिः देवै सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीमभयदाम् जाड्यान्धकारापहा
Thank you. After light lamping, I will request IMA President Richa Madam to bless us with few words. Deepak Behrani sir, please come on the dais.
Good afternoon, everyone. Respected dignitaries over the dais, I welcome everyone over here on behalf of IMA Jabalpur. This is the 7th International Conference of Newer Dimensions in Diabetes. So I congratulate Dr. Ashish Dengra, Dr. Jigyasa Dengra, and whole of the team for this successful conference, international conference. We have our guest who has come over here from US. And so I hope you all must have been benefited very much. One thing I just want to say कि आप लोगों के जितने भी sessions में जो भी discussions हुए हैं, एक चीज़ जो मेरे को समझ में आती है कि diabetes is related to our culture, our Indian culture, Indian festivals and Indian style of eating. हमारे हर फेस्टिवल में एक कुछ स्पेशल एक एंटिटी होती है कि बिना उसके वो चीज़ होती नहीं है. ये चीज़ मैंने बहुत महसूस की. आप कितने ही कोशिश कर लो, जब तक कि आपके घर में मिठाई नहीं बनेगी तो फेस्टिवल होता नहीं है. तो आई थिंक इस चीज़ पर भी रिसर्च होनी चाहिए कि त्योहारों में जो हमारा ईटिंग स्टाइल है, फास्टिंग होती है तो उसमें बोलते हैं पुए बन रहे हैं तो वो गुड़ के ही पुए बनेंगे.
मैं इसमें
तो
एक इंटरप्शन कर रहा हूँ मैडम.
होना चाहिए.
सर के यहाँ केक नहीं कटता है, फ्रूट केक कटता है. सर फ्रूट को केक बनाते हैं डिफरेंट फ्रूट से. बर्थडे में सुनील गुप्ता सर के यहाँ केक नहीं कटता है, एक फ्रूट का ऐसे पूरा आकार रहता है जिसमें केक बन जाता है और उसको काटा जाता है. तो वो शुरुआत हो गई है.
बिल्कुल. तो इसके लिए बहुत बहुत बधाई सर को. और ये चीज़ पब्लिक में भी जानी चाहिए कि हमको अपनी ईटिंग हैबिट्स, जो हमारे फेस्टिवल्स, आप फेस्टिवल्स भी मनाएं, अपना कल्चर से भी जुड़े रहें, अपनी मिट्टी से भी जुड़े रहें और अपने डायबिटीज से भी बचे रहें. तो आई थिंक उससे समाज को बहुत ज़्यादा फायदा होगा. थैंक यू वंस अगेन.
थैंक यू मैडम. आई वुड रिक्वेस्ट राखी वाजपेयी मैडम टू ब्लेस अस विद फ्यू वर्ड्स फॉर NDID.
Respected dignitaries on the dais, everyone who is present here, all the chairperson, delegates, I would like to congratulate Dr. Ashish Dengra, Dr. Jigyasa Dengra for organizing this very nice, huge 2-day international conference. And all the topics which I have heard, they are very nice with many good take-home messages. And we all know diabetes, that is entering in every home. So we must know each and every point of it. And I would also like to congratulate Dr. Ashish. You are organizing it like online also, virtual also.
Yeah.
तो ये है ना, माने it is very much benefit. Those who are unable to come here, वो भी इससे benefit हुए. और जो दूसरे cities के हैं या जिनको भी इसमें माने आना था, क्योंकि सारे topics बहुत अच्छे होते हैं आपके. Thank you so much.
Thank you very much. I request Rajaram to bless us with few words.
This is my first time in Jabalpur, and I'm very impressed with the level of enthusiasm, the excellent topics, knowledge base, and the participation. Congratulations to Mr. and Mrs. Dengra, and thank you so much.
Thank you, sir, for coming from the long distance on my request. Thank you. I will request Sunil Gupta, sir, to bless me.
Congratulations Ashish, congratulations Jigyasa, congratulations Mahi team, and congratulations all of you sitting so patiently even with the lunch timing. I feel congratulations. Let's give a big hand for yourself. आप सभी लोगों के लिए जोरदार तालियां होना चाहिए, वो इम्पोर्टेंट है. मैंने ऑलरेडी बहुत बोल लिया है, पर जो बात हुई वो रुक नहीं पा रहा हूँ. अबाउट फ्रूट, सो वी से कट द फ्रूट एंड नॉट द केक. कट द फ्रूट एंड नॉट द केक टू सेलिब्रेट एनी ओकेजन. यदि हमने घर में सब लोगों के साथ ऐसा करना शुरू कर दिया तो हमारे साथ साथ और 8-8, 10-10 घर वो लोग भी शुरू करेंगे और ये एक श्रृंखला चलती रहेगी. सो कट द फ्रूट एंड नॉट द केक. थैंक यू.
Swami sir,
थैंक यू आशीष फॉर एक्चुअली इम्प्रोम्प्टू मुझे स्टेज पे बुलाने के लिए. थैंक यू वेरी मच. And Dr. Sunil, who is the president-elect for RSSDI, National RSSDI president, a personal friend, a senior, and we started our journey together actually, way back in 30 years ago. And congratulations Ashish and Jigyasa for organizing such a nice conference. It's always a pleasure to be here. Your topics are excellent. The deliberations are outstanding. So thank you again. And best wishes for many more years to come. Thank you.
Thank you, sir. Behrani sir, he is our mentor and he is always with us and he is a great academician, great physician और इनका जो डेडिकेशन है वो आज किसी डॉक्टर में नहीं मिलता है, तो इनके लिए बहुत जोरदार तालियां. हमने इनको देखा है कि हॉस्पिटल में कैसे 16-16, 18-18 घंटे रहकर पेशेंट की जान बचाई है. उसके लिए इनका बहुत बहुत धन्यवाद. जबलपुर के लिए ये वरदान है और ये डुओ जोड़ी जो है जय वीरू की, ये पूरे हॉस्पिटल जो जबलपुर हॉस्पिटल को संभाल के बैठे हैं वो इन दोनों की वजह से है. आप थोड़ा सा हम लोग के लिए कुछ शब्द कहिए.
थैंक यू डॉक्टर आशीष. मंच पे उपस्थित डॉक्टर सुनील गुप्ता जो कि नेशनल प्रेसिडेंट है हमारे डायबिटिक सोसाइटी के, डॉक्टर राजाराम, डॉक्टर राखी वाजपेयी मैडम जॉक्स की प्रेसिडेंट, डॉक्टर अमरेंद्र पांडे जो मल्टी डायमेंशनल पर्सनालिटी हैं, नर्सिंग होम एसोसिएशन, डॉक्टर एसोसिएशन, डर्मेटोलॉजिकल एसोसिएशन, और जबलपुर में जो बेस्ट से बेस्ट हो सकता है मेडिकल फ्रेटर्निटी के लिए उसके लिए हमेशा प्रयास करते हैं. मैडम ऋचा, डॉक्टर परिमल स्वामी और हमारे आदरणीय डीन डॉक्टर नवनीत सक्सेना सर, आप सभी को स्वागत है, वंदन है, प्रणाम है. आप सबके सहयोग से ये जो कॉन्फ्रेंस, नेशनल और इंटरनेशनल कॉन्फ्रेंस है, वो सफल हुई है. डॉक्टर आशीष का हमेशा ये प्रयास रहता है कि हम तो अपडेट रहें पर सारे फिजिशियन, सारे जबलपुर के डॉक्टर्स भी अपडेट रहें ताकि डायबिटीज़ के मरीजों का अच्छे से अच्छा इलाज हो सके. इसी तारतम्य में उन्होंने वर्चुअल कॉन्फ्रेंस करवाई जो आ नहीं पाते थे, नेशनल और इंटरनेशनल फैकल्टी, और जबलपुर के सारे फिजिशियंस को उनने कुछ न कुछ टास्क दिया ताकि वो भी अपनी प्रतिभा को निखार सके और स्पीकर बनाया उन लोगों को. डॉक्टर डेंगरा का जो एकेडमिक फीस्ट को जो बनाने का प्लान 3-4 महीने की कड़ी मेहनत के बाद ये सब संभव हो पाता है और इतने सारे लोगों को एक माला में पिरोने का काम करते हैं, वो रात दिन मेहनत करते हैं, उसके लिए आपका बहुत बहुत धन्यवाद. डॉक्टर जिज्ञासा, डॉक्टर आशीष जो माही फाउंडेशन के द्वारा जो ज्ञान की जोत से जोत जला रहे हैं उसके लिए उनको बहुत बहुत धन्यवाद.
थैंक यू सर फॉर योर काइंड वर्ड्स. अब मैं हमारे मुख्य अतिथि डॉक्टर नवनीत सक्सेना सर से कहूँगा कि मंच पर आप हमें 2 शब्द से ब्लेस करें और इस जो श्रृंखला में हम लोगों ने आपके सहयोग से ये NDID 7th इंटरनेशनल कॉन्फ्रेंस करने में मतलब सक्षम हुए हैं, उसके लिए, और आपने जो हमारा इनविटेशन एक्सेप्ट किया, प्लीज़ 2 शब्द से हमारे को अनुबोध करें.
Thank you, Ashish. Good morning, everyone. And the dignitaries on the dais, especially who has come from the US, Dr. Raja, Dr. Rakhi, Dr. Sunil, Amren, and of course Ashish, Parimal, and Richa. And I could see some of my faculties also sitting in the audience and all the participants, delegates. I welcome all. Being an ophthalmologist, I just want to say a few words because it's a forum of diabetic, diabetologists. So being an ophthalmologist, I am an ophthalmologist. Actually, there are a lot of myths in this society about diabetes, which I have seen over the 40 years down the line. Like so many herbs which can control diabetes, like so many medicine, tablet, and different types of, it is available in the market as well. But eventually, it is the allopathic medicine which controls the diabetes, and no diabetes is never controlled. So I have seen my patient coming with a good vision and uncontrolled diabetes for long time, and they are blind. So I tell them, you live with the diabetes because diabetes is not that disease which you take a medicine and the fever is over. It has to go lifelong. So you have to understand the diabetes, that somebody's diabetes can be controlled by exercise, somebody's diabetes controlled by the diet control only. So the people start thinking, why my diabetes is not being controlled by exercise and medicine? Why should I take a treatment? So that's the problem in the society actually. So therefore, this conference, Ashish is doing a wonderful job, in fact, to educate all our new and young healthcare professionals who can take the inspiration from the stalwarts like Dr. Raja and Dr. Sunil, and discuss some problems which you are facing day-to-day life, and then practice so that we can improve. Actually, of course, it is seen over the period of time, the diabetes has increased in the younger population of India because of junk food and something like that. So we have to make them understand, our people, that the lifestyle changing and the exercises and the diet, these are the three things should be controlled. So you can prevent the aging, you can do everything. In fact, fitness should be there. So therefore, this 7th International Conference, I extend my gratitude and sincere thanks to Ashish and Jigyasa having me here as a chief guest. I'm really proud and very honored to be here in front of you, and I congratulate Dr. Ashish, many more conferences like this. So thank you very much. Enjoy the conference.
Thank you very much, sir, for your kind words. And आखिरी में मैंने अमरेंद्र को जानबूझ के रखा था क्योंकि वो उसका जो वक्तव्य है वो आप सुनिएगा कि इंटरनेशनल लेवल का है कि नहीं है. 2 शब्द आपके.
Rings and jewels are not gifts, but are mere apologies for gifts. A true gift is a portion of thyself. स्टार्ट मैं इंग्लिश में इसलिए करता हूँ क्योंकि अपने देश में अभी तक जब तक आप अंग्रेजी ना बोलें बड़े आदमी नहीं माने जाते आप. मगर मैं आशीष सर के लिए बोलना चाहूँगा कि वो व्यक्ति जो सबसे पहले कोई नया स्टेप लेता है, जो लोगों को राह दिखाता है, उसको सबसे ज़्यादा क्रेडिट देना चाहिए जनक होने का, किसी चीज़ का सृजन करने का. तो जबलपुर में इंडिविजुअलिस्टिकली कॉन्फ्रेंसों को चालू करने का और खासकर डायबिटीज़ पे कॉन्फ्रेंस को चालू करने का श्रेय आशीष सर को जाता है. इज़ अ वेरी हम्बल पर्सन. कभी उन्होंने सामने से आके ऐसा किया नहीं. कभी वो हालांकि आईएमए या हमारे अस्पताल संघ की किसी पोस्ट पे नहीं रहे, बट जब भी कोई भी कॉन्फ्रेंस हुई हमारी आईएमए की, तो उसमें आशीष सर हमारे हो गए, जिज्ञासा मैम हो गए, हमेशा उन्होंने बहुत ज़्यादा हमको सपोर्ट किया. सो थैंक यू सो मच फॉर दैट सर.
थैंक यू.
स्टेज पे सभी बैठे हुए अतिथियों को मैं अपना प्रणाम प्रेषित करता हूं, मगर 2 लोगों के बारे में अगर मैं ना बोलूं तो ठीक नहीं रहेगा स्टेज से. एक बहरानी साहब हैं. हम लोग छोटे छोटे बच्चे हुआ करते थे और मेरे दादाजी पिताजी के समय पे वो हॉस्पिटल में आते थे, तो हम लोग देखते थे एक डॉक्टर साहब हैं जिनके पीछे के जो जूते का पार्ट है वो ऐसा मुड़ गया है. आज के ज़माने में वो समझना मुश्किल है मैं क्या बोल रहा हूँ. मतलब जूते के पीछे का पार्ट ऐसा मुड़ा हुआ होता था क्योंकि वो इतनी जल्दी में होते थे कि वो जूते बेचारे नहीं पहन पाते थे, उसी को वो मोड़ के रखते थे और अपनी जेब में यूज टू कैरी आलू के रोटी के अंदर आलू के मतलब आलू और रोटी उसके ऊपर से ऐसे रोल्स, क्योंकि उतना टाइम उनके. तो ऐसे करके उनने जबलपुर के अस्पतालों को चलाया है, जबलपुर के अस्पतालों को सींचा है और जो बड़े बड़े कई डायरेक्टर्स बने घूम रहे हैं वो उनकी वजह से घूम रहे हैं. सो थैंक यू सो मच बहरानी साहब. मैं उनको बहरानी साहब ही बोलता हूँ. और दूसरे हमारे व्यक्ति जिनके बारे में मैं बात ना करूं, परिमल सर के बारे में, तो अभी पूरे वर्ल्ड में एंटी एजिंग का एक बहुत बड़ा कॉन्सेप्ट है और उस एंटी एजिंग के जनक जो मेरे जैसे जूनियर्स को अपने ऊपर प्रमोट कर देते हैं, और ऐसी कॉन्फ्रेंस जबलपुर में वो हमारे अभिषेक श्रीवास्तव सर के साथ मिलकर करते हैं, इंटरनेशनल कॉन्फ्रेंसेज ऑन एंटी एजिंग एंड एंडोक्रोनोलॉजी. तो इनका नाम मैं ना लूँ तो इट इज़ नॉट पॉसिबल फॉर मी. सो थैंक यू सो मच परिमल सर फॉर कमिंग एंड ब्लेसिंग अस टुडे. दीज आर लेजेंड्स ऑफ जबलपुर. एंड आशीष सर के लिए तो और मैं जितना बोलता जाऊं वो दिन पूरा नहीं होगा, बट जबलपुर की इसके पहले जो पहली आईएमए की इंटरनेशनल कॉन्फ्रेंस हुई थी ग्लोबल कॉन, उसमें नियम होता है कि आपको 10 इंटरनेशनल स्पीकर लाने पड़ते हैं. अब आशीष सर मेरे को लगता है कि डॉक्टरी में नहीं आते तो बहुत अच्छे पॉलिटिशियन भी हो सकते थे, एक्टर भी हो सकते थे, कुछ भी. ही इज एक्सेलेंट इन एवरी वे, क्योंकि 10 में से 4 इंटरनेशनल स्पीकर उन्हीं ने ला दिए. वो एक मैडम जिनको लाए थे उनका पोस्टर में मैंने फोटो भी देखा. तो सर इज अ इंटरनेशनली कनेक्टेड मैन. थैंक यू सो मच एंड कॉन्ग्रेचुलेशन फॉर अ वेरी गुड कॉन्फ्रेंस.
इनोवेशन का ये एक और नजरिया है. MMRF स्पेशल डॉग्स, दीज आर स्पेशल डॉक्टर्स. Mahi Medical and Research Foundation. So thank you, respected dignitaries, and after this inauguration ceremony, we will have some award function. We have a small award function which will be given by our chief guest, Dr. Navneet Saxena sir, and our team which is sitting on the dais. भंडारी सर आए नहीं, अनुराग चलेगा, यहाँ पड़ेगा ना, नीचे देना पड़ेगा. Sir, please come here.
MP20 CH 5203 जिसकी भी गाड़ी है प्लीज एक बार की दे दीजिएगा कार की. MP20 CH 5203 रैपिड.
सर कैंडल थोड़ा सा लगा ही देते ना सर, जब इतना हम मत लगवा यार कैंडल चढ़ना. हो गया लीजिए बस. थैंक यू.
अवार्ड सेरेमनी के लिए सबसे पहले मैं बुलाना चाहूंगा डॉक्टर मोहन लालवानी को. जोरदार तालियां, पीछे म्यूजिक लगाइए, सिंपल म्यूजिक अवार्ड वाली. डॉक्टर मोहन लालवानी को NDID लाइफ टाइम अचीवमेंट अवार्ड दिया जा रहा है. जोरदार तालियां. ये आप पढ़ो, इधर इधर से आओ. इसके बाद ये डॉक्टर TK को NDID ये वाला, हाँ, ये बोलना है. एक माइक ले लो.
Dr. TK Saikia, Most Compensated Doctor Award. Welcome, sir.
डॉक्टर स्वराज नायक मैडम, प्लीज कम ऑन द स्टेज. जोरदार तालियां हो जाएं. NDID अवार्ड ऑफ एक्सीलेंस इन फील्ड ऑफ ऑब्स्टेटिक्स एंड गायनेकोलॉजी. मैडम ने गायनेक फील्ड में इतना पास हो जाए. मैडम पूछ रही थी कि मैंने क्या किया है. अब यही तो बड़े लोगों की बात होती कि मैंने कुछ नहीं किया, पर जबलपुर के लिए बहुत कुछ किया. जोरदार तालियां. थैंक यू मैडम. नेक्स्ट इज डॉक्टर दीक्षा सोनी. ये उभरती हुई सितारा है हमारे यहाँ, बहुत ही चार्मिंग यंग लेडी. NDID राइजिंग अवार्ड जाता है डॉक्टर दीक्षा सोनी को. NDID राइजिंग स्टार अवार्ड
डॉक्टर उमेश चंद्र रत्नाकम. वेलकम सर.
उमेश, डॉक्टर उमेश, नेक्स्ट। नेक्स्ट बताओ। डॉक्टर यू महेश, डॉक्टर शिशिर सोनी, प्लीज कम ऑन द स्टेज फॉर NDID Award of Excellence in Field of Cardiology, प्लीज। नेक्स्ट कौन है? हाँ सर आ गए ना। नेक्स्ट कौन है देखो, आइए। जोरदार तालियां। इनके जैसा नॉलेजेबल बंदा आपको कार्डियोलॉजी में, ही इज अ वेरी वेल थरोली कार्डियोलॉजी फील्ड में इनका जैसा एकेडमिशियन मैंने नहीं देखा है।
Just want to share one information. This Sony and his wife Jaya, they are the assets of the super specialty hospital. I'm really proud of them.
फोटो ले लो। हो गया? आए नहीं? कहाँ है? डॉक्टर संदीप अहिरवार, डॉक्टर शिल्पा सोमशेखर मैडम इज हियर। नेक्स्ट। Dr. Sanjay Nema sir, please come on the stage. He has received NDID Best Community Service Award. तालियां वाला बजाओ भाई, कोई बड़ा बड़ा आवाज थोड़ी लाउड तालियों वाली। आइए सर के जैसा सरल और हंसमुख डॉक्टर आपको जबलपुर में कोई मिलेगा। He is very humble and always ready to be with us. इसी क्वालिटी को हम लोग सलाम करते हैं डॉक्टर संजय नेमा सर। नेक्स्ट डॉक्टर अनिल जैन सर, सब शादी में बिजी है। डॉक्टर प्रशांत पुनेकर सर, प्लीज कम ऑन द स्टेज। he has received NDID Best Teachers of Teachers Award from NDID Society. डॉक्टर प्रशांत पुनेकर सर।
Few qualities of Prashant. The medicine department of NSCB is known by him. Any consultant, any paramedics, class 3, class 4, nursing officer, father, he's always looking for Prashant. If the Prashant is there, then he'll come to the OPD, otherwise not. So Prashant is a great man and serving the medical college very nicely.
अगला अवार्ड जाता है हमारे गाडरवारा के बहुत ही सीनियर फिजिशियन डॉक्टर DS चौधरी सर को। प्लीज सर कम ऑन द स्टेज। बहुत बहुत बधाइयां सर को। इनका जो मेडिकल सर्विस की तरफ जो रुझान है और इतने सालों से ये सेवा कर रहे हैं लोगों की, उसके लिए बहुत बहुत आपको आभार सर और बहुत बहुत बधाइयां। थैंक यू सर। अगला अवार्ड जाता है डॉक्टर अमरेंद्र पांडे जी को, NDID अवार्ड फॉर एक्सेलेंस इन फील्ड ऑफ डर्मेटोलॉजी, जो इन्होंने जबलपुर में रहकर नए नए आयाम स्थापित किए हैं फील्ड ऑफ डर्मेटोलॉजी में, उसके लिए इनको अवार्ड ऑफ एक्सेलेंस दिया जाता है। और ये अगर नहीं होंगे तो फिर नर्सिंग होम एसोसिएशन की बैंड बज जाएगी, लेकिन इनके रहने से सबको सपोर्ट मिलता है। और कल इन्होंने एक वो वीडियो डाला था कि हमको सबको इतना यूनाइट रहना है, जब वकील के साथ कुछ हुआ तो कम से कम 1000 वकील वहाँ पे खड़े थे। तो ऐसे ही कभी किसी डॉक्टर के ऊपर कोई प्रॉब्लम आती है तो सारे डॉक्टरों को रहकर हमें उसके साथ रहना चाहिए और कोई भी माई का लाल हमको हाथ नहीं लगा सकता है। तो इसलिए हमको सबको साथ में रहना है, सबका साथ सबका विकास। नेक्स्ट अनुमति जैन मैडम, प्लीज कम ऑन द स्टेज। इनको अवार्ड जाता है NDID अवार्ड ऑफ एक्सेलेंस इन द फील्ड ऑफ न्यूरोलॉजी। मैडम का जो सरल स्वभाव है और शी इज ऑलवेज रेडी टू हेल्प द पेशेंट्स। फोन करो चाहे कुछ भी करो लो, शी इज ऑलवेज अवेलेबल फॉर द हेल्प ऑफ द पेशेंट्स। इसीलिए ये अवार्ड दिया जा रहा है अनुमति मैडम को।
about Anumati and Neeraj, I think when I was dean also in 17-19, so they came to me and they said that I am going for a higher study, we want to go. So there are certain rules to go in a higher study, but both of them went, then they have to come back and serve the primary college. So now she is serving in the super specialty, and Neeraj also doing a wonderful job in the super specialty. We are proud to have you here. Thank you.
नेक्स्ट अवार्ड जाता है कर्नल पीएन गुप्ता सर को. प्लीज कम ऑन द स्टेज. एंड उनको अवार्ड जाता है एनडीआईडी बेस्ट कम्युनिटी सर्विस अवार्ड. मिलिट्री में सर्विस करते हुए इन्होंने डॉक्टरी के साथ साथ जो सर्व किया है मिलिट्री के संस्था को. ही इज डॉक्टर कर्नल पीएन गुप्ता रिसीविंग एनडीआईडी बेस्ट कम्युनिटी अवार्ड. जोरदार तालियां. तालियां बजती रहे. खाना तैयार हो गया है. और ये लाओ ना. और मोमेंटोस फॉर द चीफ गेस्ट. प्लीज ब्रिंग द मोमेंटोस. जोरदार तालियां हमारे डीन सर के लिए. अरे के वाला ले लो. ये वाला ले लो.
पीवी सेक्टर चल रहा है. सिल्वर और पावर भी.
थैंक यू सर. थैंक यू फॉर बीइंग विथ अस. बहरानी सर को फेलिसिटेट करना है क्योंकि ही इज ऑलवेज देयर विथ ऑल ऑफ अस इन द ऑल द एकेडमिक फीस्ट. उनका आशीर्वाद हमारे जबलपुर के लिए वरदान है. डॉक्टर डीएस बहरानी सर, डॉक्टर परिमल सर चले गए हैं. आ गए. हाँ हैं. तो पहले ये कर देते. सर यहाँ सेंटर. स्वामी सर का सम्मान करते हुए हमें बहुत खुशी हो रही है. सर ने हमें सिखाया है कि न्यू इनोवेशंस को कैसे एक्सेप्ट करना है. कोई भी उम्र हो आपको नई चीज़ें जरूर सीखना है और उससे मेमोरी लॉस भी नहीं होता है. हर दिन नई चीज सीखिए. एक हमारे डैशिंग अमरिंद भाई, प्लीज कम ऑन द स्टेज. एक शॉल मिल चुकी है क्या पहले? ये तुम्हारा वाला. ये ले बुके. बुके ला. बुके हो गया. नीचे से जोरदार तालियां. सामने देखिए. इधर आ जाओ. अमरिंद भाई सबका साथ सबका विकास हमें सिखाते हैं हमेशा. और कोई भी गलत चीज होती है तो उसमें हमेशा हमारे लिए तत्पर खड़े रहते हैं. और उनके लिए उनके जैसा जो दमदार व्यक्तित्व हमारे जबलपुर को है वो बहुत बहुत बधाइयाँ. और इसके बाद हम लोग ऋचा शर्मा मैडम, प्लीज कम ऑन द स्टेज. थैंक यू.
रिचा के बारे में मैं कुछ बोलना चाहूँगा. रिचा एट प्रेजेंट ही इज IMA प्रेसिडेंट, यस, एंड डेप्यूटी सुपरिटेंडेंट ऑफ माय कॉलेज. इतनी रिस्पॉन्सिबल है
इतने डिपेंडेबल है, जो काम आपने ऋचा को दिया, मान लीजिए इट इज डन, तो मेरी आधी से ज़्यादा वो जो टेंशन रहता है वो ऋचा से सॉल्व हो जाता है। और ऋचा ने मुझे बताया, आई डोंट रिमेंबर when the MP in Raipur was, not a separate state, so I used to go to examination at Raipur. So she told me that I was the examiner for her to giving a DMS examination. PG examiner. So she is wonderful lady and wonderful person. Thank you.
Rakhi Bajpayee madam, please come on the stage for felicitation. Tips. स्वामी सर चले गए क्या? चले गए, ठीक है। तो अभी हम राजा राम जो अमेरिका से आए उनका लेक्चर सुन के 5-7 मिनट बाद लंच चालू करेंगे। उसके लिए आप लोग क्षमा चाहते हैं, थोड़ा सा लेट हो रहा है क्योंकि उनकी फ्लाइट है और अमेरिका से आए हैं और उनका लेक्चर सुनना बहुत ज़रूरी है। तो राजा राम प्लीज़ कम ऑन द स्टेज। चेयरपर्सन प्लीज़।
I request our chairperson, Dr. T.C. Korea, sir, Dr. S.K. Rai, sir, and Dr. M. Korea, ma'am, along with Dr. Prashant Punekar, sir, to take a seat. I also request Dr. Rajaram Karne, sir, from Colombia, who will be speaking on a topic, effective lifestyle modification for treatment of obesity. I request our chairperson to take a seat. Dr. T.C. Korea, sir, Dr. S.K. Rai, sir, Dr. M. Korea, ma'am, and Dr. Prashant Punekar, sir, to take a seat.
कुछ होगा, कोई भी प्रेगनेंसी हो, डायबिटीज फोटो कुछ जब तक सब सेट हो रहा है एक लकी ड्रॉ और निकाला जाए, उठाइए। नवनीत सर, हम लोग हर घंटा एक लकी ड्रॉ निकाल रहे हैं, तो प्लीज आप आ जाइए और एक लकी ड्रॉ निकालिए। ये किसका रह गया? हाँ, गिफ्ट्स बांट रहे हैं आज, थोड़ा थोड़ा जो अच्छे क्वेश्चंस पूछते हैं निकालिए, इसमें से 2। तो जो हमारे लकी विनर हैं, अभी हमने रजिस्ट्रेशन नंबर लिखे हैं 164, तालियां हो जाएं। अभी नाम बताया जाएगा। 164 नंबर, पहले 7 और 40 आया था, तो जिसका भी वहां रजिस्ट्रेशन नंबर 740 है वो हमसे संपर्क करे। और 164 अगला लकी नंबर है 68। अभी ये हर घंटे खुलते रहेंगे। थैंक यू।
It's my privilege to present Dr. Rajaram Karne sir. He is presently practicing as an endocrinologist, co-director weight management program, Central Ohio VA Healthcare System, Columbus, USA. He has many major achievements. He did MBBS and MD medicine from Miraj Medical College. He did DMA endocrinology from KEM Hospital, Mumbai.
Shyam Gupta sir, please.
He is
chairperson.
Did internal medicine residency at Bronx Lebanon Hospital in New York. He has fellowship in endocrinology at National Institute of Health, Bethesda, Maryland. He is a faculty at Ohio State University, Columbus, Ohio. He is a founder member of Columbus Endocrine Society. With this background, I present him before you for his talk. Over to Dr. Rajaram Karne, sir.
Thank you. Okay, so we are going to talk about lifestyle modification in a culture or in a association where most of the interventions are pharmacological, and lifestyle, we are actually talk a lot about it, but we do not really pay so much time or attention. We don't have time in our practice. So I'm trying to just focus on how powerful, how important it is that we need to use this in diabetes and obesity. So this term is actually a disuse syndrome. Every part of the human body, you either use it or lose it. If you don't use your brain, it degenerates. If you don't use your muscle, they get weak. And okay. And the sedentary lifestyle is the very serious worldwide problem. It progressively has increased over several decades, and that's why we are seeing the explosion of diabetes in South Asian countries, is because 50, 100 years ago, we had very active physical lifestyle and scarcity of the food. That equation has exactly gone opposite. We humans are not programmed to be physically inactive. And most of us, our work is 7 to 8, 10 hours of sitting with very little room or time for the physical activity, and we automatically become office worker, doctors, many others, physically inactive. It's actually a major risk factor for premature death. In fact, there is a term floated by some as a sedentary death syndrome, because it is a precursor of many chronic medical conditions. One paper describes that in the United States, 2/3 of the major causes of death are related to lifestyle. You can actually call it as a cause of major death. And 15% of 1.6 million newly diagnosed. We talked about prevalence, now we are talking about incidence in each year are due to sedentary lifestyle. So it's very important to talk about this. This is a long list of physical inactivity associated diseases. We all know that. Now when it comes to the obesity, it actually progresses through different phases. In the very early phase, when it is triggered by physical inactivity. Now this is very common. If you have an athlete or active duty soldier or person working in the warehouse, they can eat anything, but they are still lean. The moment the athlete stops competing, soldier gets retired or someone gets a job like me, that's the initial stage of beginning of obesity. And it is super compounded by the excess diet. Now, Madam referred to our culture. The excess diet is actually new part of the culture. Previously, again, 100 years ago, it wasn't that available. Now, or cow, the forceful eating of the culture and everything, whether it's a game, whether it's a birthday, whether it's a wedding, the feast is compounding to the decreased activity. So, simple formula. You gain weight when your intake exceeds your spending. Your weight is stable when they are matching, and when we want to lose weight, we want to reverse the equation by less intake relative to spending. Very simple, but it gets slowly complicated. So for a given physical activity, more the intake, more is the weight gain. So I'm giving it pictorially. This is not exactly to the scale, but when you are very high on the physical activity, but you start increased eating, you will gain weight. But focus on the slope. When your physical activity is less, for a given food increase, your weight increases more. and for less, and when you have a very minimal physical activity, even with a 1200 calories intake, you will gain weight. So any advice of the weight gain or the diet or the exercise is not isolated. It is a combination of how much intake you are doing for how much physical activity. The second layer of this equation is chronicity. In a short term, you change the equation, it doesn't last longer. If I go to a yoga retreat and lose 10 pounds in 10 days, when I come back, I gain it back. So the second layer on this is a chronicity. The net change between eating and spending has to be chronic to set up a long-term problem, and that's the current conundrum, is we don't know how chronic is chronic. Is it weeks, months? We don't know, but definitely years. If you have a stable spending or eating habit for years, then that becomes chronic, and that's where the obesity gets set in. So lifestyle changes, if you want to reverse it, if you want to go back to the healthy lifestyle, it is first best done when you are in the initial phase, but if you are already chronically set, you have to do it for a long period of time. I mean, a lot of people say, I went to the gym for 6 weeks and I didn't lose any weight. It's not yet set into your chronicity. Once chronic, now this is the problem with obesity. Once you get chronically weight gain, it is not just limited to the weight. Then your joints start affecting. Then you get the cardiopulmonary deconditioning. You can't make active. So there are secondary changes from the weight itself. They prevent you from getting back on the healthy lifestyle. So alone lifestyle changes are not sufficient in the late stage. You need additional medication. But in the early and middle, you can do it. There is one topic keeps on coming on all the conferences, that's saying if you tell somebody to change your lifestyle, you are actually shaming that person about them. You are saying that, hey, there is nothing wrong with you, but we are saying that you should have done enough. So a lot of people say that don't tell them, you should have, it's not their fault. Obesity is a disease. I think there is something in between. Instead of saying lifestyle changes do not work, you need GLP-1, what we say is lifestyle alone is not enough. You have to do it no matter what. If that is not enough, you need an additional benefit, because if you do not do any lifestyle, no medication will work. So at every stage you need to change the lifestyle, but any medication, any alternative that is proposed to weight loss will not work. It is not effective if your lifestyle is not changed. So this is a very simple picture here, that we eat 3 times a day, but our basal metabolic rate is continuous day and night. So how does the energy gets distributed over the time during the day? So we take a meal. Now we are not using all those calories while we are eating in those 15-20 minutes. So postprandially, part of the energy or the calories are stored in the liver glycogen, which is about 75 gram. Part is stored in the muscle glycogen, which is about 400 gram. And then in the rest of the period, when we need food, we use those glycogen. So by the time we eat the next meal, the previously eaten food is used up, and now we are ready for the next meal. So that's how we keep the weight stable. Now the problem comes when we eat more than what we spend between the meals. So for example, if we eat a big meal, now as some will be stored, but by the time we are ready for the next meal, the previous calories are still hanging out. Now you take another big meal, here not only just the next big meal, but the previous calories are sitting there to be consumed, and which we don't because of lack of activity. So by the time we eat the next meal, we have enough and more surplus. So no activity, more eating, add surplus after surplus after surplus, eventually it goes into storage into fat. So how do we reverse that? How do we avoid that? Number one, now that you have a surplus, we need to reduce. So just eating matching will not work. We have to do the negative balance. We have to spend more and take in less. That's the beginning. Two ways it can be done. One is you push the meal ahead, which means if by the time you are ready, you are not hungry, you extend it forward, which is basically, I'm talking about intermittent fasting. What we do in the intermittent fasting is we prolong the time period between the two meals so that the previous surplus will be used and then there will not be present for the fat collection. Another way to do that is increase the exercise. So fundamentally, intermittent fasting and exercise work in the same way. They consume the excess food before you eat the next one, either by prolonging the eating or by spending more. So this is the basic principle of, and then the fat will shrink if you do these two things. So another pictorial information about diet, exercise, and weight gain relation. Say for example, if you are lean and gaining weight in the forward direction, your physical activity is less and excessive diet in comparison with physical activity. So that's how you gain. But when you lose, the equation is very interesting. You need calorie reduction for weight loss, period. If you do not reduce the calories, you will not gain the weight loss. You have to induce it, but at the same time, you need physical activity to maintain the lost weight, to prevent the gain. Now this is important. You lose weight just by dieting, you will invariably gain it back if you don't exercise, because you lose the muscle, you lose the BMR, and even the cut portion. Many people have done this. They go for dieting, they lose initial 10 kilos, and then nothing happens, no matter how much you diet. In fact, little bit loss in the control gains you the weight. Why? Because physical activity is required to maintain the lost weight. So again, diet will reduce the weight, physical exercise will prevent the weight regain. And if you have the physical exercise before you gain the weight, you will probably not gain the weight. Here I'm going to emphasize the hazards of only diet. Now, I'm specifically bringing this slide because most of the people, when they talk about weight loss, they talk about diet. Because there is exercise doing is hard and it doesn't work because short run. What happens when you do the just calorie restriction? Now here we have the obesity with all its complications. If you restrict the diet, it will lose the basal metabolic rate, it will reduce the bone density, it will reduce the muscle mass. Somebody was bringing up sarcopenia. It is always part of the weight loss. It will cause osteopenia, disability, decreased quality of life, and fall. So just imagine somebody is thrown on the island and no food for 2 months. They will lose weight fantastically. On the weight scale, they will lose a lot of weight, but they will not be healthy because they have lost tremendous amount of muscle and eventually the bones. So when you add metabolic strength exercise, you can reverse this by maintaining the muscle mass, maintaining the metabolic rate, and then it will prevent these outcomes, unhealthy outcomes of the dietary, I would say isolated dietary reduction. Also does the decrease in the future incidences. There is also improvement in the all-cause mortality and cardiovascular rates. So last 2 slides, people ask me what physical activity you need. These are the guidelines by American Heart Association and Sports Medicine. You need about 30 minutes, 5 days a week of moderate, or 20 minutes, 3 days a week intense exercise. That's the basic minimum. And these recommendations are same, but intensity changes over the time. And even 15 minutes every day says your all risk mortality by 14% decreases. So, my thoughts, take home points is, exercise prevents weight gain, diet control induces weight loss. Chronicity is the key, needs to be done over the long period of time. No health or weight loss program can be serious if it does not include dietary control and, I'm specifically highlighting and, structured and monitored physical activity. Diet alone is very dangerous. It should be combined with exercise. And if your work hours do not permit inbuilt exercise, like my job, my work doesn't have exercise, so I have to find time to do the physical activity at least to make the minimum standards. And if you don't find time for exercise today, tomorrow you will have to find time for doctors. That's it. Thank you.
Thank you, sir. House is open for questions.
Of course, of course.
Fuel eating is a pattern
Yes.
which animals also take.
Yes.
But as per humans, we have gone for fun eating or hedonic eating or a fog eating. These are also the pattern which are causing obesity. So we should be telling our patients to change our pattern of eating also, sir.
Absolutely. This was focused only on calorie reduction. We are not very much trained in med school to give a expert advice how to do that. So dietary counseling is the next part of achieving that calorie reduction without preventing the balanced diet. So we have to have a balance of the diet. Overall reduction is important, then comes the composition. And for that, theoretically, I mean practically also, we need help from the nutrition expert. We can't do that in 10 minutes of our medical consultation. Similarly, we need an exercise guidance because we are not trained on which exercise for 20-year, which for 80-year-old, and which for the person who doesn't have leg. We need an exercise therapist, just like the nutritional therapist, who actually will tailor a program for a given person how to exercise and how to progress it forward.
But the obesity is more rising only because of the dietary pattern.
Yes.
Diet. It is only also rising because of the fog eating and fun eating.
Agreed.
Because fog eating and fun eating components are more of a high calorie content.
Yeah. But remember, athletes eat the same food that we eat, but they don't gain weight. Yeah,
But they are for
that's the
fuel
difference.
eaters, fuel eaters.
Exactly. Thank you.
Raja, thank you for excellent talk. Over to chairpersons.
Thank you, sir, for a very excellent and informative talk and highlighting the role of lifestyle modification so beautifully. Thanks again, sir.
So I have one question. Come on the stage, sir. Are there any exercise prescription for patients that we are lacking in India?
We are lacking it in United States also. This is one of the big hole in the healthcare delivery that neither us nor the people are strongly given the information in a rational manner. We need that whole school. Just like in 1980s and the 90s, there was no dietary consultation. Now we need to look forward for exercise consultation with the expert.
Okay, thank you. Please come on the stage, Raja. So we will felicitate our speaker. Please bring that mementos. Sir, Prashant sir, idhar se. Thank you, sir. We will give a token of love to our chairpersons. Talia. Thank you, sir.
Thank you so much. As we move on ahead with our next session, I request Dr. Ranu Mishra ma'am, Dr. Sanjay Nema sir, Dr. Shishir Soni sir to
To chair
present
the session.
as a chairperson.
Sriram, please come on the stage for your
I
talk.
request Dr. Sriram Agrawal from Narmada Puram to be present on the stage as a speaker. He will be speaking on the topic ESV versus ADA guidelines for cardiovascular risk in diabetes. I request our chairperson to introduce a little bit our speaker.
So, Dr. Sriram Agrawal is a renowned cardiologist, and welcome Dr. Sriram. And straight away, I think he has
Sriram
various
has
papers.
traveled a long distance to our conference. Thank you. Over to you.
Okay. So, welcome Dr. Shriram Agrawal. He is a renowned cardiologist and he has very good academic commitments also, and he has various papers in the national and international journal. So, straight away it's over to you, Dr. Shriram. We are waiting for your lecture.
Thank you very much, sir, and all the delegates present here. So today we will be talking about. Hello. Yeah, so today we will be talking about ADA versus ESC guideline, what's new in cardiovascular management. So the newer things are basically greater emphasis has been put on prevention of ASCVD using cardioprotective agents. There is a more and more emphasis on the use of SGLT2 and GLP-1 receptor agonist. Along with that, better lipid management, the lower the better with that guideline, and the routine use of NT-proBNP in selected patients to detect subclinical cardiac dysfunction. So we will be seeing in the next few slides about SGLT2 inhibitor along with GLP-1 receptor agonist, and how LDLT targets remain low for very high risk, but guidance also recommend the usage of early recommendation of ezetimibe, PCSK9 inhibitors, inclisiran and bempedoic acid as and when needed. So straight away we will be moving on to the guidelines. So basically here reduction in the diabetes complication is from the ADA guidelines, and apart from glycemia management we have moved to other comorbidities like blood pressure management, lipid management, and agents with proven cardiovascular and kidney benefit, which we have in our bucket, SGLT2 inhibitor along with GLP-1 agonist. So this is a busy slide from American Diabetic Association, and we can see that the indication has moved from glycemia management to more and more for ASCVD and indicators of high CVD risk. So we have to control the subclinical atherosclerosis and high-grade inflammation which is going on in diabetic patient with the proven agents, either SGLT2 inhibitor or GLP-1 agonist as and when needed. Along with that, we can, if we move on to the chart, for obese patient, we have now GLP-1 agonist, which we have been talking throughout the session. We have tirzepatide, semaglutide, and other agents. So ADA 2025 continues to set patient-centered care. And as we have seen in the previous lecture, no one size fits all, and now individualized care is the need for the hour. So the agents now recommended are not just for glycemia management, but for cardiovascular and improving renal outcomes. So we basically can divide the patients into those with ASCVD and those with CKD, and those who are having ASCVD, we should use agents, those who have proven CV benefits like SGLT2 inhibitors. And this from ESC guideline, we can divide as per score 2. This is the scoring that the ESC has given. We can divide into mild, moderate, high, and very high risk. And based on that, you can see starting from the metformin to the lower risk group, we can straight away move to SGLT2 along with add-on to GLP-1 agonist at a very high risk group. So these are the key recommendations from the ADA. Basically, it emphasizes on the earlier use of SGLT2 along with GLP-1 agonist. And emphasis is more and more on SGLT2 inhibitors. Along with that, in the patients on CKD, finrenone has been put up as an additional agent and to be used at an earlier stage. Again, LDL remains the cornerstone, and the newer shift in the guideline is used in add-on agents as and when needed, and it has to be initiated at an earlier stage and not waiting for too long when the LDL targets are not met. So basically in people between 20 to 39, only consider statin therapies if there are additional ASCVD risk factors. We have very well established lipid guidelines and ASCVD risk calculators for the patients between 40 to 75 years of age, and we should use those calculators. So we all know, apart from statins, we have various agents now, starting from PCSK9 inhibitors, bempedoic acid, ezetimibe, and inclisiran. So again, this is the slide that apart from glycemia control, the other arm was the BP control, and the AHA guidelines are recommending to start straight away with combination pills. At least 2 of the agents has to be initiated, and they have to be followed, and preferably ACARBs has to be added in case of proteinuria or albuminuria. Antiplatelet, definitely secondary prevention, they remains the mainstay. For primary prevention, still the debate continues, and it has to be given only in high-risk patients and those who are having a low bleeding risk. One more caveat is screening for heart failure in all the high-risk group, and this can be done with NT-proBNP, and if they are elevated, then more closer collaboration with cardiologist and heart failure team has to be done. So these are basically 3 arms for all the diabetic patients we should be screening for, and these are coronary artery disease, heart failure, and peripheral arterial disease. So they has to be screened for. Already as alluded in the previous slide, SGLT2 with Finrinron, they are coming up way along, and they have to be initiated early on in the management of diabetic patient, and they should be regularly followed up. And also to be kept in mind are the side effect profile of SGLT2 inhibitor, basically more of genitourinary infection, urinary tract infection, and for the GLP we should look for GI side effects. So the main highlights are earlier combination therapy, shared decision making with cardiologists and allied teams, and use of biomarkers, that is natriuretic peptides. Along with that, earlier and more widespread use of interventional lipid strategy. We all know the injectable inclisiran, along with multidisciplinary care models. So now coming on to the ESC. Again, this is the busy slide for the glycemia management, and we can see the crux of the 2 guidelines remain the same, that it is not just the glycemia management but the subclinical ASCVD which has to be monitored, and the agents, those who are having proven cardiac benefits, they have to be used initially, including SGLT2 inhibitors and GLP-1 agonists. Only in the resource limited setting, they have advised for the use of sulfonylureas and thiazolidine diones. We have to risk stratify our patients into very high risk, moderate risk, and low risk, and this is based on score 2 and score 2 OP risk, and this is score 2 is for fatal cardiovascular event, and score 2 OP is for non-fatal cardiovascular events. And you can see the main highlights how we can risk stratify, and more than 20 is very high risk, 10 to 20 is high risk, and 5 to 10 is moderate risk as per score 2 classification. And based on the classification, we have various target levels to be achieved for LDL, and if it is at very high risk or extreme risk, the target for LDL is less than 55, and based on various risk categories, the target changes. Again, this is the same as I reiterated. Very high risk is more than 20%, and these are the patients which have to be very closely followed up. So glucose lowering agent, not just the glycemia management, but also those who have a proven CV safety benefit, including SGLT2 inhibitor and GLP-1 receptor agonist. They have to be initiated very early in the eligible patient, and particularly now what is coming up is the GLP will be very soon incorporated in HFpEF guideline in the obese phenotype of HFpEF patient. They will be very soon in the guidelines, and we all know SGLT2 inhibitor, they are one of the main 4 pillars in HFrEF management. So again, in patients with type 2 diabetes and CKD, ACARBs are the mainstay along with SGLT2 inhibitors, and Finrinron has to be initiated often all those who are having albuminuria and established CKD. Only thing is if EGFR less than 20, Finrinron has to be avoided, and for SGLT2, EGFR is less than 30. So for the management of cardiovascular disease in patients with type 2 diabetes, this is the chart giving us almost the same picture. There's those who are having, this is the CKM continuum, what is going on in the present CMEs, that it is a disease in continuum. It is not just involving the pancreas, but cardiac and metabolic as well. So we have to screen, we have to see the patient as a whole, and the screening has to be done for cardiac as well as metabolic profile, and so the drugs has to be initiated accordingly. Lipid management has to be definitely more aggressive, and They have told us to initiate non-statin therapies, particularly ezetimibe, PCSK9 inhibitors, inclisiran very early on if the target LDL is not met in the next 6 weeks. This is the LDL reduction, what can be achieved, and we all can see that the combination therapy of statin along with ezetimibe, bempedoic acid and inclisiran, they have a maximum reduction of LDL to close to 80%. And these are various charts showing various reduction of LDL from various agents. So I'll take 2 more minutes. So non-statin therapies has to be initiated early on. This is a class 1A recommendation, and bempedoic acid is recommended for patients who are unable to tolerate their statin therapy. All the patients had to be screened for NT-proBNP for a high-risk individuals, and if it is elevated, then they have to be taken into the close follow-up and also referral to a cardiologist. Again, HSCRP that has come up. HSCRP, it's a class 2 indication, and it is used as a tool for risk stratification, and elevated HSCRP may indicate residual inflammatory risk. So it's an ideal marker, and it is nowadays coming up in most of the profiles what the patient bring. And elevated HSCRP more than 3, it is an indicator of subclinical atherosclerosis. So ESC again sticking to the target of less than 130/80, and it highlights the integrated team-based care. Cardiology, diabetology, endocrinology and nephrology coming up together, and again advocating more and more use of SGLT2 along with GLP-1 receptor agonist. So these are the key comparison, whereas ADA is more patient-centered, individualized goal and shared decision making. ESC focuses more on integrated care, integrated cardiometabolic care and multidisciplinary collaboration. Almost both the guidelines are same as coming to BP and LDL targets, as well as for secondary and primary prevention. Whereas this ADA uses ASCVD risk calculator, ESC recommends score 2 and score OP risk scoring. So these are the initial drug recommendations, both of them sticking to SGLT2 and GLP-1 receptor agonists, whereas blood pressure targets are not much different, and lipid management both recommend treat early and as low as possible with statin and non-statin based regimes. So these are my key takeaways. Basically more and more use of GLP-1 receptor agonist, SGLT2 inhibitor, and also very important take-home message is usage of HSCRP as an indicator of subclinical atherosclerosis. Thank you.
Thank you, Dr. Sriram, for the crisp presentation.
Sriram, for an excellent talk. Chairpersons, please come on the stage for felicitation. Momento, please. Thank you, sir, for coming. तालियां हो जाएं, इसके बाद लकी ड्रॉ निकालेंगे। वो नाम अनाउंस करना आशीष, जो जिनका था ना, ये आपका है, ये मैडम को दीजिए। मैडम, हाँ, तालियां बजती रहें। थैंक यू। डॉक्टर ललित सर, एक और लेके आइए मोमेंटो। हाँ नहीं, वो एक और। डॉक्टर विवेक, प्लीज कम ऑन द स्टेज। अभी जाना नहीं है, लकी ड्रॉ खुलने वाला है 10 मिनट में। थैंक यू वेरी मच। ये डॉक्टर विवेक अरोरा है, हमारे ऑप्थेल्मोलॉजिस्ट, रेटिना स्पेशलिस्ट। आज बच्चों का भी टाइप 1 डायबिटीज का प्रोग्राम नीचे चल रहा है, एजुकेशन प्रोग्राम, जिसमें कि बच्चों को हर फील्ड के बारे में कि इंसुलिन कैसे लगाना है, आंखों का क्या देखभाल देना है। तो ये सेकंड JD-CON, जो कि पहली बार पूरे मध्य प्रदेश में जब बच्चों के लिए जो कॉन्फ्रेंस की जा रही है वो पहली बार माही मेडिकल रिसर्च फाउंडेशन द्वारा की गई है और ये उसका दूसरा संस्करण है। तो उसके लिए हम सर को बहुत धन्यवाद देते हैं कि बच्चों को उन्होंने आंखों की कैसे देखभाल करनी है टाइप 1 डायबिटीज के बच्चों को, उसके बारे में उन्होंने जानकारी दी। तो जोरदार तालियां विवेक सर के लिए। Thank you. Next talk is of Dr. Deepak Behrani sir. Chairpersons please.
I request all the chairperson,
Abhishek
Dr. Abhishek
Chairperson.
Srivastav sir, to be present.
Rajkumar sir.
Dr. Rajkumar Jain from Sehora.
Doctor, sir, your good name?
Brigadier Sir, Satyanand. please be
Brigadier
present.
Satyanand sir, please come on the stage.
The speaker, Dr. Deepak S. Behrani sir from Jabalpur. He will be speaking on the topic stepping up to
Speaking about doctor, I am very new to Jabalpur, friends. I have just joined Apollo Hospital 2 months back. But what I have heard about Dr. Behrani sir is a simply great human being, great doctor, and talking anything about Dr. Behrani sir is like throwing a torch on the sun. So let's hear from Dr. Behrani sir about today's topic. Thank you so much, sir.
Thank you, chairpersons. First of all, I would like to thank Dr. Ashish Dengra for giving me this opportunity to interact with you. Today's topic is stepping up towards a transformative health-centric approach to obesity care. So, there is a lot of emphasis on the diet. In the obesity, diet is very important for weight loss, and we need to change our food habits, and we should be well aware about what to eat and what not to eat. But without exercise and diet, the management of obesity is incomplete. And you know that it is important that one should have the different types of the exercises to achieve the weight loss. Previously we are having the bariatric surgery, which causes 25 to 35% weight reduction. But the bariatric surgery has got some complications, some risk factors, and some death rates also. 1 in 10,000 may be the complications occurring with bariatric surgeries. There was an unmet need which was filled by the two blockbuster molecules, the Wegovy and the Mounjaro. Today we will be discussing about the semaglutide injectable. The agenda are understanding the global and Indian obesity landscape, effective management of the obesity, the clinical evidence and benefits of semaglutides, its role in cardiometabolic risk reduction beyond weight loss. Obesity is a global health problem. 1 billion people are affected by the obesity. There are 764 million adults. 86 million adolescents are having obesity, and 71 million of the children are having obesity globally. In India, 254 million people are having obesity, and 351 million are having abdominal obesity. That is very important for us to understand and treat it. Increasing weight is related to cardiovascular deaths. 70% of deaths related to obesity are due to cardiovascular causes. And there is a threefold increase in the cardiovascular death rates in the obese people. There's a progressive weight loss, has dose-dependent and tissue-dependent biological effects. You will see the 5% weight loss will have some effect on the liver, insulin sensitivity, liver triglycerides, beta cell function, muscle insulin sensitivity, the gene expression, the abdominal adipose tissue insulin sensitivity, and inflammatory markers. If you got the more than 11% weight loss, you see the biological effects of the weight reductions are manifold. The 10%, more than 16% or 15% weight loss has got even the robust benefits in the biology of the obese people. So, involving the health beyond weight loss should be an explicit goal of the long-term obesity management, because obesity affects the heart failure with preserved ejection fraction. We need to have the glycemic control, liver disease, the fatty liver, the musculoskeletal problems with the joint problems with the obesity, mental health problems and quality of life. All these are to be addressed in the obesity management. Till now we are having, with the diet and exercise, we can get 3 to 5% weight loss. With bariatric surgery, we are having 25 to 35% weight loss. And there was a gap between these two subsets. And now we are having 15 to 20% weight loss with the pharmacotherapy, with the semaglutide injectable. So a treatment gap was existing. Now the unmet needs have been fulfilled, and this gap has been fulfilled with the two important molecules in the obesity management. So introducing the important molecule semaglutide 2.4 milligram. Semaglutide is a human GLP-1 analog. It's 94% similar to the natural GLP-1. It acts on the hypothalamus and hindbrain. It reduces the satiety, increases satiety and reduces the craving for the food. So semaglutide 2.4 milligram is a GLP-1 receptor agonist that works in the key areas of the brain to help control the hunger and craving. Homeostatic regulation, semaglutide 2.4 milligram increases satiety, making your patients feel less hungry. And hedonic regulation, semaglutide 2.4 milligram reduces food craving and preferences for certain foods. Semaglutide 2.4 milligram phase 3 trials have shown that there is up to 18% weight reduction. And the weight loss was more than 20% in 33% of the patients, and it is sustained for more than 4 years with semaglutide. So there were various trials, step 1, step 3, step 4, step 5, with various cohorts, and the mean weight loss was 18.2% with semaglutide 2.4 milligram once weekly. There was 5% weight loss in 90% of the patients, and 75% patients they show the 10% weight loss, 50% patients they show the 15% weight loss, and 33% patients they show the 20% weight loss. So across all the cohorts, we can get benefits from 5% to 20% of the weight loss. 1 out of 3 participants had, with the semaglutide 2.4 milligram, more than 20% weight loss. That is very important. Semaglutide 2.4 milligram was associated with reduced total fat mass. The total fat mass reduction was by 4%, but the lean body mass proportion was increased by 3.5%, which is very important. So fat mass and lean mass by the DEXA scan they have calculated. The weight loss benefits of the semaglutides, greater weight loss up to 21% seen with higher dosage of the semaglutide in a step-up trial. When the semaglutide 7.25 milligram was used, more than 25% of the body weight reduction was seen. So the semaglutide achieves more benefits to the patients of the obese personality. So there's a beyond weight loss, the waist circumference was reduced by 16.3 centimeter. The systolic BP was reduced by 10.9 millimeter. HbA1c was reduced by 1.9 millimeter, and triglyceride was reduction by 22%, and CRP reduction was 63%. So all the important other parameters were addressed by the semaglutide 2.4 milligram. And one more important point, that there was, out of 10, 8 people with pre-diabetes demonstrated reversal to the normoglycemia. So it works in pre-diabetes also. It reduces the HbA1c by 1.9%, and more than 82% patients, they had the target of the HbA1c at 7. More than 72% patients, they have got the HbA1c target of the 6.5. So it is a drug which can achieve the HbA1c on target or on goal, 82%. It is a drug which is widely studied in 17,000 patients, and it is one of the largest cardiovascular outcome trial. So it is the only drug approved by US FDA for the diabetes also, for the obesity also, which has got the definitive cardiovascular outcome benefits. Only anti-obesity medication with proven CV benefits. You can see the curve and the reduction of the cardiovascular outcome was seen. In the 80% of the patient, the MACE reduction was seen with the semaglutide 2.4 milligram. In the real world, 57% of the MACE was reduced in majority of the trials. And the another aspect of the semaglutide is that it affects the liver. It improves the MASH. In 37%, the proportion patients, they improved the fibrosis with no worsening of the osteoarthritis. 63% of the patients with semaglutide 2.4 milligram achieved the resolution of the MASH. No other drug has been shown to show these benefits. Semaglutide 2.4 milligram is approved for the treatment of MASH by US FDA. So it is a wonderful drug which works in the diabetes, in obesity, and in the MASH also. It is studied by 60,000 patients across various trials. So it is a widely studied drug. It has got the safety profile, and it is a GLP-1 analog. So overall safety concerns that it is well tolerated. There are some GI side effects of the vomiting, nausea, and the rate of hypoglycemia was less. Cholelithiasis was seen in some few cases. Very few cases were pancreatitis, and the no increase in the malignant neoplasm. So in conclusion, that the semaglutide, the mean weight reduction can be achieved by up to 21% or 25%. It is a only anti-obesity medication with proven CV benefits, and GLP-1 receptor treatment with benefits to the MASH also recently approved by the US FDA. It has been studied by 60,000 patients. So I think this molecule is very, very useful for our practice. So diet and exercise, they are not enough. You need a drug, and you have got this good molecule in your hand. Thank you so much for your kind attention.
Thank you, Bharani sir, for such a lucid talk. And any questions are invited, or else we move on with the next session. Ashish, Anurag, next session ke liye bolo.
We request all the chairperson to kindly felicitate the speaker and move into the next session. Okay.
Moving forward to our next speaker.
Rajesh Kevar ko bitha. इसके बाद मैं बैठ जाऊंगा रे.
Now it's pleasure and honor to invite a leading diabetologist of Jabalpur and one of my senior, Dr. Abhishek Srivastava. and his topic is pioglitazone, the powerhouse in diabetes. And the chairpersons are Dr. Shishir and Dr. J.P. Kaushal.
Yes. स्टार्ट करते हैं यार, जल्दी स्टार्ट करते हैं. सो गुड इवनिंग and quickly thank you Dr. Ashish, Dr. Jigyasa for inviting me to NDID, and I am very thankful, and let's begin. So आज मैं आप लोगों को पायोग्लिटाजोन के बारे में बताऊंगा. ऑफ कोर्स आप लोग सब पायोग्लिटाजोन यूज़ करते हैं, बट देयर आर सम कंट्रोवर्सीज आल्सो लाइंग बिहाइंड द यूज़ ऑफ पायोग्लिटाजोन. इसलिए आप लोग थोड़ा सा पायोग्लिटाजोन को यूज़ करने में एक झिझक रहती है. But yes, today I'll be trying to justify why we should use pioglitazone. अच्छा, ऑप्टिमल ट्रीटिंग ऑफ टाइप 2 डायबिटीज़ को हम दो तरीके से भी ट्रीट करते हैं. एक तो हम शुगर बढ़ी रहती है उसको ठीक करते हैं. दूसरा हम क्या करते हैं, शुगर से एसोसिएटेड जो भी एसोसिएटेड कोमॉर्बिड कंडीशंस होती हैं, है ना, ओबेसिटी हो गया, हाइपरटेंशन हो गया, डिस्लिपिडेमिया हो गया, एथेरोस्क्लेरोसिस हो गया, या एनी अदर माइक्रोवैस्कुलर कॉम्प्लिकेशंस, तो इसको भी हम ठीक करते हैं. तो ये दोनों ही हमको ये पिलर को ध्यान पे रखना है. इसलिए ऐसी दवाई वी शुड एक्चुअली चूज वेयर नॉट ओनली वी कुड गेट गुड ग्लाइसेमिक कंट्रोल, बट अगेन अलॉन्ग विद गुड ग्लाइसेमिक कंट्रोल हमको ये सब पैरामीटर्स में भी फायदा हो, है ना. अब डायबिटीज का मेन टाइप 2 डायबिटीज का फंडा क्या होता है, इंसुलिन रेजिस्टेंस, मोर और लेस. तो कोई भी ड्रग जो इंसुलिन रेजिस्टेंस को कम करती है वो ड्रग हम सबसे बेसिक में लेते हैं. तो दो ड्रग हैं जो इंसुलिन रेजिस्टेंस को कम करती है. वन इज मेटफॉर्मिन जो इंसुलिन सेंसिटाइजर है, एंड सेकंड इज पायोग्लिटाजोन. तो आज हम पायोग्लिटाजोन के बारे में डिस्कस करेंगे क्विकली. अब पायोग्लिटाजोन क्या है, पीपीएआर गामा एक्टिवेशन करता है ये, बट क्यों ये फायदेमंद है, वाई पीपीएआर गामा एक्टिवेशन मैटर्स, बिकॉज इसके डायरेक्ट इनडायरेक्ट इफेक्ट्स बहुत ज़्यादा है. डायरेक्ट इफेक्ट्स है, इन्फ्लेमेशन कम करता है, ऑक्सीडेटिव स्ट्रेस कम करता है, एंड इनडायरेक्टली आपका ग्लूकोज कम करता है, हिपैटिक ग्लूकोनियोजेनेसिस कम करता है, ट्राइग्लिसराइड्स कम करता है, एचडीएल बढ़ाता है, जो कि इंपॉर्टेंटली हमको देखना पड़ेगा. सो दैट इज द रीजन व्हाई पीपीआर गामा एक्टिवेशन मैटर्स इन मैनेजमेंट ऑफ टाइप 2 डायबिटीज. इसलिए पायोग्लिटाजोन acts as a potent PPAR gamma agonist addressing one of the core defects in type 2 diabetes, that is insulin resistance. मसल इंसुलिन रेजिस्टेंस कम करता है, हिपैटिक इंसुलिन रेजिस्टेंस कम करता है, मोर और लेस एडिपोज टिश्यू डिस्फंक्शन कम करता है बाय रिड्यूसिंग द ऑक्सीडेटिव स्ट्रेस, रिड्यूसिंग द फ्री फैटी एसिड्स, एंड ऑफ कोर्स इनडायरेक्टली बीटा सेल डिस्फंक्शन को भी कम करता है बिकॉज ऑफ ऑक्सीडेटिव स्ट्रेस रिलीवर. सुपीरियर टू मेटफॉर्मिन इन रिड्यूसिंग इंसुलिन रेजिस्टेंस, देयर आर सर्टेन डेटास, कुछ स्टडीज भी हैं वेयर वी कुड क्लियरली सी दैट इन इंसुलिन सेंसिटाइजिंग प्रॉपर्टी पायोग्लिटाजोन स्कोर्स ओवर मेटफॉर्मिन. ये स्टडी है, दिस वॉज अ डबल ब्लाइंड प्लेसिबो कंट्रोल स्टडी, जिसमें एक हैंड में मेटफॉर्मिन है, एक हैंड में पायोग्लिटाजोन है, एंड वी कैन क्लियरली सी दैट द ट्रीटमेंट इंड्यूस्ड चेंजेस इन इंसुलिन मीडिएटेड ग्लूकोज अपटेक विद पायोग्लिटाजोन वॉज हायर एज कंपेयर टू मेटफॉर्मिन. ऑलमोस्ट जो हम देखते हैं कि जो सेंसिटाइजिंग प्रॉपर्टी है वो ऑलमोस्ट 20 to 25% मोर है एज कंपेयर टू मेटफॉर्मिन. पोटेंशियल एंटी एथेरोजेनिक इफेक्ट ऑफ पायोग्लिटाजोन, यस, डिक्रीज HbA1c, ऑफ कोर्स लोअरिंग ऑफ सिस्टोलिक ब्लड प्रेशर, HDL बढ़ाता है, ट्राइग्लिसराइड घटाता है, बट नॉन ट्रेडिशनल रिस्क फैक्टर्स को भी कम करता है, जिसमें वन ऑफ द मोस्ट इंपॉर्टेंट इज एंटी प्लेटलेट इफेक्ट एंड इंप्रूवमेंट ऑफ फाइब्रिनोलाइसिस. So any patient who has macrovascular complications, again prescribing pioglitazone could be a better option, but of course there are some hicks also in using, तो वो discuss करेंगे आगे जाके. Superior to metformin in reducing microalbuminuria, yes. Significant lowering of urinary albumin creatinine ratio by treatment with pioglitazone in type 2 diabetes. But again हमने metformin से compare किया because insulin sensitizer सिर्फ metformin है. तो आप क्लियरली देख सकते हैं कि पायोग्लिटाजोन वर्सेस मेटफॉर्मिन का जो यूरिनरी एल्बुमिन क्रिएटिनिन रेशियो लोवरिंग का इफेक्ट है वो पायोग्लिटाजोन में ज़्यादा है एज कंपेयर टू मेटफॉर्मिन. एंड ऑफ कोर्स एक्टिव कंपेरेटर और भी थे इसमें, सल्फोनिलूरिया था, अगेन सेक्रेटोगॉग. तो हम क्लियरली इसमें देख सकते हैं कि द प्रॉपर्टी ऑफ पायोग्लिटाजोन इज मच मोर सुपीरियर एज कंपेयर टू मेटफॉर्मिन एंड सल्फोनिलूरियाज. Significant increase of HDL cholesterol, which is a strong predictor of CV mortality in patients with type 2 diabetes. Of course, yes, benefits of pioglitazone in lipid metabolism. Pioglitazone improves diabetic dyslipidemia, decreases triglycerides level, increases high density lipoprotein cholesterol levels. इसमें भी हम दे सकते हैं. These are the three main important landmark trials जो pioglitazone के लिए किए गए थे. One of the most important is proactive, second is Chicago, and third is पेरिस्कोप. और इन तीनों में जो सेकेंडरी एंडपॉइंट हमने देखा था वो यही था कि बेनिफिट्स ऑफ पायोग्लिटाजोन इन लिपिड मेटाबॉलिज्म, और इसमें हम देख सकते हैं कि पायोग्लिटाजोन हैज प्रूवन टू बी सुपीरियर एज कंपेयर्ड टू प्लेसिबो एंड इवन एक्टिव कंपेटिटर दैट वाज मेटफॉर्मिन एंड सल्फोनिलुरिया. अब which are the studies we have to show that pioglitazone has an anti-atherogenic and cardioprotective effects? मैंने आपको पहले बताया था proactive, Chicago, periscope and iris, and several meta-analyses are also there. अब proactive quickly discuss कर लेंगे. proactive ने क्या दिखाया? प्राइमरी एंडपॉइंट क्या था प्रोएक्टिव का? सिग्निफिकेंट रिडक्शन ऑफ द कंबाइंड क्लिनिकल आउटकम ऑफ डेथ, मायोकार्डियल इंफेक्शन एंड स्ट्रोक. और वी कैन क्लियरली सी एज कंपेयर टू प्लेसिबो, पायोग्लिटाजोन का रिलेटिव रिस्क रिडक्शन वाज ऑलमोस्ट 16% सुपीरियर व्हेन इट वाज कंपेयर टू प्लेसिबो. अगर हम देखेंगे पायोग्लिटाजोन्स इफेक्ट ऑन रिकरेंट स्ट्रोक इन पेशेंट्स विद पीरियड स्ट्रोक, अगेन आप देख सकते हैं सब्सटैंशियल 47% रिलेटिव रिस्क रिडक्शन वाज देयर विद पायोग्लिटाजोन एज कंपेयर टू प्लेसिबो. अगेन दिस वाज द रिजल्ट इन प्रोएक्टिव ट्रायल. Pioglitazone's effect on recurrent myocardial infarction in patients with previous MI, then also the relative risk reduction was 28% as compared to placebo. These are all positive effects. हम क्यों बता रहे हैं pioglitazone का? Because pioglitazone के हम सिर्फ बैड साइड देखते हैं, हम पॉजिटिव साइड नहीं देखते हैं. तो these are some good positive sides जिसमें हम ये देख सकते हैं pioglitazone, how pioglitazone has concomitant pleiotropic benefits apart from anti-hyperglycemic effects. Effect of pioglitazone treatment on the combined endpoints of all cause mortality, myocardial infarction and stroke. Then again हम देख सकते हैं इसमें भी हमने इसको कंपेयर किया था मेटफॉर्मिन से एंड इंसुलिन से. Then also we can clearly see that patients when pioglitazone was used with and without CKD proactive trial में हमने देखा था कि the end secondary endpoint was much more lower as compared to the active comparator or placebo also. Chicago trial एक था, a study evaluating carotid intimal medial thickness in atherosclerosis using pioglitazone. Then here also the objective was to demonstrate the impact of pioglitazone versus glimepiride. Minded इसको glimepiride से compare किया था, तो active comparator was glimepiride here on atherosclerosis as measured by the carotid intima medial thickness in 400 patients. क्या देखा गया? A study evaluating the CIMT in atherosclerosis comparing pioglitazone versus glimepiride. Here also we can see that the carotid intima medial thickness was superiorly reduced by pioglitazone as compared to the glimepiride. Here also we can see the active comparator was glimepiride. IRIS study, here also pioglitazone, हमने IRIS study में क्या देखा? Pioglitazone after ischemic stroke or transient ischemic attack. What was the result? Pioglitazone was associated with a greater weight gain than placebo, but again अगर हम देखेंगे कि the relative incidence of recurrent ischemic stroke or transient ischemic attack was much more lower as compared to placebo. Balance, of course हमने benefits बता दिए, but yes कुछ adverse events भी हैं, कुछ risk भी हैं when using pioglitazone. One is weight gain, that is water retention, heart failure, रिस्क, बोन फ्रैक्चर्स एंड ब्लैडर कैंसर, ये सब है. बट कंट्रोवर्सीज हैं, इसको हम कैसे देख सकते हैं, कैसे करना है? पायोग्लिटाजोन ब्लैडर कैंसर, FDA issued a safety communication noting use of more than 1 year may be associated with increased bladder cancer risk. अगर पायोग्लिटाजोन को 1 साल से ज़्यादा यूज़ करते हैं तो risk of bladder cancer is increased and required label changes and patient counseling. Later on, FDA reviewed additional data and reaffirmed that a small increased risk could not be excluded in perspective of the bladder cancer. So these are the 3 large studies which have concluded, or rather I would say they have not shown any evidence of an association between use of pioglitazone and the risk of bladder cancer. Again, ये studies क्यों ही हैं? इनमें बताया गया तो बहुत ही मॉडेस्ट रिस्क है, बट अगेन रिस्क इस तभी है जब पायोग्लिटाजोन को मोर देन 12 months to 18 months हम यूज करेंगे लगातार. And what the meta-analysis show? Meta-analysis and systemic reviews generally report either a small increased risk overall or a signal that is dose and duration dependent, higher risk with longer exposure and longer cumulative dose. And findings may vary by study methods and populations. Again, clinical takeaway, contraindication हम रखेंगे. किसी को हिस्ट्री ऑफ एक्टिव ब्लैडर कैंसर है, यस, डू नॉट यूज पायोग्लिटाजोन. किसी को हिस्ट्री ऑफ वेट गेन है या एडिमा का हिस्ट्री है, देन अगेन डू नॉट यूज पायोग्लूटाजोन. इन्फॉर्म पेशेंट्स टू रिपोर्ट इफ पायोग्लूटाजोन के बाद हेमाचूरिया होता है. बहुत ही कॉमन नहीं है ये, मैंने बहुत ही कम लोगों में देखा हेमाचूरिया. और न्यू यूरिनरी अर्जेंसी और यूरिनरी इनकॉन्टिनेंस, ये भी देखा गया पायोग्लूटाजोन के साथ यूरिनरी इनकॉन्टिनेंस एक मेजर साइड इफेक्ट है. तो अगर कोई पेशेंट आपको आके बोलता है कि यूरिन रोकने में थोड़ा सा प्रॉब्लम हो रही है, तो आप समझ जाइए कि पायोग्लूटाजोन अगर चल रहा है तो तुरंत पायोग्लूटाजोन आपको बंद करना है. हार्ट फेलियर, पायोग्लूटाजोन causes dose related fluid retention and is associated with a higher rate of heart failure events or even hospitalizations due to heart failure, but has not been shown to increase heart failure mortality. That is important. Yes, fluid retention के कारण higher rate of heart failure events है, even hospitalizations है, but mortality has not been increased with the use of paglitazone, and in randomized control trials it has been shown. So these are the key randomized trials. Proactive किया था, pooled RCT safety analysis भी किया गया था real world evidences में, and they have summarized and reported an excess of edema, heart failure, hospitalization with paglitazone, but without a clear signal of increased heart failure death in randomized data. So yes, एडिमा के कारण हार्ट फेलियर हॉस्पिटलाइजेशंस का इवेंट्स बढ़े हैं, बट अगेन मोर्टैलिटी हैज नॉट बीन इंक्रीज्ड. सो क्लिनिकल इंटरप्रिटेशन mechanism is of course I'll not discuss quickly. Practical nuances: do not start paglitazone in patients with NYHA class 3 and 4. 1 and 2 में कर सकते हैं, but 3 and 4 में absolutely it is an absolute contraindication to use paglitazone. Use caution in patients with risk factors for volume overload, that means cardiomyopathy अगर किसी को है, reduce LVF है, chronic kidney disease है, and concurrent insulin और NSAID use. Again अगर किसी को chronic insulin use हो रहा है तो भी उसमें paglitazone हम use नहीं करेंगे. Osteoporosis, again paglitazone increases fracture risk, but particularly in post-menopausal women, because could be one mechanism could be via PPR gamma mediated effects that reduce the osteoblastogenesis and favor bone loss. So again post-menopausal women में paglitazone should be used cautiously. Of course there are some nuances also, and randomized trials किए गए हैं and pool safety analysis भी किया गया, and they have shown an increased fracture incidence with paglitazone. So again what to do? Pre-initiation assess fracs या DEXA scan भी हम करवा सकते हैं in patients with a higher risk, और जिसको आपको लगता है कि पोस्ट मिनोपॉजल विमेन है या लॉन्ग स्टेरॉइड यूज है या पुअर प्रायर फ्रैक्चर हिस्ट्री है. बस 1 minute. And then again counsel that patient, monitor that patient, and if fracture or significant bone loss occurs, stop paglitazone immediately and treat osteoporosis as per the guidelines. Contemporary combinations हैं, I'll not go with that. Paglitazone SGLT2 के साथ भी use हो रहा है. Again yes, it is a good combination. Complementary actions, sensitive versus weight loss हम देखते हैं with paglitazone used with SGLT2 inhibitors और GLP-1 analogs. So practical recommendation: start low, 15 milligram per day के से start कर सकते हैं, titrate up to 30 milligram as needed, but maximum 45 milligrams per day if tolerated. Best candidates कौन-कौन है? Insulin resistant type 2 diabetes, biopsy proven NASH में yes, paglitazone has a major positive effect. Selected post-stroke patients with insulin resistance. Avoid asymptomatic congestive heart failure, active bladder cancer, or unexplained gross hematuria. Monitor weight, peripheral edema, symptoms of heart failure, liver function, and urinary symptoms. And if combining with SGLT2 inhibitors or GLP-1 analog, anticipate complementary benefits along with SGLT2 inhibitors and GLP-1 analogs. Thank you.
So, thank you sir, it was a nice presentation. Now the windows are open for audience. If you have any question, then please ask. Okay.
Hello. Now moving to next session, we request Chairperson Dr. M.L. Vishkarma and Dr. Shyam Gupta to come on the chairperson sheet, and we request Dr. Rajesh sir, technical team kindly upload the presentation and CV. We request Dr. Rajesh sir to come on the dais. Technical team, kindly show the CV. क्या हो गया?
एक मिनट में कर देता हूँ। नीचे वाली कि ऊपर वाली? नीचे वाली, ये वाली। दोनों ही कर देता हूँ एक मिनट। ये वाली है। हाँ वाली। PS पे ही आ रही है। PS चलेगा PS। डायरेक्ट चला देता हूँ। ये उस पेन ड्राइव पे डाली थी। पेन ड्राइव पे है। एक माइक नहीं है ऐसे नॉर्मल। फटाफट में को क्या 10 स्लाइड बस है ऐसे बोल देता हूँ। करनी बुरी नहीं है वो वाली व्हाट्सएप वाली। अनुराग कहाँ पे है?
क्या हो भाई?
सर है ऊपर। यही है ना? हाँ भाई
Sir, we request to kindly start the session, and we request kindly hand over the mic to the chairperson. Sir, slide visible, sir. Can you read the CV?
Hello.
Read that CV, sir.
Dr. Rajesh Kumar Kewad, he is MD Medicine in General Medicine. He did his MBBS from Jabalpur Medical College and MD from SS Medical College, Rewa. He has done fellowship in diabetes, fellowship in IBS and certificate course in advanced diabetes. He is member of Royal College of Physicians, member of RSSDI, and member of API and IMA. He is consulting physician in Marwal City Hospital, Seth Manulal Jagannath Hospital, Jabalpur, and Swastik Hospital. He is director of Narayan Health Clinic and Diagnostic in Jabalpur.
Thank you, sir. Today, we are discussing a very important topic related to diabetes. Generally, we are discussing that diabetes can cause complications like diabetic retinopathy, diabetes nephropathy. But we are generally skip a very important point, that is erectile dysfunction due to diabetes. Most of the time it happens that when diabetes nephropathy happens, means it mainly involves the neurological and vascular component. But when it involves retinopathy, then mostly it involves vascular pathology. But in erectile dysfunction, this is very important point. Why? Because it includes not only two, that is vascular and neurological, but also includes a psychological pathology. Most of the patients which are having diabetes suffer from this erectile dysfunction, goes to psychological disorder. They take various counseling because due to depression, due to anxiety. So it is very important to keep it in mind that if we examine any diabetic patient, then it is very necessary to take history of erectile dysfunction also. One more important thing, that almost 50% of every diabetic patient can cause erectile dysfunction, but in our clinic only 20% patient complaining that he is having this erectile dysfunction. So is it epidemic in our clinic that is it hidden epidemic in our clinic that amongst 50% only 20% are presenting this erectile dysfunction? So this is very important point, that if patient is having history of around 6 to 7, even 10 years diabetes, then this point should be keeping in mind, that we should keep we should take a history of this erectile dysfunction. Why? Because it can lead to not only endocrinal pathology, but also it involves the psychological pathology also. So we are discussing in a very short, because we have not enough time to discuss in detail this topic. So we are covering maximum important topics clinically. So when we examine our patient, then we should keep these points in our mind and take in history of this erectile dysfunction. So my topic is diabetes and sexual dysfunction, a diabetologist approach. So we all know that diabetes is one of the most common chronic disease in all countries, and its data generally increases year by year, and it is one of the most global burden that we should focus on this increase in this burden. So these are the estimation and projection of number of people, that is 20 to 79 years age with diabetes in different edition. We clearly see that amongst various decades, as year increases, the case of diabetes increases with same ratio, even more than that. So diabetes and sexual dysfunction, in this Massachusetts male aging study, clearly indicate that if compared to normal patient, then 3 times more common this erectile dysfunction in diabetic patient. So this erectile dysfunction in male patients, also in women, this sexual dysfunction we clearly seen due to some hormonal imbalance. So this diabetes not only cause erectile dysfunction in male patients, but also causing various infertility, various sexual dysfunction in female patients also. And it is 3 times more common in men compared to normal patients. So this is if we define this erectile dysfunction, that it is persistent inability to achieve or maintain penile erection for successful intercourse, causing decreased quality of life in men. And it is common sexual disorder that increases with age. Yes. Among 50 to 60 years of age, we are clearly seeing that in all diabetic patients, 50%, this is very big value, 50% is having problem of this erectile dysfunction. But due to some hesitation and psychological cause, only 20% patient presents with this illness. Means what a hidden epidemic in our clinics. We are generally ignoring this point, but even 30% cases are hidden in our clinics which are having this type of problem. So it is very important. Why? Because it involves not only endocrinal hormonal pathology, but also psychologically. So if we talk about its pathology, then atherosclerosis in the penile and duodenal arteries limits the blood flow. Due to deficiency of blood flow in this artery supply in this cavernosum muscle, it can causing this erectile dysfunction. Or also some autonomic neuropathy is major contributor to high incidence of erectile dysfunction in people with diabetes. So these are the neurological and vascular causes of this erectile dysfunction. And if we talk about this mechanism, then hyperglycemia can causing the acylated glycation end products deposition, also causing oxidative stress, which can lead to these molecular alterations causing cavernosal endothelial dysfunction, leads to impaired endothelial and smooth muscle relaxation and hemodynamic alterations. The point is deposition of this product, oxidative stress, can causing endothelial dysfunction of this cavernosus muscle, can lead to erectile dysfunction. And hormonal changes in diabetic erectile dysfunction can causing due to this vascular component, cavernosal structural functional changes, endothelial dysfunction, neuropathy, hormonal changes. These all factors can contributing and causing this erectile dysfunction in diabetic patient. Now, in diabetes, erectile dysfunction is a marker of yes, this is very important point. We are not focusing only on this point, erectile dysfunction in diabetics. If any patient having this erectile dysfunction since 3, 4, even 6 months, then we should focus on this pathology. Like, moreover, erectile dysfunction is a marker of significantly increased risk of cardiovascular disease, congestive heart disease, stroke, and all-cause mortality. So if any patient, either diabetic or non-diabetic, having erectile dysfunction since last 3, 4, even 6 months, then you should go to examine for cardiovascular disease, even stroke. You should rule out these first, because this is not only due to diabetes, But also, why? Because due to LDL, due to increase in LDL, it can causing this erectile dysfunction, and LDL is a common factor for both this cardiovascular disease and erectile dysfunction. So you should examine your cholesterol level also if you are having erectile dysfunction. So this is the data given that 1 in 5 men having erectile dysfunction, that is 3 times more common compared to other. How common is erectile dysfunction in diabetes? Of the men with diabetes, more than 50% have erectile dysfunction caused by their diabetes, which means 1 in 2 men you see could be suffering from erectile dysfunction. So this is very biggest data that 50% diabetic patient is having this erectile dysfunction. Now, the cause of erectile dysfunction also due to testosterone deficiency regulate nearly every component of erectile function, from pelvic ganglion to smooth muscle and to the endothelial cell of, these are the mechanism given of testosterone. So it is still unclear what level of testosterone is needed for good erectile function. However, evidence derived from clinical and molecular studies support the use of testosterone replacement in hypogonadal patient. This is not a very big point that testosterone, we all know that testosterone deficiency can cause erectile dysfunction. So we can maintain this also. So this test, but in diabetes mellitus, if we talk about diabetes, then mechanism involved in testosterone deficiency in diabetic patient include low level of sex hormone binding globulin due to insulin resistance, increased aromatase activity in visceral adipose tissue leading to an augmenting conversion of testosterone. In diabetic patient, this testosterone level decreased due to some hormonal imbalance. So this diabetic mellitus can cause testosterone deficiency very easily, which can lead to erectile dysfunction. So these are the various phenomena given that Ballestella et al. Suggested a possible autoimmune pathogenesis of hypogonadotropic hypogonadism in type 2 diabetes patient as indicated by the presence of anti-pituitary antibodies at high titer as compared with age-based controls. Now, insulin resistant and visceral adiposity, yes, this is a main cause, that insulin resistant and resistance and visceral adiposity, which are both distinct clinical triads of type 2 diabetes associated with pro-inflammatory state that result in decreased availability and activity of nitric oxide leading to erectile dysfunction in overweight and obese diabetic men. So this is the mechanism given how this insulin resistant can causing this erectile dysfunction. So diagnosis, how we can diagnose it is easily detected by having male patient complete standard questionnaire. Simple, we are asking some questions regarding for identification of this pathology, investigating their sexual function. One of the most practical question that is administered is the internal index of erectile function, that is IEF5, which consists of items 5 and 7 from the full scale. These are the scale which we are asking some question to patients, and we can analyze the patient is having this erectile dysfunction. So why diagnosing erectile dysfunction important? We already know for uncovered diabetes, for cardiovascular disease, these are the various drugs causing erectile dysfunction. So we can skip these drugs if you having this erectile dysfunction. If we talk about treatment, then mechanism of this various drugs are given. The important thing that these are the treatments of erectile dysfunction. Tier 1 is pills, second is injection, implants. These are the drugs given, sildenafil, valdenafil, tadalafil, avanafil. These are the drugs in which the most safest drug is tadalafil. We are given easily even in old patients. Various injections are available to treat this erectile dysfunction. Alprostadil injection can be injected. Psychological barrier, we can counsel the patient, and various implants are there. We can implant as a prosthesis in penile, so we can treat this patient by implantation also. So this is the screening of erectile dysfunction in diabetes. So we should screen the patient. PDE5 inhibitors are unsuccessful, refer to a service offering special management. If PDE5 inhibitors are given, even it is unsuccessful, then we can transfer this patient to specialist management. Now we can control our glucose lifestyle modifications to control this ED. And if we talk about sexual dysfunction of females, then same phenomena occur, but due to hormonal imbalance, this can causing various symptoms in females like disorder of sexual desire, arousal, orgasm, and pain. These all due to diabetes. So these are the risk factor associations of given of various analysis, various meta-analysis are given for female patients also. So these associations and risk factor with diabetes can causing this sexual dysfunction. So these are the various factors are given, which are given in detail, not important. The important thing is that how we manage and how we identify this sexual dysfunction in females and males both. So proper counseling and proper management of lifestyle modification and sugar control is the main therapy for this control of sexual dysfunction. Now, if we talk about pathogenesis, these are the pathogenesis, how this female sexual dysfunction occur in diabetes. In simple language, we say the alteration in the level of androgen, estrogen, as well as sex hormone binding globulin can causing this fertility dysfunction, sexual dysfunction. Now, depression, we all know that in spite of association of vascular neurological, there's an important one more system involved, that is psychologically, that depression is strongly associated with diabetes in both males and females due to various sexual dysfunction and hesitation to explain this in front of your doctor. Now these are the various symptoms are given in female patient which can causing this sexual dysfunction. Now tips for addressing sexual functioning with diabetes, these are the various tips given how you feel comfortable this female to explain your problems with your doctors. So these are the various points given which are given in detail, but we have not enough time to discuss this in detail. But the thing is, you can ask your patient with very formally, very normal languages, and you can compare even with other persons also to compare his sexual dysfunction. So you can simply ask questions. So treatment options, these are the simple options for a female patient. Vaginal lubrication to reduce genital infection, treat various type of genital infections, and vaginal lubrication can be improved by giving various therapies. Now these are the summarize of female sexual dysfunction, that modification of risk factors, psychological issue, cognitive behavior therapy, that is psychological therapy is very important. Various hormones are given. So these are the treatment of female sexual dysfunction. So in conclusion, diabetes mellitus is a growing public health concern leading to vascular, psychological, and sexual dysfunction. So we must focus on to control blood sugar level. If patient is having erectile dysfunction, then also rule out other activity like cardiovascular and also various congestive heart disease. This is very important point. To not only diabetes, but also this system also can be excluded in diabetes mellitus, erectile dysfunction. So these are the high prevalence of female sexual dysfunction has been described in both type 2 and type 1 diabetes as compared with non-diabetes. So these are the point. The most important we are discussing, if we summarize the whole program, that if patient is having erectile dysfunction, then you should rule out diabetes is okay. But you should focus on other disease also, like coronary artery disease, like congestive heart failure. So this is a sign, this is a simple sign of erectile dysfunction, that you become serious and focus on other abnormalities also other than diabetes. And if patient come in your clinic, then obviously you can ask this problem why, because amongst 50% patients suffer from this erectile dysfunction, but only 20% patient can explain their problem to doctor that I am having this erectile dysfunction due to some hesitation. So this is very important that psychologically well explained to patient in their language that this is very common. Talk about diabetes, that this is very common symptoms and you can easily manage, we can correct this problem. So you can ask and correct this and give psychologically counseling for depression. So patient become friendly with you and you can manage your this erectile dysfunction problem. Thank you. Thank you.
Thank you, Doctor. Thank you very much, Dr. Kevat. Very well explained. I have a question.
Yes, sir.
How do we define, is it not a misnomer in females to call it erectile dysfunction?
Sorry, sir.
Erectile dysfunction in females, is it not a misnomer?
No, ma'am. Sir, sorry, sir. Sir, erectile dysfunction, actually, sexual dysfunction in female. And due to hormonal disbalance, due to incomplete androgen, due to incomplete estrogen.
in the beginning you said erectile dysfunction in
सर वर्बल
female.
वो सर वो हो गया होगा निकल के एक्चुअली में
And, how do we diagnose erectile dysfunction in female?
No, sir. Actually, sexual dysfunction, we can identify sexual dysfunction in female, but in male, we can identify erectile dysfunction.
Yes. So, how can it be treated?
Yes, sir.
How can it be treated in females?
Sir, hormonal therapy is given, various hormones are given, estrogen progesterone combination can be given, various jellies are available which can be applied. Better to consult with your gynecologist to treat this cause. Our part is to control blood sugar level and rule out other pathology. But gynecological problem, better to refer that patient to gynecologist to explain their
And
problem.
you said there is a role of hormones in female. Which hormone is active?
Sir, the most important thing is estrogen, sir. Mainly we are focusing on estrogen. Even androgen, we are also can see the testosterone also even see in females. Why? Sometimes testosterone can be converted into estrogen, and they can play a role in various sexual. Yes, sir. So all hormones, even all entire hormone profile is very important in female patients to identify this female sexual dysfunction.
Thank you.
Thank you.
Thank you.
Thank you so much, sir.
Momento, please.
I request
Questions
the
from
chairperson to
audience?
come on the stage and facilitate our speaker.
शिशिर,
I also request
जो लकी ड्रॉ के विनर हैं वो हैं 7 नंबर डॉक्टर एस.सी. घोष, 40 नंबर डॉक्टर के.सी. चोपड़ा, 68 नंबर डॉक्टर मोहन सक्सेना, 164 नंबर अखिलेश सोनी। जो भी इनको जानते हैं तो बता दीजिएगा। अभी 5 लकी ड्रॉ और निकल रहे हैं। अगर वो कोई बैठा होगा तो उसके लिए तालियां। आप जो बैठे हैं उन्हीं का निकालेंगे, ये बात भी सही है। एब्सेंट है उनको नहीं देंगे। तो जो बैठे हैं वो बैठे रहे, सबको डेफिनेट गिफ्ट मिलेगा। मिलेगा अब। नेक्स्ट टॉक, चाय पे चर्चा। कुर्सियां लगाइए जल्दी से यहाँ। थैंक यू राज।
starting with our next session, Chai Pe Charcha. I request our moderator, Dr. Shishir
Soni sir.
Dr. Shishir Soni sir to come on the stage. I request Dr. Rajkumar Jain sir as a chairperson and Dr. Sheikh Nabil sir from Bangladesh as a chairperson.
थैंक यू। रानू मैडम आइए। तो चाय पे चर्चा एक बहुत इनोवेटिव चीज हम लोगों ने इजाद की है कि हर फील्ड के डॉक्टर्स यहाँ पे चर्चा करते हैं। 5 मिनट में हम लोग इसको समाप्त करेंगे। उसके बाद हाँ यहाँ पे कुर्सी लगाओ ना। डांस, अच्छा डांस तो कल बहुत हो गया। सत्यानंद सर, सर प्लीज कम ऑन द स्टेज। आएगा ना, जो बैठे हैं उनको सबको गिफ्ट मिलेगा। बेबी को बेस पसंद है, ठीक है बेस दे देंगे। कौन सा, जो म्यूजिक वाला बेस? हाँ कौन है? अरे वाह, सही में वेरी गुड। आईडी कार्ड दिखाइए। मजाक कर रहे हैं, देंगे आपको। कल का आपका रजिस्ट्रेशन नंबर था ना ये? आप पेन दो।
I would like, sir, with your permission, shall I start this session? Ashish sir?
You should start. Okay. I'm coming.
I would like to invite Dr. Ranu Mishra ma'am, senior pathologist from Medical College, respected Dr. Satyanand sir. I would also like to invite respected Dr. Jigyasa ma'am.
गिफ्ट भी निकल रहा है।
And Ashish sir, आपको भी आना पड़ेगा डायबिटीज के लिए।
ये निकला है आपका 40 नंबर पे, दे रहा हूँ बस। पेट।
डॉक्टर
केसी चोपड़ा सर यहीं उपस्थित हैं जिनका गिफ्ट निकला है, तालियां, पहले से मौजूद थे ये, थैंक यू।
तो यूजुअली लोग चाय पे चर्चा करते हैं तो कुछ बातें जनरली इंडिया में तो आप जानते हैं यदि चाय पे चर्चा कर रहे हैं तो कभी बातें क्रिकेट की होगी तो कभी बॉलीवुड की होगी या शायद स्टॉक मार्केट की हो जाए। तो हमने भी जो थीम है वो कुछ इसी तरीके से रखा है कि बातें तो कुछ ऐसी होंगी जो कुछ बॉलीवुड से रिलेटेड हो, कुछ क्रिकेट से रिलेटेड हो या स्टॉक मार्केट से, लेकिन जवाब तो हमारे फील्ड से रिलेटेड ही होगा। तो मैं फर्स्ट क्वेश्चन आशीष डिंगरा सर से करना चाहूँगा। सर इतना एडवांसमेंट हो गया, अभी हम देख रहे हैं एआई है, ये सब कुछ है, तो बॉलीवुड का एक काफ़ी फेमस डायलॉग है कि अब तुम्हें दवाओं की नहीं दुआओं की ज़रूरत है। तो क्या अभी भी ऐसी कोई चीज़ रह गई है जहाँ आपको ये कहना पड़े कि दुआओं की ज़रूरत है, या स्टिल वी आर क्वाइट अहेड इन दिस फील्ड?
नहीं, अभी भी हम बहुत पीछे हैं, अभी भी बहुत रिसर्च की ज़रूरत है। जैसे एआई आने से तो बहुत फ़ायदा होने वाला है, पर दुआओं की ज़रूरत इसलिए होती है कि वो हमारे दिल से जुड़ा हुआ है। तो सिर्फ दुआओं पे आप जाएंगे तो फिर आपकी डेथ हो जाएगी, सिर्फ दुआओं पे चलेंगे तो आपको कोई भी बीमारी हो, डायबिटीज़ हो या कोई भी बीमारी हो, उसमें दवाओं के साथ साथ, दुआओं के साथ साथ लाइफ स्टाइल मैनेजमेंट बहुत ज़रूरी है। तो पहला स्तंभ है लाइफ स्टाइल, दूसरा स्तंभ है आपका दवाइयाँ और तीसरा स्तंभ है दुआएं। तो दुआएं आती हैं लास्ट में, बट आप दुआओं को भी साथ में रखिए, लेकिन दवाई को नियमित रूप से लीजिए और अपनी नियमित रूप से जांच कराइए, तो आप स्वस्थ और आनंद जीवन व्यतीत कर सकते हैं।
थैंक यू वेरी मच सर। कार्डियोलॉजी में देयर आर सर्टेन सिचुएशंस।
सिर्फ डायबिटीज में नहीं, सिंस आई एम अ फर्टिलिटी एक्सपर्ट,
यस सर,
आई डू आईवीएफ। मैं कई सारे ऐसे पेशेंट्स को बोल देती हूँ कि आप तो भूल जाओ यार, कोई स्कोप ही नहीं है, आप प्रेग्नेंट नहीं हो सकते, बट एक एम्ब्रियो के साथ भी वो प्रेग्नेंट हो जाते हैं। और कई ऐसे पेशेंट्स को मैं अपनी तरफ से नहीं, हाँ तुम्हारा तो 100% पॉजिटिव आएगा, बट वो नेगेटिव आते 4 अटेम्प्ट 5 अटेम्प्ट हर अटेम्प्ट। बट उस टाइम पे ख्याल आता है वी आर जस्ट द पपेट्स, आना और जाना, इट इज नॉट डिसाइडेड बाय अस एंड इट विल नेवर बी डिसाइडेड बाय अस। तो वहाँ पे दुआएं काम आती हैं।
थैंक यू सो मच फॉर द इंसाइटफुल कमेंट्स। अब मैम के लिए एक सवाल है जो नॉर्मली बॉलीवुड मूवी में काफ़ी एक देखा है कि माँ और बच्चे में से किसी एक को बचाया जा सकता है। तो मैम काफ़ी सीनियर गायनेकोलॉजिस्ट हैं, तो क्या ये रियल वर्ल्ड सिनेरियो में एग्जिस्ट करता है? तो व्हाट आर द मैटरनल इंडिकेशंस व्हिच कैन लीड टू द थ्रेट to the survival to the fetus, and in that scenario if there is a possibility of the either of them can survive?
Either of them can survive, ऐसा वाला इंडिकेशन तो अब इस एरा में, मॉडर्न एरा में कम है, because we consider fetus to be a patient.
Yeah.
So we consider both of them to be patient. हमारा फर्स्ट वही रहता है कि we should save both of them. पर भी अगर ऐसा कुछ सिनेरियो आता है कि नहीं, मदर इज इन द हाई रिस्क जोन लाइक इन प्री इक्लैम्शिया, इफ शी इज हैविंग, शी इज या इक्लैम्शिया, शी इज थ्रोइंग कन्वर्जन्स एट 30 वीक्स, देन वी हैव टू थिंक अबाउट मदर फर्स्ट।
ओके, सो
और भी ऐसे सिचुएशंस हैं लाइक स्टार्टिंग में ही फर्स्ट ट्राइमेस्टर में वी वर डिस्कसिंग इन द मॉर्निंग कि कोई पेशेंट है विद डायबिटिक कॉम्प्लिकेशंस, फॉर एग्जांपल शी इज कमिंग विद डायबिटिक नेफ्रोपैथी विद EGFR less than 30, then we will not allow her to continue her pregnancy up to 9 months. Similarly, proliferative diabetic nephropathy with she has conceived, then we will not allow her. At least we'll counsel her कि you should not progress your pregnancy and whatever, then it's her decision finally.
So ma'am has enumerated certain conditions where the
Similarly
survival
in cardiac things, like if patient
stenotic bowel heart diseases. So
there are many heart diseases which are contraindication for pregnancy. Like for example, nowadays we don't see such patients, and at least in private, maybe they may come in medical college and super specialty we have, so they might be going there like coarctation of aorta and all, which are absolute contraindication for pregnancy. So we tell them to avoid pregnancy, or if they become pregnant, then we tell them to discontinue that pregnancy.
So thank you very much ma'am for the insightful comment. And there are several conditions because of nowadays that things are being detected. So even in the first month of their pregnancy they used to get some echo done, and there are certain situations like severe stenotic valvular heart diseases, severe PH and coarctation of aorta like situation as ma'am said, wherever the survival with the pregnancy becomes very difficult, and ultimately you have to say not in that Bollywood style, but we have to convey them it is very dangerous for the survival of the female at least. And question to Ma'am Rano ma'am. Ma'am, just we are changing to some other kind of movies like Drishyam kind of movies. So but the problem is that you know that the culprit is like this, but there are the evidences are not that much that you can find out the culprit. But there are, on the contrary, there are situations when you think, okay, yes, this is going to be the culprit, but even with if you don't know about the final one. So at times it might happen that the clinician who are sending the samples to you might not be writing that this patient is diabetic. But what are the situations in which you are suspecting like, okay, ये तो diabetes ही होगा. तो
हाँ, in pathology when we found certain infections, कुछ infections हैं जो कि हर infections ज़्यादा common होते हैं diabetic patients में, ज़्यादा severity से होते हैं, but there are certain infections if they are seen present, they pinpoint कि भैया diabetic patient ही है. तो इसमें एक है emphysematous cholecystitis, emphysematous pyelonephritis, that is gas. When we see on the CT imaging gas fluid levels and gas in the kidney, gas in the gallbladder and histopathology, so emphysematous cholecystitis, pyelonephritis, otitis externa, which is known as malignant invasive otitis, ये pseudomonas aeruginosa से होता है. एंड फोर्थ जो कि है हम सबने देखा है, इट्स अ राइनोसेरेब्रल म्यूकर माइकोसिस. प्री कोविड एरिया में हमने कभी नहीं सुना था बहुत ज़्यादा म्यूकर माइकोसिस. सो इफ इट इज़ देयर, it pinpoints that the patient is diabetic and we must screen for that. So on the biopsies, these are the things that we have come across with these lesions, specifically seeing in a diabetic people. Even it is mentioned in books also. So this is for my side.
Thank you, ma'am. And it was indeed a very important answer, because even without knowing the whole picture, you can pinpoint that, okay, this is going to be a diabetic. Thank you so much, ma'am. Sir के लिए भी sir is working in a very good hospital, and sir के लिए question है, जैसे normally हम एक पुराना डायलॉग था उसको थोड़ा बहुत modify किया है. हम आएंगे, ज़रूर आएंगे, पर वो गोली भी हमारी होगी और हॉस्पिटल भी हमारा होगा. तो जैसे आपको लोग कहते होंगे कि नहीं सर आप हमारे हॉस्पिटल में आके यहाँ थोड़ा सा ओपिनियन दे दीजिए, ये होंगे, तो शायद आप उस समय ये करें. तो मैं चाहता हूँ कि कौन सी डायबिटिक सिचुएशन में सिनेरियो है जहाँ आपको लगता है कि मेरे को हॉस्पिटल सेटअप बिल्कुल अपना चाहिए, कि मेरे को कुछ मतलब जो कोई यदि हॉस्पिटल में इंसान एंटर कर रहा है ना, तो मैं तो उसकी अंगूठियाँ भी उतारवा दूंगा, घड़ी भी उतारवा दूंगा, लेकिन मुझे ए सेप्सिस चाहिए. तो ऐसी कौन सी सिचुएशन से डायबिटीज़ में जब आप यही डायलॉग कहेंगे कि हम आएंगे, ज़रूर आएंगे, वो गोली भी हमारी होगी खाने वाली मेडिसिन, और हॉस्पिटल भी हमारा होगा?
एक्चुअली आई एम नॉट यूज्ड टू, मैं ऐसे कभी नहीं हुआ जैसे चर्चा हो रही है, बट आई विल पुट माय बेस्ट एफर्ट टू आंसर. यू सी, diabetes is so rampant in our society. Like morning in Dr. Agarwal sir was mentioning, 40 to 50% we screen we'll be having, if it's point of care HbA1c we do 40 to 50% will be pre-diabetic. It's something like that. So our hospitals, our hospital management gives emphasis in diagnosing diabetic patients early. Like हमको सबको पता है टेम्परेचर, पल्स, बीपी, ये 3 वाइटल साइंस हम सबको देखते हैं. बट माय हम्बल रिक्वेस्ट विथ आवर एक्सपीरियंस दैट अगर पॉइंट ऑफ केयर में ब्लड शुगर मॉनिटर करते हैं वो पेशेंट के साथ, इट डजंट कॉस्ट मच. ऑफ कोर्स एवरीबडी गोज फॉर कॉस्ट कटिंग. अगर जो भी पेशेंट हमारे पास आता है उसका हम HbA1c करते हैं, और जो भी पेशेंट हमारे पास आता है और उसके अटेंडेंट का हम ब्लड प्रेशर लेते हैं, we can reduce the morbidity and mortality of our society to a great extent. So this is where I want the hospital and hospital management to be proactive in supporting the clinicians for a better outcome.
Thank you so much, sir. अगला राउंड है स्टॉक मार्केट से रिलेटेड, और उसमें भी आपके पास सवाल होंगे. इसमें ये है कि आप लोग को खुद से पहले चूज करना कौन पहले जवाब देना चाहेगा. तो मार्केट में एक बहुत ही कॉमन ट्रेंड होता है बुलिश एंड बियरिश, जिसमें से मार्केट आप सुनते होंगे कि अचानक से एकदम उठ गया, और कभी सुनते हैं कि मार्केट एकदम से डाउन हो गया. तो अब मेरा सवाल है, डायबिटीज़ पेशेंट में ऐसी कौन से सबसेट ऑफ केस मिल जाते हैं जब एकदम से आपका पेशेंट ड्रास्टिकली इंप्रूव करने के लिए चले जाता है? तो ऐसे कब सिनेरियोज आपने देखे कि जब आपको बड़ा लगा अरे एकदम से ऐसा हो गया, ये तो
देखिए, डायबिटिक कीटोएसिडोसिस एक ऐसा सिचुएशन है जिसमें कि डायबिटीज़ में कीटोन बनता है और वो जहर पूरे बॉडी में फैल जाता है और पेशेंट मरने की स्थिति में आ जाता है। लेकिन यदि वह समय पे आ गया और सही ट्रीटमेंट पा गया तो वो ऐसे मरते मरते जिंदा हो जाता है। तो यह बहुत बड़ा हमारे लिए वरदान है कि आज डायबिटिक कीटोएसिडोसिस से हमारे टाइप 1 डायबिटीज़ बच्चे नहीं मरते हैं, क्योंकि बहुत सारी सुविधाएं अब उपलब्ध है। तो ये एक वरदान है कि जान बच जाती है तुरंत। मतलब आप जैसे ही पेशेंट आता है ऐसे आता है और विद इन 1 घंटे में वो यूं हो जाता है। तो ये है चीज जो वरदान है इंसुलिन और मैनेजमेंट ऑफ फ्लूइड बैलेंस का। तो ये एक कंडीशन है। दूसरी है यूटीआई, जो कि फीमेल्स पे बहुत कॉमन है डायबिटिक पेशेंट्स में, जैसे कि मैडम ने बताया पाइलोनेफ्राइटिस। तो यूटीआई वाला पेशेंट खाना ही नहीं खाएगा बहुत दिन तक घर में। अरे क्या बताएं, हमारी अम्मा तो 5 दिन से खाना नहीं खा रही थी सर, बहुत ज़्यादा बीमार है। फिर जांच कराइए तो उसमें WBC काउंट बढ़ा है, यूरिन में बहुत ज़्यादा इन्फेक्शन है, आप इनको 1-2 दिन के लिए भर्ती कर दीजिए। तो जैसे ही उनको 2 डोज एंटीबायोटिक के जाते हैं, IV फ्लूइड्स के जाते हैं, अरे का कमाल कर दो दद्दा आपने, अम्मा तो खूब खाना मांग रहा हुई है। तो ये कमाल होता है ऐसी कुछ बीमारियों में, और पेशेंट भी वाकई में उसका जो जीवन कैसे व्यतीत कर रहा है वो हम लोग भी महसूस करते हैं।
थैंक यू सो मच सर। सर आपके कुछ ऐसा एग्जांपल, कुछ ऐसे एक्सपीरियंसेस जब आपने ऐसा फील किया हो?
हाँ, डेफिनेटली सर का अदर पार्ट ऑफ डाइके हाइपोग्लाइसेमिया, पेशेंट कम्स इन कोमा, बेहोश होके आया है, उनको आई स्पेशलिस्ट ने ऑपरेट किया है, उन्होंने डायमॉक्स लिखा है 1 TDS, तो गलती से डायोनिल चला गया, क्लिबेंट वंस अपॉन ए टाइम, तो पेशेंट बेहोश होके आ गया है, सर डायग्नोसिस किया 5% डेक्स्ट्रोज दे दे, पेशेंट उठ के बैठ जाता है। सो दैट इज वंडर्स इन मैनेजमेंट ऑफ डायबिटीज, और द सिचुएशन ड्रास्टिकली चेंजेस इन डायबिटीज एंड इन डायबिटिक मैनेजमेंट स्पेशली अभी पेटेंट निकल गया तो SGLT2 inhibitors are become affordable in our country. Same thing, patient comes with 300-400 diabetics, you give SGLT2 inhibitor 3 days, it was so, Dr. Saab, wonderful.
अब तीसरा जो कि नॉर्मली इंडिया में सब लोग चाय पीते समय डिस्कस करते हैं, और आज का दिन भी है, 2 बड़े बड़े मैच चल रहे हैं, तो क्रिकेट से भी सवाल होगा। तो क्रिकेट में नॉर्मली देखते हैं विराट कोहली बैटिंग कर रहा है, बाहर जाती हुई बॉल को छेड़ दिया, आउट। अब हर किसी का ओपिनियन खड़े होके होता है कि अरे ये क्यों कर दिया। बात भी बड़ी सही है कि वहाँ वो ये चाहता था कि उसको मैक्सिमम रिवॉर्ड मिले, लाइक 4 रन, इधर उसको जो अनडिजायरेबल चीज़ थी वो मिल जाती है। तो डायबिटीज पेशेंट के मैनेजमेंट में ऐसा कौन सा सिनेरियो ऐसा होता है जब वहाँ पे ऐसा रहता है कि बस बाहर जो जाती हुई इस बॉल को नहीं छूना है? तो व्हाट इन योर क्लिनिकल एक्सपीरियंस इज समथिंग लाइक आई वुड से in especially in antibiotic treatment in diabetes, if you would say, what all precaution you should take like not to touch that?
May I sir? Yeah. See the first part of the question.
Yes sir.
Ball छोड़ रहा था.
हाँ.
Diabetic neuropathy, worst thing to treat in diabetes. किसी का practice नुकसान करना है. I am from army, never practiced in my life. I just come joined in private practice for few months now. So किसी का practice diabetic neuropathy patient को दूसरे diabetist को भेज दो, तो his practice is like he's not going to improve. So that is what where the cricket ball छोड़ना है. So that's it. And otherwise, optimum management of diabetes, we have got 508 drugs for the management of diabetes. We can pick up 3-4 of them, and proper management diabetes, proper management with statins, proper lifestyle. Diabetes is one of the wonderful disease to be treated. I'm sure Dr. Dengra will agree. Dr. Mohan Diabetic Center, they celebrate centenarians who have been taking oral hypoglycemic drugs over a period of time, who have celebrated their golden jubilee of being detected diabetes. So that is the best happy situation of diabetes there. Our patients will be loyal to us, patient will be happy with our treatment, and patient will live long enough. Diabetes is not a disease. It's not a disease where we have to think seriously about it. If we respect diabetes, you can hit century. That is the message.
सर ने बड़ा अच्छा जवाब दिया। सर आप भी कुछ बताइए ऐसा सिनेरियो जहाँ बाहर जाती हुई बॉल को नहीं छिड़कानी नहीं करनी है।
बाहर जाती हुई बॉल की छिड़कानी नहीं करनी है कि एग्रेसिव इंसुलिन थेरेपी। हम देखते हैं कि शुगर 500 है और एकदम से इंसुलिन लगा दिया तो उसकी शुगर एकदम से लो हो जाती, तो गो स्लो गो लो। तो आप कोई भी पेशेंट पहली बार आया है तो उसको इंसुलिन थेरेपी अगर चालू कर रहे हो तो उसके बॉडी वेट के हिसाब से, उसकी हिस्ट्री के हिसाब से उसकी किडनी की जांच जरूर कराना है, क्योंकि अगर क्रिएटिनिन बढ़ा है तो 1 यूनिट इंसुलिन उसके शरीर में 10 यूनिट के बराबर काम कर सकता है, क्योंकि हमारा बॉडी से कोई भी दवाई कहाँ से निकलती है, पेशाब से, छन के बाहर होती है। तो अगर किसी की किडनी में लोड है तो वो दवाई अंदर ज़्यादा काम करेगी तो शुगर लो हो जाएगी। तो ऐसी चीज़ें हैं जिसमें हमको सतर्कता से काम लेना है।
कार्डियोलॉजी में भी मैं एक सिनेरियो बताऊंगा।
हाँ।
कि जब इन्फेक्शन के साथ एसोसिएटेड साइनस टेकिकार्डिया रहता है, स्पेशली फेब्राइल स्टेट्स में, यूजुअली इट हैपन्स कि ऑर्थो आप वार्ड्स में देखेंगे तो बहुत ज़्यादा लोड रहता है समटाइम इन्फेक्शन, तो टेकिकार्डिया के लिए कई बार कॉल हो जाता है। बट उसमें टेकिकार्डिया यूजुअली जो है वो उसको चेज नहीं करना चाहिए। जब मोमेंट यू ट्रीट द इन्फेक्शन इट गेट सेटल्ड ऑफ। दूसरा एक सिनेरियो जो मैंने देखा कि हार्ट फेलियर पेशेंट में एसोसिएटेड टेकिकार्डिया जब रहता है तो यूजुअली जब क्लास 4 डिस्निया है तब फेलियर मैनेज करना बेटर है रादर देन टू चेज द हार्ट रेट। तो एक लास्ट सवाल और है, क्रिकेट से ही रिलेटेड है सर। लास्ट सवाल ध्यान से सुनिएगा। जब कभी देखते होंगे कि एलबीडब्ल्यू की अपील हो जाती है तो लोग कहते हैं कि बॉडी के क्लोज से खेलना चाहिए था, ऐसा नहीं था कि बॉडी से और बॉल से इतना डिस्टेंस मेंटेन कर रहे, तो ये तो होना ही था। तो ऐसे सिनेरियो वैसे तो हम मॉनिटरिंग करते हैं, बट कुछ ऐसे सिनेरियो जहां आप कहोगे कि मैं ओपीडी पेशेंट में भी बहुत क्लोज मॉनिटर करता हूं, तो वो सिनेरियोज बताइए जहां पे आपको एकदम क्लोजली मॉनिटर करना है।
जेस्टेशनल डायबिटीज हो गया, हाइपरटेंशन इन डायबिटीज हो गया, थायराइड इन डायबिटीज हो गया, इसमें हमें बहुत ही सतर्कता बरतनी है, क्योंकि जीडीएम में जैसे बात हुई दोपहर में कि हमारे को शुगर 90 खाली पेट और भरे पेट 120 रखनी है। नॉर्मल व्यक्ति की कितनी होती है? 180 के नीचे भरे पेट की रख सकते हैं और खाली पेट 126 के या 20 के नीचे। तो प्रेगनेंसी का जो फिगर है वो बहुत स्ट्रिक्ट कंट्रोल चाहिए टू प्रिवेंट कॉम्प्लिकेशंस। तो एक तो ये सिनेरियो हो गया, दूसरा हाइपरटेंशन है, तीसरा थायराइड है इन प्रेगनेंसी, चौथा किडनी के मरीज जो कि पहले अपनी बात हुई कि उनमें आपको हाथ खींच के काम करना है, क्योंकि दे में लैंड अप इनटू सीवियर हाइपोग्लाइसीमिया।
SGLT2 स्टार्ट करने के बाद सर आपका सिनेरियो कि आप क्लोजली थोड़ा मॉनिटर करते हैं इफ यू स्टार्टेड इन ए पेशेंट हु इज नॉट दैट मच।
Yes sir, same mycotic genitourinary and mycotic infections, very common, very common. And there's again somewhere again this thing na, doctor साहब ऐसे दवा दे दिया, मैं बिल्कुल ठीक था, but I am suffering with this complication and many time they won't expose this.
Anything, any comments ma'am from your side? लैब टेस्ट में बहुत क्लोज मॉनिटरिंग।
Then it is a HbA1c जैसा कि बताया। दूसरा है हमारा फ्रक्टोजामीन। जब HbA1c gives roughly 2 to 3 months control, but the fructosamine gives a 2 weeks control. It's a fractionated albumin that we are measuring.
Especially when HbA1c is not reliable. In anemia and all those cases, fructosamine is
इसके अलावा डायबिटीज़ के अलावा अगर हम बात करें तो जो ब्लड ल्यूकीमियाज होते हैं उसमें एक एंटिटी होती है APML, एक्यूट माइलॉइड ल्यूकीमिया का एक वेरिएंट है APML। ये रेसिडेंट को भी मैसेज रहता है कि अगर आपको नाइट में भी स्लाइड में इफ़ यू आर सस्पेक्टिंग APML इमीडिएटली कंसल्टेंट को इन्फॉर्म करना है, क्योंकि ये पेशेंट्स कोएगुलोपैथी में सबसे ज़्यादा जाते हैं। दे आर हाई चांसेस ऑफ डेवलपिंग DIC। तो इसके लिए वार्न किया जाता है और तुरंत कंसल्टेंट को ऑन कॉल किया जाता है कि वी आर सस्पेक्टिंग APML, तो उस हिसाब से उसको ट्रीट किया जाए। हाँ, एक्यूट प्रोमाइलोसिटिक ल्यूमिया, क्योंकि इसका ट्रीटमेंट भी अलग है। अपार्ट मतलब AML में जो ट्रीट दिया जाता है उससे ट्रीट नहीं होता, ये तो एट्रा थेरेपी से ट्रीट होता है। तो APML इज़ वन जो कि हम वी कीप आस्किंग, रिमाइंडिंग आवर रेसिडेंट, मिले तो तुरंत इन्फॉर्म करना है आपको।
ये जो मैम ने बात बताई है मेरे को, मैम ने एक बार 2008 में भी बताई थी।
अरे वाह।
इन द ईयर 2008 मैम वाज टीचिंग मी दिस थिंग एंड क्लास में मैम का लेक्चर था, इट वाज वेरी
इम्पोर्टेंट। थैंक
यू एवरीवन फॉर द टू ऑल आवर।
बहुत जोरदार तालियां हो जाए शिशिर सोनी सर के लिए कि नया इनोवेशन आया है बॉलीवुड और स्टॉक मार्केट का, जो क्वेश्चंस और क्रिकेट। तो ये बहुत ही इनोवेटिव और एकेडमिशियन है, बहुत ही अच्छे कार्डियोलॉजिस्ट हैं, सबकी हेल्प करते हैं, गरीब मरीजों को भी वहाँ बहुत ट्रीट करते हैं। मेडिकल कॉलेज में है ये। कभी आपको कोई पेशेंट लगे कार्डियोलॉजी में तो इनका नाम लिख के भेजिए मेडिकल कॉलेज में, सुपर स्पेशलिटी में। और इनका जो डायग्नोसिस है और जो नॉलेज है एंडलेस। मैं इनके साथ बहुत दिनों से काम करता हूँ, तो ये हार्ट बोल रहा है तो बहुत बहुत धन्यवाद इस सेशन को बहुत बखूबी और इतने इनोवेटिव तरीके में करने के लिए। जैसे कि मैं इनोवेशन करता हूँ, नया मैंने पोस्टर स्पेशल डॉक्स बनाए हैं डॉक्टर्स, ऐसे ही आप भी स्पेशल चीज़ें बनाते हैं, उसके लिए धन्यवाद। थैंक यू।
Thank you so much, sir.
Thank you to our faculty. Momento, please. Yeah. Bouquet to sir. Chairpersons, please come. Momento of Shishir sir, Ranu madam. We will give them mementos. Thank you.
A round of applause for this lovely interaction, please.
Award में
For a wonderful
आपका
Thank you so much, everyone.
उसमें फोटो भी लगी थी।
Moving on to our next session,
मिल गए।
I request
यही तो है शिशिर।
our chairperson, Dr. Shishir Soni sir,
ये लो सर आइए। मैडम आइए
Brigadier
मैडम।
Dr. Satyanarayan, Brigadier Dr. Satyanand sir as a
जोरदार तालियां शिशिर सर के
chairperson,
लिए। चेयरपर्सन सत्यानंद सर।
Dr.
केसी चोपड़ा सर।
Jigyasa Dengra ma'am as a chairperson, please.
मैडम मनीष सर का रखा है तो आपको ही दूं मैं, वो सर आ नहीं पा रहे हैं ना, लेके आओ।
Our next session will be carried by Dr. Ashish Dengra sir, who will be speaking on the topic Imiglumin, a powerhouse approach to diabetes mellitus.
आइए मैडम, ये जिज्ञासा भी देगी ना साथ में, आ जाओ मनीष सर का, लो बेटा फोटो।
I request our
फोटोग्राफर
chairperson,
लैपिन माइक लगाओ। ऊपर ही आ जाओ यहीं कर।
I request our chairperson.
क्या?
Kindly
Word
take
about
us-
Dr. Dengra sir. I'm very new to Jabalpur. I just joined
नहीं
Apollo
तो उससे कोई
Hospital.
दिक्कत थोड़ी ना, वो तो कोई ज़्यादा नहीं है, अपन सब साथ वाले ही हैं, आ जाओ, कुछ नहीं होगा।
So if Dengra sir would not have been in Jabalpur or not in medical science, probably he would have been competing with Hrithik Roshan or Shah Rukh Khan.
अरे बाप रे।
So with that compliments, I would request Dengra sir to go ahead with his presentation.
Thank you sir. So in 5 मिनट और झेल लीजिए, उसके बाद जो लोग बैठे हैं उनको गिफ्ट दिए जाएंगे। थैंक यू फॉर बीइंग हियर, क्योंकि लकी ड्रॉ वाले जो डॉक्टर्स जिनका निकल रहा है वो है ही नहीं, तो जो बैठे हैं उनको दिया जाए। थैंक यू फॉर बीइंग हियर। 5 मिनट में अपन एक नई दवाई पढ़ेंगे आज, इमिग्लिमिन, अ पावर हाउस अप्रोच टू टाइप 2 डायबिटीज। तो इमिग्लिमिन एक नया दवाई है जो कि आपको यहाँ पे मैं 5 से 7 मिनट में बताऊंगा कि वो कैसे काम करती है। तो पैथोफिजियोलॉजिकल समरी, डायबिटीज होती क्यों है? 2 प्रकार से, या तो इंसुलिन कम बन रहा है या तो उसका काम नहीं हो पा रहा है बॉडी में। तो इंसुलिन कम बन रहा है उसे कहते हैं इंसुलिन सिक्रीशन डेफिशिएंसी। दूसरा है इंसुलिन रेजिस्टेंस, मतलब बन तो रहा है इंसुलिन लेकिन सेल में जाके काम नहीं कर पा रहा है। तो इसीलिए आपका माइटोकॉन्ड्रियल डिस्फंक्शन ड्राइव्स ऑक्सीडेटिव स्ट्रेस एंड इन्फ्लेमेशन एग्रीवेटिंग इंसुलिन रेजिस्टेंस एंड बीटा सेल फेलियर। तो यदि आपका माइटोकॉन्ड्रियल डिस्फंक्शन होगा, माइटोकॉन्ड्रिया क्या होता है? हमारा सेल के अंदर जो मेन इंजन है वही माइटोकॉन्ड्रिया रहता है और वही हमारे बॉडी को मैक्सिमम सेल को एनर्जी देता है और चलाता है। सो टाइप 2 डायबिटीज आपको इंसुलिन सिक्रीशन की कमी से या रेजिस्टेंस के वजह से हो सकता है और उससे आपकी सेल्यूलर इंजरी होगी, रिएक्टिव ऑक्सीजन स्पीशीज बनेंगी और माइटोकॉन्ड्रियल डिस्फंक्शन पैदा हो जाता है। इसीलिए लिमिटेशंस ऑफ करंट थेरेपीज इन टाइप 2 डायबिटीज क्या है? जो दवाइयाँ ऑलरेडी उपलब्ध हैं वो क्या प्रॉब्लम देती हैं? जैसे कि मेटफॉर्मिन, इससे आपको जीआई साइड इफेक्ट होते हैं। अनुराग ये बात कर लो नीचे, ये कौन किसका फोन है? सो मेटफॉर्मिन से आपको पेट में कभी कभी खराबी हो सकती, पेशेंट बोलता है कि मुझे पेट फूल रहा है। और सल्फोनिलुरिया से एकदम से शुगर तो आपको ये प्रोज एंड कॉन्स देखने हैं कि किस दवाई से क्या हो रहा है। SGLT2 इनहिबिटर जो आजकल डापा product with mitochondrial dysfunction and it is approved in India by DCGI in June 2021. ये काम कैसे करती है? माइटोकॉन्ड्रियल बायो एनर्जेटिक्स एंडोथेलियल सेल और बीटा सेल पे काम करती है। इट इज improving the function of mitochondrial cell, mitochondrial respiratory chain complex activities and it is decreasing the reactive oxygen species. आपको कहते हैं ना कि चलिए अपन चलते हैं वेलनेस थेरेपी लेके आएंगे। वेलनेस थेरेपी मतलब जब आप लेटते हो वहाँ पे ऋषिकेश में 50,000 रुपए दे के तो आपकी बॉडी को डिटॉक्स किया जाता है, तो रिएक्टिव ऑक्सीजन स्पीशीज को कम किया जाता है। इसी तरीके से ये दवाई माइटोकॉन्ड्रियल बायोएनर्जेटिक्स को संभालती है, एंडोथेलियल सेल्स को इंप्रूव करती है, बीटा सेल के रिस्पॉन्सिवनेस को इंप्रूव करती है। सो मैकेनिज्म ऑफ एक्शन इज माइटोकॉन्ड्रियल पाथवेज and other cellular pathways and it improves the insulin secretion and function. Pharmacokinetically it is absorbed, rapidly distributed to organs and tissues and it is having insensitive to ethnicity and food intake and rapidly absorbed and distributed. So impact of immunoglobulin on endothelial function, heart, adipose tissue and brain. तो ये हार्ट पे, ब्रेन पे सब जगह पॉजिटिव बेनिफिट देती है। अब मेटफॉर्मिन और इमिग्लोबिन के बारे में जब हम बात करेंगे तो देर इज इंक्रीज ग्लूकोज स्टिमुलेटेड इंसुलिन सिक्रीशन विथ इमिग्लोबिन, बट मेटफॉर्मिन क्या करता है? इंसुलिन रेजिस्टेंस को सिर्फ कम करता है, पर इमिग्लोबिन दोनों काम करता है। इट हेल्प्स टू इंप्रूव द इंसुलिन सिक्रीशन एंड डिक्रीज द इंसुलिन रेजिस्टेंस। इज देयर एनी सीवी एफिकेसी? सम स्टडीज हैव शोन, कुछ स्टडीज में ये देखा गया है कि द हार्ट फेलियर प्रिवेंशन एंड इट प्रिजर्व्स द इजेक्शन फ्रैक्शन बाय रैपिडली रिकवरिंग द impaired unfolded protein response in mice subjected to cardiometabolic stress. So the treatment of imiglomin started at 10 weeks not only improved abnormal systemic glucose metabolism, मतलब सिर्फ शुगर को कंट्रोल नहीं कर रहा है, it improves the visceral obesity, but systemic inflammation is also reduced and prevents the development of heart failure. Absence of QT prolongation in a thorough QT study with imiglamin, a first-in-class agent. So it has established the electrophysiological effects in and demonstrated the supra-therapeutic exposure of imiglamin did not induce the QT prolongation. क्योंकि आजकल दवाइयों में हार्ट पे कोई साइड इफेक्ट तो नहीं हो रहा है, तो ही वो मार्केट में रिलीज की जाती हैं. जब आप ये अध्ययन कर लेते हैं कि साइड इफेक्ट नहीं है हार्ट पे, तो ही वो दवाई रिलीज होने देते हैं. तो दैट इज वेरी इंपॉर्टेंट. द रिस्क ऑफ मेटाबॉलिक lactic acidosis with metformin is higher in contrast to the imiglamin. Advantages for kidney: 5 mg twice daily for patients with EGFR or 15 to 45, and 500 mg with a longer dosing interval was suggested for EGFR less than 15. तो यदि किसी की किडनी खराब है तो भी आप ये सेफली दे सकते हैं 500 मिलीग्राम बीडी में. Major published phase 3 trials are there. Meta-analysis have shown the positive benefits, and HbA1c reduction with imiglamin given as monotherapy was positive. And 1000 milligram BD dose है नॉर्मल व्यक्ति में, और किडनी वाले में 500 milligram BD, और अगर EGFR बहुत कम है तो OD. Fasting sugar was reduced with monotherapy, and it is efficacious, was proved in this randomized controlled trial. The results were showing the reduction in HbA1c. This is the CGM graph. बिफोर एंड आफ्टर. जब आपने देखा कि गोली नहीं दी है तो इतना हाई शुगर हो जा रहा था उसका लंच के बाद, नाश्ते के बाद, जब वो दवाई दी गई तो वो धीरे धीरे 150 के नीचे आने लग गया. इंडियन पेशेंट्स के ट्रायल हुए हैं इंडी टाइम्स, और 1000 मिलीग्राम बीडी ये दवाई दी गई तो उससे क्या फायदा हुआ? फास्टिंग पीपी शुगर कम हो गई और HbA1c 1.12% से कम हो गया. सो दिस इज द इंडी टाइम HbA1c रिडक्शन, फास्टिंग पीपी रिडक्शन, and it has shown the positive benefit on liver and kidney profile. So improvement in renal parameters and liver lipid parameters. Adverse effects बहुत ज़्यादा नहीं है, किसी किसी को वही गैस, ब्लोटिंग या एब्डोमिनल पेन, नॉजिया, वोमिटिंग हो सकता है, वो तो हर दवाई से किसी को भी हो सकता है. अब हमारे पास कई पेशेंट आते हैं जो गैस की दवाई से भी गैस बन रही है, तो उसके लिए क्या बोलोगे? तो इंडिया में हर मरीज अलग है, और एक पेशेंट तो एलर्जी की दवाई एविल डेकाड्रान बोलता है ये अगर मैंने खा ली तो मुझे एलर्जी हो जाएगी. तो मैंने कहा तुम तो फिर बच ही नहीं सकते, वही तो दवाई बचाने के लिए होती. तो मैंने कहा तुम्हारे लिए तो बचाने के लिए कुछ बचा ही नहीं फिर. तो recent studies suggested imiglamin ability to modulate mitochondrial function, and it is when it was studied in metformin intolerant patient, it have shown good beneficial effect. So real world studies have been done, and the case control study was also showing the positive benefits. Imiglamin in Indian context, the monotherapy and dual drug therapy has been studied. So अंत में ये दवाई क्या करती है, एक स्लाइड में हम बताते हैं कि imiglamin has shown the positive benefit on skeletal muscle glucose uptake, hepatic glucose production, and beta cell apoptosis, important targets for Asian Indians. It demonstrated good efficacy with monotherapy and also with combination. Maximum benefit was seen when used with DPP4 inhibitors. The studies have shown better tolerance and less adverse reaction as compared to the other drugs. So ये एक नई दवाई आई है imiglamin, जो कि मार्केट में अब उपलब्ध है, और 1000 मिलीग्राम बीडी इसका डोज है. अगर किडनी खराब है या डिस्फंक्शन है तो आपको 500 मिलीग्राम देना है. imiglamin नाम से आती है ये, imiglamin. और इसका अगर पेशेंट मेटफॉर्मिन नहीं ले पा रहा है तो ये आप स्टार्ट कर सकते हैं. अगर मेटफॉर्मिन सल्फेनिलुरिया के साथ ले रहा है और आपकी शुगर कंट्रोल नहीं है तो भी दे सकते हैं. तो ये किसी भी दवाई के साथ आप आसानी से चालू कर सकते हैं. थैंक यू.
A novel molecule, not many of us heard about it, but sir is so brave enough to start with very good results also. Open for discussion. Any comments from the house? Questions?
तो अभी एक डॉक्टर साहब आए हैं जो अपना पेपर प्रेजेंट करेंगे. शिशिर यहीं करा ले, थोड़ा सा वहाँ पे पेन ड्राइव में दे दीजिए. एंड डोंट पैनिक, सब फैमिली है. ये थोड़ा नया टॉपिक है इनका. लेट्स सी. और ये लिस्ट मेरे पास आ गई है जो डॉक्टर बैठे हैं, कोई छूट रहा है तो बताइए। डॉक्टर आलोक मिश्रा, जेपी कौशल, एमएल जहांगीर, एमएल विश्वकर्मा, क्या नाम है, डॉक्टर महेंद्र बुंदेला, प्रमोद पटेल, मनोज चौधरी, वत्सल राम चौधरी। आपका नाम क्यों नहीं लिखवाया? लिखो ना। बोलो।
ड्रग की लिमिटेशंस क्या है?
किसकी
Immediately.
लिमिटेशंस? ये है कि जीआई साइड इफेक्ट थोड़े हैं तो उसमें अवॉइड करना है। बेसिकली मोस्ट ऑफ द पेशेंट्स आर हैविंग यूजुअल कॉमन कॉम्प्लिकेशन इज जीआई साइड इफेक्ट। But you cannot replace metformin. If you are tolerant, then it is the first choice.
In terms of A1C reduction?
A1C reduction, मतलब metformin will give you 0.5 to 0.8 and similar is with this 0.5.
प्रेजेंटेशन कैटेगरी क्या है आपका? पोस्टर प्रेजेंटेशन या एब्स्ट्रैक्ट प्रेजेंटेशन? पोस्टर प्रेजेंटेशन, ओके।
है? बस हो गया ना? ये लास्ट है, सर तो जीते ही हैं उसमें, सर को तो पहले देना है। वो कहाँ है? वो कहाँ गए गिफ्ट जो लाए थे? नहीं नहीं, ये क्या है? ये क्या है? खत्म है नीचे का? हाँ बंद करो, उठा लो। हाँ हाँ, वो छोड़ दो, बंद कर। बंद करो ना नीचे का। पहला बहुत, वी विल कॉल यू रेगुलरली। सर का नंबर ले लो। ये केसी चोपड़ा सर को जो पहले प्राइज निकला था उसके लिए बहुत बहुत धन्यवाद और बधाइयाँ। एटम बम है क्या इसके अंदर, पूछ रहे हैं सर? एटम बम है, हाँ। बैठिए, थैंक यू। हाँ देखिए वहाँ देखिए, एटम बम है। चाय बस अभी पिलवाएंगे, आप भी तैयार कर लीजिए प्रेजेंटेशन, वहाँ पे दे दीजिए।
I think you can start your presentation.
मेल से दे दो ना, अरे कुछ नहीं होता।
Yeah, you have 2 minutes. You can start your presentation.
All of you. I report a case of.
Yeah, introduce yourself. You are.
I am Dr. Ashwarya Nigam. I am a third year PG resident at SSMC Riva.
Okay.
In Department of Medicine.
Okay.
We reported a case of 2,4-dichlorophenoxyacetic acid, 2,4-D, which is a herbicide, and it's poisoning.
Yeah.
Overall, agriculture poisoning is most common in India, but 2,4-D poisoning is rare in itself. Here, there is a case report, 17-year-old female presented in our emergency department with ingestion of 50 ml of 2,4-D. After that, after 3 hours, she came with complaint of restlessness, irritability, exhibited stiffness of both hands. On examination, patient had myotonia, and altered sensorium. On investigation, patient had CK total level 1790, which was suggestive of myotoxicity, and renal function suggestive of mildly raised urea and creat, which was suggestive of nephrotoxicity. Actually, this poison affect 3 parts: gastrointestinal system, musculoskeletal system, and it is neurotoxic. In gastrointestinal system, it has a corrosive effect, GI bleed, abdominal pain, and on musculoskeletal system, it has effect like muscle fibrillation, muscle fasciculation, severe myalgia, rhabdomyolysis, myopathy, Neurotoxic manifestations are altered mental status, confusion, drowsiness, coma, seizure, ataxia, nystagmus. This patient came to us with all these complaints. Further, on management of this patient, the output of this patient was reduced and patient had altered mental status, for which we monitored the patient for blood urea and create and urine output. Earlier the urine outputs were reduced, but a sole principle in this case of poisoning, there is forced alkaline diuresis, which is an unsung hero in this case. If we do alkaline diuresis with maintaining a pH of 8, then after diuresis, the patient in 24 hours got his sensorium back and urea create to a normal level and decreasing creatinine kinase levels. So in conclusion, 2,4-D poisoning is uncommon but can occur with intentional ingestion. Early recognition and prompt management of this poisoning can help in better management. Renal function monitoring is essential as AKI can develop due to both direct nephrotoxicity and rhabdomyolysis. No specific antidote exists, just symptomatic management is essential. Rapid clinical improvement is possible if timely intervention has been done. Thank you.
So good. So there are certain questions for you. जब भी कभी neurological symptoms भी किसी में आते हैं तो sometimes conscious unconscious हो जाता है. So there are certain instances when a patient cannot tell you that he has exactly taken this particular element, or you don't have any conclusive evidence to say like you have this medicine bottle in front of you, or he might have told you that he has taken ingested this thing. Sometimes children also used to ingest something which they are not aware of that this is the. So what are the points in favor which specifically suggest that the patient might have taken 2,4-D rather than if you don't have that information prior to admission?
Firstly, if patient have their attenders with them, mostly they take the photo.
No, it's a clear-cut blind. Nobody is knowing what patient has taken.
Then only we can do symptomatic management because it is rare poisoning.
Okay, so can you tell me some other poisons which are available which are having a very similar presentation?
Cypermethrin, pyrethroid derivatives, then that on high level of ingestion can produce similar symptoms of myotoxicity, renal toxicity and altered mental status.
What are the cardiovascular manifestation in this poison?
Hypotension and rarely can develop myocarditis.
Can develop myocarditis. Okay. So can you tell me certain poisons, because you have presented this thing, which can lead to ventricular tachycardias?
Sulfos.
Any other?
Digitalis and aconite.
Yes. What is the classical ECG presentation in aconite poisoning? Okay, good.
We request to Ashish sir, kindly come on the rise. Skin chalu, skin
Sir,
chalu.
wait.
Yes, sir.
Sir.
Hello, sir. Sir, one question there. Dr. Vatsalopadhyay here. Can any type of culture is helpful in this case? Blood culture or urine culture or a sputum culture? We can intermediate.
Sorry?
Is any type of culture, blood culture or urine culture or sputum culture, we can correlate with this case? Can it is helpful for in this case?
No.
No need.
HPLC for 2,4-D level can help in diagnosis, but other than that, nothing is that much helpful.
Okay,
Only symptomatic management, early diagnosis and treating it with forced alkaline diuresis, we can manage this case. Otherwise, if patient comes late, we have to go with hemodialysis for 3 to 10 sessions. After that, the urine output will increase.
It's a temporary dialysis.
Temporarily.
Okay, thank you.
Sir.
Sir, he has done that.
Completed.
Yes.
Topic क्या था?
2,4-D poisoning. Poisoning. 2,4-D poisoning.
So, Sheikh, you can come. अरे कर दो यार क्या है? इसका भी एक वो था
हमारा भी
पेपर.
एक है ना?
टॉपिक क्या था? टॉपिक क्या था? टॉपिक आ जाओ घबरा में होना पूछी चेस का थे पंजे मैं पेन ड्राइव से 5 वहाँ देखो छूट गए क्या? वही तो वहाँ वो गिर गए ना पेन ड्राइव देखो वहाँ नीचे गिरे हैं क्या? ये वापस डालो ये वाले ये 10 थे जो पॉलिथीन रखी थी वहीं पे रखी थी तुमको जो दी थी देखो हैं? हाँ ये तो वापस मयूर को वापस जाएगा ये बैग वाला ये लेके आओ बेटा सर हाँ। ये भी पेन वाली ट्रे बना दी इसको क्या पता तेरे को? वो कहाँ गया बालक? बेटा आपका नाम क्या है? आ जाओ इधर आप अपना इंट्रो दे दीजिए.
My name is Dr. Ashwarya Nigam. I am a third year PG resident at SSMC Riva in Department of Medicine.
तो थैंक यू आप रीवा से दूर इतनी दूर आए आपने प्रेजेंट किया तो इनको पोस्टर प्रेजेंटेशन में कौन सा अवार्ड देना फर्स्ट सेकंड थर्ड तो ये इनको फर्स्ट प्राइज देते हैं अपन 5,000 रुपीज़ का तो आपको बहुत बहुत बधाइयाँ कॉन्ग्रेचुलेशंस. फोटो मोमेंटो ले आओ एक मोमेंटो मोमेंटो दे दो सर को ये वाला ही अच्छा ये बड़े वाले किसके छूट गए हैं इसको देंगे ना अभी और ये जो है जो लड़की वो बताओ ये भिजवाने हैं उनको वो वाले गाड़ी में रखवा थैंक यू कॉन्ग्रेचुलेशन.
2 मिनट बैग लेके आ
नहीं रुको तुम ही पेन इधर ये उठा के आ जाओ तो बांटते चलते हैं एक हाँ फोटो खिंचाना है एक ग्रुप फोटो हो जाए. सर को तो दे दिया. डॉक्टर आलोक मिश्रा जी को बधाइयाँ. डॉक्टर जेपी कौशल जी को बधाइयाँ. तालियां बजती रहें. एमएल विश्वकर्मा जी आपको बहुत बहुत बधाइयाँ. एमएल जहांगीर साहब बहुत बहुत बधाइयाँ. बुंदेला जी बहुत बहुत बधाइयाँ. सुशील तिवारी सर बहुत बहुत बधाइयाँ. महेंद्र को हो गया ना. प्रमोद पटेल जी आपको बधाइयाँ. मनोज चौधरी सर आपको बधाइयाँ. राम आपको बहुत बहुत बधाइयाँ. एक पाव का आइटम में वो श्याम सर थैंक यू. मैडम थैंक यू. बुशरा मैडम थैंक यू. वत्सल भाई बुस्ट्रा का होगा, एस के पटेल, थैंक यू। रवि राय जी, रेखा पटेल, सृष्टि, शैलजा, तनुश्री, और कहीं रह गया सर को? हाँ ठीक है, को भी दे दो। सॉरी, थैंक यू। आप भी आ जाइए, आपका फेलिसिटेशन है, आइए इधर आइए। तो पूरे मंच का संचालन जो
हेलो
शर्मा ने किया है, उनको कौशिकी शर्मा, इन्होंने जो मंच का संचालन मास्टर ऑफ सेरेमनी प्रोग्राम में पूरी सहायता करी 2 दिन में। शिशिर आप भी आ जाइए, तो इनको जिज्ञासा आ जाइए, जोरदार तालियां दीजिए कि इनका प्रोत्साहन बढ़ता जाए और ये और बेहतर से बेहतर होती जाए। अभी इनकी जो उम्र है उसके हिसाब से इनने बहुत बड़ा कार्य किया है, उसके लिए बहुत बहुत धन्यवाद और तालियां लीजिए। और शिशिर सर भी हमारे मास्टर ऑफ सेरेमनी थे साथ साथ, जोरदार तालियां भाई। थैंक यू, कॉन्ग्रेचुलेशन। आप उनसे मिलते जाना और भी आप। हाँ सर को भी देंगे, वो पेन सब मैडम को दे दिया, चोपड़ा साहब को भी दे दिया। नहीं स्पेशल है, मैग्नेटिक। सर आएंगे ना, उनको दे दीजिएगा, अभी सर आएंगे। जाएंगे, थैंक यू। सर्टिफिकेट दो ना बेटा, सर्टिफिकेट लाओ वाले वाइट वाले, आ जाओ। वो मोमेंटो ले आओ, छोटे वाले मोमेंटोज हैं तो वो भी ले आओ। अच्छा नहीं आए, ये वाले हैं ना, आ जाओ वहाँ पे। वहीं के लिए वहाँ मजा आएगा। कौन से? बताइए ना। हेलो, हेमंत स्टेज पे आइए, निधि स्टेज पे आइए। ये लो बेटा, ये अलग आए क्या? वत्सल, ओ वत्सल, 3 देना है ना, 3 देना है, दे दो। वो छोटा वाला लिया माही के लिए। और वो कहाँ है राम? दूसरा दे रहे, आपको भी दे रहे, निकालो। वो कहाँ गया? हेमंत चलो ना ऊपर, और निधि को भी ले चलो ऊपर। हाँ ये ले ना कलर। ये कहाँ गया वो? हाँ सर मैं लगा। बैग दो बेटा सर को, इतनी देर रुके हैं तो जो बोलोगे वो मिलेगा। थैंक यू। हाँ हाँ मोमेंटो दे रहे हैं, कल ले गए थे आप एक। हाँ ये लीजिए, आ जाइए। अच्छा छोटा है, बड़ा वाला दे दो, बड़ा वाला। हाँ यही तो दे दिया, एक बड़ा वाला और ले आओ, 2 बड़े वाले ले आओ। चलो ये सब ले आओ। आपको बैग नहीं मिला बेटा? बड़ा वाला बैग दे दो सर को, बड़ा वाला निकल रहा है। ठीक, थैंक यू। अरे वाह मजबूत है बहुत। चलो आप जी, अरे बाप रे, आए भेज दीजिए कल। थैंक यू। हेलो डॉक्टर हेमंत, निधि आप प्लीज स्टेज पे आ जाइए। आज हम लोगों ने टाइप 1 डायबिटीज के बच्चों का भी प्रोग्राम किया, जो कि नीचे। मुस्कान आ जाओ बेटा, आना है तो यहाँ आ जाओ। क्या पूछना है कुछ? आ जाओ। हाँ किसका हो गया ना? कौन सा? हाँ सर्टिफिकेट पार्टिसिपेशन वाला, दैट आई विल सेंड यू, नो डोंट वरी, क्योंकि विथ चेक आई विल सेंड यू। हाँ अभी जो हम लोगों ने प्रोग्राम किया था आज बच्चों का टाइप 1 डायबिटीज पे, डिस्चार्ज नहीं बनाया क्या उसका? हाँ पी के सही है, डॉक्सी और हाँ बस भेज रहा हूँ, 2 सेकंड। आज पूरे दिन इन लोगों ने बच्चों को पूरी पढ़ाई करवाई कि टाइप 1 डायबिटीज़ में क्या करना है, और ये हमारे साथ पूरे रात दिन मरीजों की सेवा में लगे रहते हैं। ये हमारे डॉक्टर हेमंत हैं, ये हमारे साथ पिछले 15 साल से पूरे हॉस्पिटल को, पूरे मरीजों को संभाल रहे हैं। और जैसे कि आप जानते हैं कि जड़ जो होती है उसके बगैर पेड़ बड़ा नहीं होता है, तो ये हमारे हॉस्पिटल की जान है, शान है। और इनकी वजह से बहुत सारे मरीज घर बैठे इलाज लेते हैं। जो बच्चे हैं टाइप 1 वाले, उनको ये मोबाइल पे पूरा सपोर्ट करते हैं, तो उसके लिए बहुत बहुत तालियां। क्योंकि बच्चे आ नहीं पाते हैं, माता पिता इतना फ्री नहीं रहते, तो भी ये सपोर्ट करते हैं। तो हमारी जो सपोर्ट टीम है वो बहुत ही इम्पोर्टेंट है। इसमें टाइप 1 डायबिटीज़ के लिए हो, या जब बच्चा गर्भावस्था में GDM हो, जब प्रेगनेंसी में डायबिटीज़ होती है, तो भी ये बहुत हम लोग हेल्प करते हैं। तो इनके पास सारे फिगर जाते हैं और ये उसको एडजस्ट करते हैं। तो बहुत बहुत तालियां इनके लिए। और आज इन्होंने बच्चों को पूरा ज्ञानवर्धक पूरी चीज़ें बताई कि इंसुलिन कहाँ रखते हैं, कैसे लगाते हैं। तो इनके लिए हम एक फेलिसिटेशन प्रोग्राम करते हैं। डॉक्टर हेमंत, ये निकालो पन्नी। आइए निधि, आप भी दीजिए। जिज्ञासा कहाँ गई? आओ जिज्ञासा मैडम, आइए। थक गई। फराज, मोहसिन, कम फेलिसिटेट कर देते हैं थोड़ा सा। आ जाओ, आ जाओ, यहीं आ जाओ, आ जाओ मोहसिन। ये हमारे निधि, इधर आ जा बेटा, इस तरफ। ये हमारे डॉक्टर हेमंत हैं हॉस्पिटल में। तालियां बजती रहें। बैग देखो। ये बिटिया के लिए कुछ सामान लेती है। ये डॉक्टर निधि हमारे यहाँ डाइटिशियन है, आइए। इनका भी सम्मान करते हैं। ये पकड़ो। हमारे हॉस्पिटल में पेशेंट्स को क्या खाना है, क्या नहीं खाना है, जो सर खाते हैं, जो भी है, तो इसका सर खाते हैं जाके कि क्या खाना है, क्या नहीं खाना है। तो हम लोग बोलते हैं यहाँ जाइए और सब समझ लीजिए। तो पेशेंट्स के मन में 15 साल बाद भी आएगा तो सवाल रहते हैं कि सर खाने में क्या खाना है। शुगर का मरीज 15 साल भी बाद भी यही पूछता है, क्योंकि वो हमारे मुंह से सुनना चाहता है कि हम मीठा खाना अलाउ कर दें। मैडम फोटो तो आपका कहाँ गया? बैठो। आ जाओ, पकड़ो। थैंक यू। सब खाओ। अभी फार्मा वाले सब आ जाइए ऊपर। हाँ बस आ जाओ, इधर आ। ऊपर ये वाला निकाल, एक और, एक और निकाल, ये वाला निकाल, होगा उससे लिया वो 25 मैडम डाइटिशियन के पास।
हम नहीं करेंगे, हम आपकी छत्र का है, हम नहीं करेंगे।
ये पिटिए बच्चों के लिए
समझ गया।
ये वाला हाँ दे रहे हैं, ये मैं दे रहा हूँ। एक मैडम को दे दो। है ये, अरे आपके कितने बच्चे हैं? इधर लाओ, एक और डालो, पहले इसमें डालो एक, फिर मैडम को दे दो अगला। ठीक है, तेरे को भी 2 डालो। वो मैंने डाल दिए 2, मेरे को तो पता है, मैं इसके घर गया हूँ। क्योंकि जीरो जीरो क्या करें, ठीक है बनाएंगे आराम।
डॉक्टर गुप्ता
बहुत बड़ा यार, संभालना बहुत।
लक्ष्मी नारायण, हाँ
ऊपर आ जाओ।
जब आप बोलो।
हेलो। तो वैलिडेक्टरी फंक्शन में पहले हम बहुत धन्यवाद करना चाहते हैं प्रभु का, जिसकी वजह से ये सक्सेसफुल कॉन्फ्रेंस हुई। तो हम गणेश जी का मंत्र चला सकते हैं कि वक्रतुंड महाकाय। सबसे पहले हमें प्रभु को धन्यवाद दे रहे हैं कि ये प्रोग्राम से कॉन्फ्रेंस की वजह से ये इतना सक्सेसफुल हुआ और लोग बाहर से हर प्रदेश से आए और अमेरिका से भी डॉक्टर जबलपुर आए, ये हमारे लिए गर्व की बात है। तो डॉक्टर राजाराम ने मेरे एक रिक्वेस्ट पे ओके करके वो कल रात को दुबई से बॉम्बे पहुंचे और फिर उन्होंने सुबह सुबह 8:30 बजे करीब उनकी फ्लाइट थी, वो सीधे जबलपुर आए। तो उनको बहुत बहुत धन्यवाद, तालियां दीजिए उनके लिए। और वक्रतुंड महाकाय वाला चलो। उसके बाद जो हमारी फार्मा टीम है, सहयोग रहता है तो ये इतनी बड़ी सक्सेसफुल कॉन्फ्रेंस हो पाती है, नहीं तो ये संभव नहीं है। क्यों? क्योंकि वो एक हमारे जो पेड़ की शाखाएं रहती हैं उसकी तरह है।
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुंड
मंत्र हो गया। वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। हरिओम। तो जैसे कि अपन बात कर रहे थे कि फार्मा जो हमारे साथी हैं उनको जब तक हम लोग फेलिसिटेट नहीं करेंगे तो हमारे लिए ये अधूरा प्रोग्राम हो जाएगा। बैग्स एक एक करके लेके आइए। हेमंत ये करो यार उसका डिस्चार्ज। शुगर कितनी थी, क्या दे रहे थे पहले अपन? यही वाले, ये हाँ खोलो ना। मुझे दिखाई दो। ठीक है ना, दे दो। ठीक है, जाने बस में और कुछ तो नहीं। तो हमारे फार्मा टीम में जो हेल्प मिलती है उसके बगैर ये बड़ी बड़ी कॉन्फ्रेंसेस संभव नहीं है, क्योंकि वो लोग ट्रैवल कोऑर्डिनेशन और जो डॉक्टर्स के साथ कोऑर्डिनेशन रहता है उनको लाना ले जाना, उनकी आओ भगत करना, उसमें जो पूरी टीम लगती है वो पूरा काम ये लोग बखूबी इनके रग रग में बस गया है। जैसे हमारे को कोई नींद से उठा के भी पूछेगा कि शुगर 500 है तो क्या देना है, ऐसे ही लोग उसमें कारगर हो गए हैं, जो कि उनकी ट्रेनिंग इतनी तगड़ी हो गई है इतने दिन से यही काम कर करके। तो उसके लिए बहुत बहुत तालियां। और ठीक है, पानी अच्छे से पिए बोलना। तो जो भी कंपनी वाले अगर उपलब्ध हैं तो एक एक करके। यूएसवी टीम है क्या कोई? यूएसवी आशीष भाई तो है ही है, फोटो लेते जाएं। म्यूजिक बजाइए पीछे से थोड़ा थोड़ा। थैंक यू। जाइडस वाले खड़े हैं, आ जाइए। लो सीधा। थैंक यू। सन फार्मा, थैंक यू। यहाँ एक जना सत्तू ऊपर आ जाना बेटा, तेरे को भी दूंगा। ये बढ़ गया, ये वाला खोल दिया, कलर ये एक ये दो, ऐसे कर। कौन सा चाहिए कलर? मैं समझ गया किसी को नहीं पसंद आ रहा था। थैंक यू। और बिट्टू भैया, ध्रुव भाई आ जाओ, हैं वो सब बाद में। टीम सीनेट एक और लाओ भाई, प्रमोद भाई नाराज हो जाएंगे तुमसे। आइए। और कौन से फार्मा डिवीजन से LIC बचे हैं? और कौन बचा है? ट्रायम वाले सब बाकी घर चले गए। थैंक यू। गर्व को तक याद हो गया मेरे लौंडे को। एलिसिया, टीम ट्रायम ऊपर आ जाइए, म्यूजिक चलती रहे। लाओ दो और। जीतू भाई बीमार थे फिर भी आए हैं। मोमेंटो का काम हम लोगों ने खुद कर लिया इस साल, क्योंकि ये वो ऑटो मोड में चला गया ना, तो अनुराग भाई ने बहुत हेल्प करी मोमेंटो में। जी सर, बात कर लो तुम ही, क्या बोल रहे हैं? बोलो स्टेज पे हैं। अनुराग भाई आ जाइए। अरे आइए भाई, आप तो फैमिली जैसे हैं आपको। अरे जल्दी आओ, अरे जल्दी आओ। हाँ बुके दे रहे, चलो। क्या हो गया? आओ ना यार। अरे गिफ्ट थोड़ी ना दे रहे हैं, बुके दे रहे हैं। एमिराल्ड इवेंट्स, मयूर जी आ जाइए। आ जाओ आ जाओ। सत्तू तो रह गया, तू बताया नहीं और कौन है? अभी अभी दे। पहले सत्तू को करेंगे। सत्तू को बैग दीजिए सत्येन जी को एबॉट से। फोटो लीजिए, थैंक यू। और मयूर जी एमिराल्ड्स इवेंट्स बुके लाइए और वो बैग दीजिए एक।
डिस्पाइट,
हाँ बताइए।
इवेंट की समस्या होने के बाद पारिवारिक पिताजी की बीमारी के बाद ही मयूर दिन रात लगे रहे। इट्स अ बिग राउंड ऑफ अप्लॉज टू मयूर सर।
बहुत बहुत तालियां दी जाए। एमिराल इवेंट्स जो रात दिन लगा रहा 3 महीने से, और 4 बजे तक हम लोग बैठ के प्लानिंग करते थे, तब ये संभव हुआ है। और हर प्रोग्राम में थोड़ी बहुत हिचेस तो होती हैं, और उसको तो पार किया जाता है। जैसे कि इन्होंने इतने सारे स्टॉल लगाने में जद्दोजहद हुई, फिर भी उसको पार कर दिया और सब खुश होके गए। उसके लिए बहुत बहुत तालियां मयूर जी का और उनके इवेंट कंपनी को। और आगे काम मिलता रहे। आप लोग को भी कोई काम लगता है तो इनसे कांटेक्ट कर सकते हैं। और टेक टीम आइए, यश, इनके बगैर तो हम दिखेंगे ही नहीं। अच्छा, सब लोग आएंगे ना एक साथ।
मयूर शादियां भी इवेंट प्लान करता है, अगर किसी को शादियां करानी है तो भी करा
सर को बुके दीजिए। बेटा बुके लाइए, बैग लाइए सबके लिए एक एक। नाम किशोर जी का बहुत बहुत धन्यवाद। इन्होंने जो ऑडियो विजुअल नीचे आ गया है। थैंक यू सर। आ जाइए बेटा, आपका नाम? फोटो बैग के साथ लो ना। अच्छा सिंगल, हाँ आ जाओ। थैंक यू। फोटो लो। थैंक यू। इनका नाम क्या, बच्चे का? कहाँ गए? हाँ फोटो। आप आ जाइए बेटा, आ जाओ ना। ले लो फोटो, लो भैया। थैंक यू। आइए, आपका नाम बेटा है? शिवांश जी का बहुत बहुत धन्यवाद, जिन्होंने ऑडियो विजुअल पूरा मैनेज किया। 2 दिन, तालियां हो जाएं। थैंक यू बेटा। आपका भैया आ जाइए। है और सबसे ज्यादा जहाँ पे हम खड़े हैं, जहाँ पे प्रोग्राम हुआ, गुलजार होटल वालों का, मैनेजमेंट वालों का बहुत बहुत धन्यवाद। ट्राइम टीम नहीं आई क्या अभी तक? आपका शुभ नाम? गोपाल जी का बहुत बहुत धन्यवाद ऑडियो विजुअल के लिए। आपका शाम सर? उमंग अभी आएगा ना, वो उसको यहाँ बुला लेंगे तो फिर सब छूट जाएगा। कैमरा पर्सन बोल रही मैडम आखिरी में बुलाएंगे ना, सब छूट जाएंगे फोटो। वो है ना बच्चा, वो खींचेगा उसका साथी। आइए सर, आपका शुभ नाम? महेश जी का बहुत बहुत धन्यवाद और तालियों से स्वागत करिए इनका, क्योंकि इनके बगैर आपको फोटो नहीं मिलेंगे फिर। थैंक यू
सर। कल चाहिए गूगल ड्राइव में
कल मैं डांस कर रहा था, मैंने एक गाने में हार्ट का नाम आया तो मैंने ऐसे बनाया था,
शानदार फोटो थी
और इन्होंने मेरी दोनों आंखों के बीच से हार्ट की फोटो ले ली उतनी देर में। तो लिंक अभी चाहिए भैया, फोटोज की लिंक, और ये मोबाइल में भी डालना है तुरंत, इसमें पेन ड्राइव में। आ जाओ, वीडियो वाले कहाँ गए भैया? उनको बुलाओ। महेश गुलजार होटल से आइए। नहीं दे सकते। आपका शुभ नाम? सौरभ जी को बहुत बहुत धन्यवाद, थैंक यू। हो गए सब? ट्राइम टीम हो गई। अब कौन? उसका हो गया, ये बचा है। आइए बेटा, ये सपोर्टिंग एक्टर आ गए हैं कैमरामैन के। क्या शुभ नाम है आपका? सुमित जी को बहुत बहुत धन्यवाद। जब तक महेश बिजी था तो सुमित ने काम संभाला। मुस्कान हो गया आपका बेटा? नहीं आए, सबका हो गया। दीपेश कौन है? रह गए थे क्या तुम लोग? ऑल डन। चलो आ जाओ, सब एक साथ फोटो लेते हैं। आ जाओ फराज, मोहसिन, आ जाओ, सब लोग आ जाओ। योगेश, विज्ञप्ति पढ़वा के जाना। तुम कल कितनी गंदी बनाई, बंदूक नहीं छापा उसको। सब लोग आ जाइए। यहाँ आ जाएगा महेश की नीचे आए। आओ ना, क्या हो गया? कौन बच गया? आशीष आ जाओ। अच्छा मोबाइल दे रहा था अपना। यहाँ आ जा नीचे, इधर आ नीचे, बीच में मस्त फोटो आएगी। नीचे बैठ जा, नीचे बैठ जा बोल रहा हूँ, कटेगा नहीं। हाँ ऐसा। यहाँ साइड से ले, उसको दिक्कत हो रही है। चेयर पे खड़े हो जाओ। आना जिज्ञासा, थक गई। अभी रुको, बैठो वहीं वैसे ही के वैसे ही रहो। ए आशीष, अबे देख उधर जल रहा है वो दिया। अभी हाँ ऑल्टरनेट हो जाओ। अब 3 चीयर्स फॉर NDID 2026। हिप 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 हिप। आप लोगों को कुछ कहना है तो माइक पे कह सकते हैं किसी को। है? हाँ बम्बू लग गई है। सबको सोना है तो चालू करवा जल्दी। म्यूजिक लगा दो थोड़ा सा।